دكتور ضلال الحربي.
السلام عليكم ورحمة الله وبركاته. بسم الله والصلاة والسلام على رسول الله. في بداية هذا السيشن دعوني أن أرحب بالجميع في اليوم الثاني من المؤتمر العلمي لطب نمط الحياة، وفي نفس الوقت نهنئ القائمين على هذا المؤتمر في النجاح المتميز الذي حققه في هذا الافتتاح يوم أمس. مثل ما تفضل الدكتور صالح الراجحي في كلمته أمس، طب نمط الحياة الآن يحظى بأمير نمط الحياة في تبني وزارة الصحة، في تبني الرؤية. فهنيئا للقائمين على هذا المؤتمر في مثل هذه التميز في تطبيق الرؤية التي تساهم في رفع الوعي الصحي لدى المجتمع ككل. Welcome to all for the first session for the second day, and I just spent 1 minute to express my gratitude to the scientific committee for the amazing the lectures yesterday have been done, and also today we have a lot of panel discussion and also presentation, and also we have other commitment for the presentation for the community, for the public, and they start as a concurrent session today as some of our colleagues going now to all the countryside to give a talk for the public. So for the first session today, for the first talk today, we will gonna have Dr. Rasha Al-Raddadi. She will gonna talk about the exercise and type 1 diabetes. Dr. Rasha Al-Raddadi, certified by the American Board Pediatrics, and she worked as an assistant professor at Taiba University, and also she awarded as a master's degree of clinical research from the United States. So welcome, Dr. Rasha.
السلام عليكم ورحمة الله وبركاته. Thank you for this nice introduction. I would like to thank the committee and the organizer for this invitation. I'm so excited to be here with you today. Is my voice clear? Okay. I'm so excited to be with you here today in this amazing and beautiful city talking about type 1 diabetes and exercise. So first of all, why should we care about exercise in type 1 diabetic patients? If we think about obesity, WHO declared that obesity is a pandemic, and type 1 diabetic patient is part of our populations. So obesity is as common in children and adolescents with type 1 diabetes as those without diabetes. So why should we care about obesity in type 1 diabetic patients? If we think about it, both obesity and type 1 diabetes increase the risk of cardiovascular factors. So all diabetic care providers should monitor weight frequently and should encourage lifestyle interventions. That include healthy diet and exercise. Sorry, I think it's... Okay, so as what we said, obesity is common in diabetic patient as those without having diabetes. So that's why as healthcare provider, we should care about monitoring the weight status all the time And we should think about healthy diet and lifestyle interventions, that including regular exercise and diet. So it's very crucial to understand the physiology of exercise. So first of all, if we think about non-diabetic patient as a baseline, what happens inside to their body when they do exercise? So that during exercise, the blood flow increased to the muscle, increased to the non-insulin mediated glucose transport. So that will increase the glucose uptake inside the cells, and that will decrease the glucose inside the blood vessel. So they have normal beta cell. That will lead to decrease the insulin and increase the counter-regulatory hormones. So the end result of this will be normoglycemia. And compared to the well-controlled, healthy diabetic patient who takes his insulin on time, what happened during exercise? The same thing happened. Increase blood flow to the muscle, increase non-insulin mediated glucose transport. That will lead to exactly the same thing. The glucose uptake inside the cell will increase, and glucose inside the blood vessel will decrease. Because they have insulin on board, they have insulin there, they take insulin. So if you check the blood insulin, you'll see it's normal or high. And the beta cell is not functioning. So the increase in the blood and in the insulin, that's because they take their insulin, not from the beta cell, of course. And that will inhibit the counter-regulatory hormones. The counter-regulatory hormones, as we all know, that increase the blood glucose, which is critical here to avoid hypoglycemia. So it's not happening here in our patients. So the end result is hypoglycemia. So this is physiology is very crucial. It's very important to understand this process so we can counsel our patients. During the next following slides, I will be talking about different types of exercise and the recommendation regarding the intensity, durations, and how often should be doing this. First of all, the aerobic exercise. It's like cycling, running, or swimming. So what is aerobic exercise? The definition of it is a prolonged rhythmic activity using large group of muscles. It can be done as HIIT or continuously. So the recommendation regarding the duration, it can be done 3 to 7 days per week, which is at least 150 minutes per week. And it's not mild, it should be done like a moderate to vigorous activity to see the effects. The second type of the exercise, the most common one is resistant. And it's recommended to be done as moderate or vigorous activity. And to the preferred time or frequency 3 times per week, but with the minimum 2 non-consecutive days per week. And it should be done at least for 8 to 10 exercises with completion of at least one set of 10 to 15 repetitions to near fatigues per every set of exercise. The third type of exercise is stretching, which can be done either static, dynamic, or other types like yoga. Or in older adults, we can do as practicing on standing on one leg or exercising using balance equipment and lower body and core resistant exercise. We call it overall as balance exercise. So the recommendation to be done as 2 to 3 days per week. And with the duration to either to hold static or to do the dynamic one as stretching for 10 to 30 seconds with 2 to 4 repetitions for each exercise. And here we talk or discuss about the pros and cons of exercise. So what are the benefits of exercise in patients who has type 1 diabetes mainly? It's very important because it increases the insulin sensitivity, and also it improves the social interactions and also the self-esteem. It helps with weight management, which is now has become as a problem. It's because, as we said, type 1 diabetes patient is part of our population, and obesity is a pandemic. So weight management that should be addressed in each clinical visits. And also creating of physical fitness, strength building, and healthy habit for adulthood. But unfortunately, there is downside of exercise in patients who have type 1 diabetes that we should be talking and counseling in every visit, like hypoglycemia and hyperglycemia. Here is I talk yoga as an example to understand how the theoretical background behind how the exercise decrease the risk of diabetes and the complication of diabetes. Sorry, I'm trying to figure out this slide. Okay, this is what I was talking about. Here I'm trying to explain, or I talk yoga as an example of how exercise decrease the risk of diabetes and its complication. So there are a lot of theoretical backgrounds behind this. So if we look at the beginning in pathway 1, so doing yoga that decrease the reactivity or the activation of adrenal system, and that will decrease the HPA axis. So as a result of that, the blood pressure will decrease and the heart rate will decrease, and that improves the sleep and mood. And with that, the vagal stimulation increase and the parasympathetic function improve, and that decrease the perceived stress. And also the other way, they said it decreased the selective activation of the brain structure and the structure. I think there's something with the slide, it's moving by itself. So. Sorry, I think there was just technical issue, so I will try to be faster. We have only 5 minutes left, but this is how the theoretical background behind yoga and how it decreased the risk of diabetes. So just to summarize, it decreased the activation of the sympathetic and sympathoadrenal axis, stimulate the vagal stimulation, and it increased the activation of specific brain structure and neurochemical system that will lead positive changes in the brain structure. So the overall changes will be improved in sleep and mood, and decrease the perceived stress, increase the physical function, and that altogether will improve the insulin resistance, that will decrease, and decrease the risk of dyslipidemia and obesity. All of these will improve the metabolic profile. Here, the different type of exercise that we talked about earlier, which is the aerobic and anaerobic, and in the middle, which is the mixed. So if we look at glucose trend, if we are doing the aerobic, mainly most of the time it will be the same. But there are a lot of variables that play inside this, which is like we'll talk about later, but mainly the intensity and duration of exercise, the insulin to glucagon ratio and fitness, and the insulin or the initial glucose concentration at the beginning. But if we look at the anaerobic exercise, most of the time it will cause hyperglycemia. And the same variables play a role with it, which make case-by-case differences, but mainly it will cause hyperglycemia. How about if we do combined, which is the best? So that will cause more stability in blood glucose. So here is the factors that affect glucose response to exercise, mainly the duration and intensity. So how we apply that? Like if we take kids as an example, so the spontaneous play, like in the playground or that will cause like repeated bouts of intensive activity that interrupted with rest or with low to moderate intensity exercise. So this type of activity will decrease the blood glucose level less than the continuous to moderate intensity exercise. So in compared to so type of activity also play a role. So the anaerobic activity, as what we said, it causes like mainly hyperglycemia on the same time, but also that depends on the duration. So it's most of the time it's lasts like 30 to 60 minutes, it's transit, and hypoglycemia, it doesn't happen on the same time, but it can follow the exercise, so later on. In compared with the aerobic activity, that will cause lower blood glucose both within 20 to 60 minutes of exercise and after completing the exercise.
2 minutes, please.
Okay, I'll try to wrap everything up. And also metabolic control play a role in that. So, for example, if we have patients who have like pre-existent hyperglycemia, that means we have inadequate insulin level at the beginning. That will cause exaggerated effect of counter-regulatory hormones and will cause ketosis. So patients who have poor like control high glucose level and hyperglycemia with A1C more than 7.5, so that will cause like decrease aerobic capacity and a lot of fatigues, and they can't like tolerate exercise very well as those with have normal hemoglobin A1C. Type and duration of insulin also important. So if we look at the type of insulin, like regular insulin, that will cause hypoglycemia within 2 to 3 hours after injections. Compared to the rapid-acting insulin, that will cause hypoglycemia between 40 to 90 minutes of injections. Unfortunately, we don't have a lot of data about the effect of basal insulin in exercise. So the training level, that means that adolescent who does like exercise on occasion, not very often, they have difficulty in managing their insulin. So if they do like exercise, the insulin sensitivity improve, then it gradually will decrease over time. And after 5 days, it will become at the level of non-trained level. So if you want the insulin sensitivity to be better, you have to do regular exercise. But what happens if you have hypoglycemia? So if you have hypoglycemia, it's better to do exercise every other day rather than doing few days in a row because of the insulin sensitivity. This is a study was done by Dr. Jones, and they looked at adolescents with type 1 diabetes, and they have like increased biphasic manner of hypoglycemia, which is very critical and important thing to understand. So if we want to take home message about this lecture today, it's very important to understand how exercise affects blood glucose level. Because what happens, sometimes family complain that the kids have hypoglycemia at night. So one of the important questions that you need to ask, what happened during the day? So you need to take detailed history about like what happened since the early time in the morning, diet, exercise, activity. So sometimes kids do exercise at afternoon, like in the school. And so if you take detailed history, you will figure it out. So you will know that's hypoglycemia because of the exercise that they have done during afternoon. Because it's biphasic effect, it will cause hypoglycemia at the same time, then after that, maybe in 12 hours. So figuring out, like changing the time of exercise will be the solution for these patients. Okay. Here, the degree of stress and competition involved in the activity also change the blood glucose level with exercise. So the competition and stress will cause adrenal response, and that will cause like hyperglycemia, or if the kids have hypoglycemia, it will cause normal glucose level. So it's depends on the case actually. So to avoid having hypoglycemia regarding the times, so morning activity before the insulin administration will not result in hypoglycemia. So this is good to understand in terms of counseling your patients. And also the group of muscles. So using the activity that has like the exercise that using a large group of muscles will cause less hypoglycemia than the activity that using a small group of muscles. And familiarity with the sports. So if the kid like do like sport very often and with the regular conditioning, so they have less hypoglycemia than the one who does exercise infrequent. Also, the absorption of insulin. So if you are doing cycling, so it's better to inject the insulin in the arms or abdomen and avoid the legs to have more stable blood glucose level and or expected blood glucose level. So what happens if you do it in the legs? So it's unpredictable. You don't know, it depends on the activity. And also the temperature. It's important to understand the high temperature will increase the insulin absorption compared to the low temperature, which is critical to know for long-distance swimmer. So you need to address the comorbid condition and diabetes complication. It's not contraindicated per se, but you need to know and to outweigh the risk and benefit. Because always exercise outweighs the risk. But you need to take it case by case. Okay. Here just the last things. Always make sure that you maximize the safety with your exercise with your patients. So always make sure the patient check the blood glucose before, during, and after exercise. Make sure that they have access to carbohydrate. And thank you all for listening, and thank you for your time.
Yeah, thank you so much, Dr. Rasha. Yeah, thank you so much, Dr. Rasha. And we have a 9 presentation today for this session. So we will gonna have the panel discussion at the end of this session. So the next speaker will be Prof. Khalid Rasadi. He's the director of the Medical Research Center, professor of biochemistry at Sultan Qaboos University. Welcome to Saudi Arabia. And consultant lipidologist at Sultan Qaboos University Hospital.
السلام عليكم ورحمة الله وبركاته. أولا طبعا هذه طبعا أول زيارة لحائل، فأنا تقريبا ما شاء الله أعجبت طبعا بكل اللي شفته أولا طبعا أشكر الدكتور صالح الراجحي على الدعوة الكريمة، وطبعا أشكر الدكتورة سامية المحمادي اللي كان في سلطنة عمان في مؤتمر وونكا وعزمتني على هذا المؤتمر. يعني صراحة كانت فرصة سعيدة جدا جدا. يعني طبعا أحس أن هذا المؤتمر من المؤتمرات اللي هي طبعا الفريدة من نوعها، يعني خاصة في المنطقة وفي حتى في الشرق الأوسط. فنتمنى إن شاء الله هذه التجربة بإذن الله ستنقل إلى بقية دول الخليج إن شاء الله، إلى المنطقة بكاملها إن شاء الله، للاستفادة طبعا من الناحية العلمية وحتى الناحية المجتمعية. يعني اللي شفناه أمس صراحة شيء مبهر، ونشكر طبعا مديرية الخدمات الصحية على كل هذا التنظيم. اليوم إن شاء الله أنا بكلمكم عن الفاتس and health implications. I think we have the same. It doesn't forward بطارية أو شيء، ياخذ وقت شوية لكن ياخذ وقت. وين توجيه؟ ياخذ وقت. يعني أنا ضغطت مرتين. تمام. So this is my disclosure slides. I don't have any disclosure for this talk. So we have been seeing from different evidences, especially when it comes طبعا to cardiovascular disease and other non-cardiovascular disease, that when you look at high intake of saturated fat, trans fats, this is خاصة trans fat, this is really the main cause, not only in events, in diseases, but even in mortality. So on the, if you can see on the y-axis, this is change in total mortality, الوفيات. فالوفيات تزيد طبعا بالincrease in the amount of the intake of trans fat اللي هي الدهون المتحولة. So this has been proven by evidence with no doubt. So most of the studies are really consistent that trans fat is really related not only to diseases and events, but even to mortality as well. So this is very important to keep in mind. And trans fat, when we talk about طبعا اللي هي الأطعمة المصنعة, processed or ultra processed food, that has been shown in the previous speakers. Saturated fat also has been related to mortality, but the problem, the evidence there is not very consistent. So there is some controversies whether this is really related to saturated fat or others. But looking at monounsaturated fat, polyunsaturated fat, especially the omega-3, not the omega-6, but omega-3, has been also consistently shown by evidence that it really decreased the total mortality. And most of this evidence really comes from cardiovascular outcomes. When it comes to cancer, mental health, and others, the evidence there is really not very consistent. So why high fat diet? I think that the speakers from yesterday, she made it very clear that really this is all related to inflammation, low grade of inflammation. So high fat diet will lead to low grade, what we call systemic inflammation, and then it will lead to all these diseases: insulin resistant type 2, cardiovascular diseases, intestinal diseases, mental and osteoporosis, kidney diseases, and even cancer. So all related to inflammation. So I think the pathophysiology here, why this high fat related to disease, is really because of inflammation. So what do we know by inflammation? So when we look at lipoprotein disorders, especially those patients with small dense LDL cholesterol or lipoproteins with high triglyceride contents, and this occurs in patients with diabetes, insulin resistance, and patients with obesity because, again, of high calories intake. These free fatty acids from lipolysis will go to the liver. Liver have to get rid of these excess fatty acids. So how does it get rid of it? Either by transporting it as VLDL cholesterol or beta oxidation. So transporting it as VLDL cholesterol will produce this small LDL cholesterol, and these can penetrate easily to the subendothelial cell, and then activate all these macrophages, foam cell production, interleukins, cytokines, inflammation, and these cycles continue to form this atherosclerosis, and then eventually it will lead to either myocardial infarction, strokes, peripheral artery disease, and so on. So there is relation between, again, the lipids that you have in your blood diet and also inflammation in the subendothelial, very clearly. So how about the brain? When we come to the brain, what is the pathophysiology there? The same principle. So again, free fatty acids, which is again coming from the diet, what it will cause the imbalance in these antioxidant protection and the oxidant production, which is the reactive oxygen species, reactive nitrogen species, because we know that most of these fatty acids, when they go to the mitochondria, they are oxidized. So when they oxidize, they produce these free radicals. These free radicals can stimulate inflammation, cytokines, TNF, interleukin 1 or 6. And this one, what they will cause, they will damage your DNA. So your protective mechanism will be impaired. What they will do also, this because the brain is very, very saturated in unsaturated lipids, because of the brain cell and neurotransmitters and all this network. So again, they will produce damage there. This can lead to, again, so many cognitive function problems in the memory, Alzheimer's disease, dementia, and even some like stress and anxiety as well, and depression. So very, very related again to what? To inflammation. So you have to remember this is the underlying pathophysiology. So this is another example which is really, really good. So we know that good quality of food, healthy fats, high fiber foods, fruits, vegetable, limited fast food will produce good mental health. Okay, so better mood, less stress, lower risk of illness, and cognitive function. Could the other way be true? Yes. We know people who have mentally dysfunction, depressed, they have a lot of anxiety. They tend also to eat unhealthy food. So this also can lead, to systemic inflammation. So both directions are really true. So whatever produce, again, we need to think about, unhealthy diet is the main really cause of this problem, and we should stop it there. Again, when it comes to cardiovascular disease, diet is really an important factor for these. Solid fats, strong. Refined sugar, strong. It can increase the LDL cholesterol moderately, but the evidence is less than the solid fat. When it comes to fish, its effect on the LDL cholesterol, the blood, we are talking here about the blood LDL cholesterol, is really small. So there's no relation between eating fish and raising the LDL cholesterol, and the evidence there is strong. And then when we come to this all polyunsaturated food, whether omega-3 or omega-6, they are strong in really reducing your LDL cholesterol. So if you want to reduce your LDL cholesterol in blood to prevent all those events and diseases, then you should eat these omega-3s and some of the omega-6 food. How about the effect of carbohydrates? We know that eating less carbohydrate can reduce the LDL cholesterol, can also reduce the HDL cholesterol, but the most significant effect of high carbs diet is really on triglyceride. This is why we see diabetic patients with really very high triglyceride level. So if you want to advise, again, your patients with high triglyceride in diabetic, they have really to, cut on their carbohydrates. And the other thing which is really challenging for us, and this is, we see it in the prospective studies, why, when we do studies, on fat intake, there is a lot of variation or inconsistency in the study. This is why, not all, even the saturated fatty acid, behave the same effect on the LDL cholesterol. So some of the fatty acid, like the lauric acid, it have high significant effect on the LDL cholesterol. But if you look at stearic acid, saturated fatty acid, it have a decreased effect on the LDL cholesterol. So our diet is really very complex. We cannot differentiate all these fatty acid in your food. So then if you come and correlate this food or fat intake and the type on the effect on LDL cholesterol, then it will become more complex, and the interpretation even more complicated. So we have really to make sure when you assess the diet, you assess it correctly. How about LDL cholesterol? Is there any relation between dietary cholesterol, the pure cholesterol that you take in your diet, and the level of blood cholesterol? No relation. So those previous guidelines, where they said you have to restrict your dietary cholesterol to reduce the LDL cholesterol, now most of these guidelines have reversed their recommendation. So you don't need really to reduce so it's mainly what? It's mainly the calories, saturated fat, and refined sugar that can really affect the blood cholesterol rather than purely the dietary cholesterol. So when we come to the human data on the relation of fat type and diseases, again, there is a lot of controversy. Why? Again, because of the nature of the food, it's very complex. The design of the study, sample size, types of fat, whether saturated, polyunsaturated, and also bias. Most of this questionnaire, they will ask the subject what you were eating, 1 month or 3 months or few days. So who remember, what he had eaten in the morning today? So sometimes, this questionnaire will create bias. So we have really to be careful again from interpreting the relation when especially they are inconsistent. But in general, let me show you some quick. So this is from Korean study, association between dietary and dietary pattern and depression. So they had classified the different foods into different items: healthy food and unhealthy food. And then what they did, so they look at the healthy food and they also quartile them according to the amount, the calories. So quarter 4 mean high calories, quarter 1 mean low calories, and they looked at healthy food and unhealthy food. Look, let us concentrate on unhealthy food. So unhealthy food, if you look at the association, especially at quartile 4, where there's high amount of this intake of unhealthy food, there is almost an increase of 39% or almost 65% for the risk of depression. So if you start eating unhealthy food, and this is model 1 and model 2, this is all corrected for what? For your race, for the male and female gender, for your weight, for diabetes. Everything has been corrected, adjusted, So this is purely what? The effect of what? The unhealthy diet. So unhealthy diet and a lot of calories from those unhealthy diet, 65%. Very, very high, for depression effect.
2 minutes.
Oh, wow. It's okay, inshallah. And then I think I will jump here. How about unprocessed food or ultra-processed food? This we have been talking yesterday about it. So Q4 is the ultra-processed food. Look at the ultra-processed food, 40% effect again on depression. And if we compare male to female, it seems that female are more affected with, depression when they eat ultra-processed food. So in female, it was 51% compared to male, 34%, and it was more significant in female. So female or ladies, you have really to be careful more about this ultra-processed food. How about cancer? Cancer, I think there are so many inconsistency in the studies, but most of the studies show that high intake of saturated fat is mainly related to breast cancer. So breast cancer and association with saturated fat is the most stronger compared to the other type of cancer, and then replacing this saturated with polyunsaturated will make this relation less. So I will not go into details again because of the time. How about the cardiovascular disease? We know from the Mediterranean study, and we had seen it very well, that if you compare Mediterranean to controlled diet, the risk for, again, total mortality and cardiovascular event is reduced significantly in those patients eating Mediterranean diet. How about the saturated fatty acid? I know there is a lot of inconsistency, and even in the PURE study, which the Kingdom of Saudi Arabia was part of this PURE study in the 18 countries, where they looked at the effect of diet on different events. Unfortunately, they didn't show any effect of total fat and cardiovascular mortality or event, but they have shown it for carbohydrates. But again, like I told you, we have to be really careful with explaining, interpreting some of these results, again, because of the bias in recall and other complex of the nutrition. But what I want to show you here, this is really very important study, where they looked at the effect of replacing saturated fat with omega-3 or polyunsaturated fat. So if you replace saturated fatty acid with polyunsaturated fatty acid, what will happen to the coronary cardiovascular event? Reduced by 13%. What will happen to coronary death? It will reduce by 36%. So maybe it is the opposite. So we shouldn't look really at how much you take of saturated, but how much you replace of saturated to polyunsaturated. And I'm sure Dr. Saleh was, even in the community yesterday, was emphasizing on that. Please replace saturated, put more proteins, put more omega-3 on that to reduce this effect. And this has been with evidence. Now we see it with really evidence. Again, with carbohydrate, when we replace, then this will shift. Trans fat, I don't really need to talk about that. So this is my last slide. So what is the evidence? This is the home take message. So now we are shifting from guidelines which will tell you that, don't eat cholesterol in the diet, don't eat saturated fat, to more, what we call personalized type of prescription. So what you have to do, that still you can eat whole fat dairy, still you can eat meat, but try to be fresh and processed. Dark chocolate is fine, okay? So this complex matrix with high saturated fatty acid, nutrient and non-nutrient, plus the protein and the probiotic and all those phospholipid, there's no strong really relation to cardiovascular disease. So this eating all these type, then it will become more balanced, and it will prevent definitely cardiovascular and diabetes. So this is the new recommendation. The new recommendation try to be far from refined carbohydrates, less maybe saturated fat, replace it with omega-3 polyunsaturated, try to avoid this highly processed or ultra-processed food. This will really help decreasing all your risk for events. With that, I will close, and thank you very much.
Thank you so much, Prof. Khalid. Even though the time is out, but it's a very interesting topic, and I think the lifestyle medicine change our conference style. If you have any questions, you can reach Prof. Khalid. He will be with us these 3 days, and you can discuss with him about this topic. So the next, and also we will have a panel discussion at the end of this session. The next speaker, Dr. Faiza Al-Ghanami. She's a consultant in clinical immunology and allergy since 2012, and she works at King Fahd General Hospital in Jeddah. Welcome, Dr. Faiza.
Assalamu alaikum. Thank you very much for the invitation. I really appreciate the invitation by the organizer and committee. I'm very glad to be part of this magnificent symposium in this magnificent city of Hail. Today, I'm going to talk about food allergy and intolerance, and I possibly gonna rush a little bit because of the time, shortage of time. So the topics I'm trying to today is the type of food hypersensitivity and food-related anaphylaxis, as well as allergenic food and management of food allergy, including lifestyle modification. And we'll also look at the allergen-free meal preparation advice for food and business and individual. So food hypersensitivity basically is an adverse reaction to food, collectively referred as any troublesome. So the food allergy refers to adverse health effect arising from specific immune response that is repeatedly occur in exposure to specific food allergen. However, the food intolerance is a non-immune response that happens as adverse effect due to ingestion of metabolic substance, toxins, or pharmacologically active components. So in total, we can divide them as you can see here. The food allergy consists of IgE-mediated form, which is the one that we will focus today on, as it is a health hazard, and also it has also to do with lifestyle modification. The commonest form is the oral allergy syndromes as well, and the extreme form is the anaphylaxis. There's also another form of food allergy in form of mixed IgE, non-IgE mediated, or non-IgE mediated, an example of which is the atopic dermatitis, eosinophilic esophagitis, as well as the food protein-induced syndromes and celiac disease. Food intolerance, on the other hand, is either due to an enzymatic deficiency like lactose intolerance, lactose deficiency, fructose deficiency, that with the resultants of lactose intolerance, or due to a pharmacological effect of the food content like tyramine or histamine. Sometimes also the intolerance can happen due to some toxins like comorbid toxicity. Okay, food sensitivity. We focus on the immune or the immune mediated because it's fatal. Looking at the pathophysiology of the IgE-mediated, which results in food-related anaphylaxis, for example here, if the patient is allergic to peanut, he needed a sensitization stage, in which that, upon the ingestion of peanut, for example here, first exposure to the allergen in this patient, for example, in this slide, for example, the allergenic food will be processed by APC, the cell there, and it presented the allergen into a CD4 helper T cell, which mediate Th2 cytokine profile, which induce the B cell to produce antigen-specific IgE. And on second exposure, so the patient basically Those produce specific antigen or allergen-specific IgE will bound to the Fc receptors on the mast cell, and on second exposure, the allergens will attach, and the food allergen will attach into these specific receptor, cause cross-reacting of these mast cell receptors, and subsequent degranulation and histamine release. The main effective anaphylaxis are actually induced by the histamine, which is the main mediators, but there is also another mediators, including leukotrienes and cytokines. The main manifestation happen mainly in the skin symptoms as well as gut symptoms, but they are mild. The severe form, where the airway symptoms involved, with the shortness of breath, also with the circulatory symptoms, where patient will have hypotension and eventually anaphylaxis. Anaphylaxis, basically the severe form of, and it's a life-threatening systemic reaction. The most important thing to remember that it's a biphasic reaction. So patient may have like another episodes of anaphylactic reaction about 12 to 72 hours after the previous episodes. Okay, food anaphylaxis is considered to be a worldwide and health burden, and it's one of the most prevalent causes of anaphylaxis. And most of the study indicate that food-induced reaction occurred about up to 40% of anaphylaxis worldwide, and 8 of these anaphylaxis unfortunately happen in children. In the state, for example, they have found that 1 in 12 children have food allergy, and it costs the country about 24 billions. And 20 of these anaphylaxis happen in children, in school-age children, who are not previously diagnosed with food allergy. Fatality rates, however, is still high in patients in death as a result from food anaphylaxis, and up to 200 fatality per year in the state, compared to to others, like, for example, venom allergy, or also like latex allergy, for example. And it's basically come second to the anaphylaxis induced by drug allergy. In general, food anaphylaxis is on the rise. It's been documented in the analysis of national data between 1998 and 2018, where the hospital admission for food-induced anaphylaxis have been raised, and the significant rates have been noticed in young children aged from 2 to 10. Because the death related to food anaphylaxis is kind of like health issue, they looked at whether these anaphylaxis or death from these anaphylaxis is preventable or not. They studied, retrospectively analyzed death records of about 16 death records out of 24 in New York City and public hospital, and they looked at it between 2000 and 2008. They have actually found that 11 of the 16 patients whom their record been evaluated, they have found that about 70% of those patients' death were potentially preventable. In those group, they found that two individuals, they die in restaurants, but they don't have previous diagnosis. That's why they call it public health preventable. The medically preventable, those people or individuals who have a food allergy diagnosed already, but they don't have access to their EpiPen. They also found that 4 of those patients or individual, they medically diagnosed, and unfortunately they died in restaurant because of the food allergy. 9 individual of those patients were known to be allergic to implicated food they ingest, but none of them had epinephrine at the time of reaction, and actually before the arrival of medical personnel, and except one of them, and at that time he doesn't have it in hand. 5 deaths of the 16 were not preventable at all, because 4 of those patients were actually allergic but not diagnosed before, and they died at home. And one of those patients, he's already a child who's already diagnosed with food allergy, and they already gave him 1 shot of epinephrine, but unfortunately they couldn't save him. Prevalence of food allergy is actually quite high, up to 10%. In Saudi Arabia, there's no national data because most of the studies being conducted on special groups like children or students and so on and so forth. Allergenic foods, there are mainly 8 common foods, including milk, eggs, peanut, tree peanuts, wheat, fish, and shellfish, and soy. Most of the children, like by age of 5, they grow out of the milk, egg, and wheat and soy, but they couldn't shed their allergies for seafood and peanut or tree peanut. The incident in adult, however, it's not actually, there's no clear data, but they have found that it's mainly common in their 30s. I need to pass some of the slides because of the time. So it's interesting to highlight that there is something called FADIA, which is a food-dependent exercise-induced anaphylaxis. In those patients, they only develop anaphylaxis if they ingest certain food 2 to 4 hours before the exercise or 1 hour after the exercise. So they don't develop anaphylaxis unless they eat that food along with the exercise. On the other hand, we have a very common form of food allergy, which is oral allergy syndrome, which is a local allergic reaction due to ingestion of certain raw fresh fruits, and due to the similarity between the allergenic proteins in those raw fresh fruits and vegetable with the pollen allergy. So those patients tend to have sort of like tingling sensation when they ingest that kind of fresh fruits, especially during the season where they are allergic to that aeroallergens. So it's important to shed some light on the treatment, medical treatment, because that's also part of the public awareness that we know that the treatment for food allergy, there are either 2 forms, either the acute treatment, which is epinephrine, or a long-term treatment, which is immunotherapy. I actually mentioned the epinephrine because the awareness of having epinephrine is really, really important and has a major role on preventing death. So management of food intolerance, on the other hand, beside the medical management, also there is a dietary management where those patients with specific intolerances, they should have like a gluten-free diet or a 6-food elimination diet, is like in atopic dermatitis, or a low food map diet or low histamine diet, and also they can have some supplement like enzymes or probiotics. So as we're talking about lifestyle management, so in food allergy, we have an important role in which that we have to have increase the awareness of strict avoidance of the offending foods. Patient and their family should be educated to take care when obtaining foods from restaurants. They should also learn about the avoidance of cross-contamination. In patients with FADIA, we also ask them to avoid exercise after eating offending food, like 2 to 4 hours after the ingestion of the food. They have to avoid exercise. And also they have to carry their EpiPen with them during exercise. Patient with OS, we advise them to eat those fresh fruits or vegetables, but in cooked form or in can, because the heat or preservation sometimes destroy the antigenic the allergens. If we're looking at the allergen management in food service and food industry, we know that the food allergy is currently documented as food safety issue. As food safety issue. Therefore, the government and also other health agencies, they have to. So the supervision of food allergen is a joint responsibility between food manufacturer and government agencies and consumers. Therefore, many international and national guidelines recognize the importance of allergen management and implement a requirement to be met by food manufacturer, including food labeling.
2 minutes.
Okay. So, for example, in the EU, they listed about like 14 food allergens, and they have to clear and state on any food packs being used in the food industry, whether in restaurants, whether in food manufacturing, or even at individual consumption. In the state, they stated about 8 food allergens, and Saudi FDA, however, stated 12 allergenic foods. So it's important to advise the staff training in food business and customers as well, that they need to learn about the importance of offering accurate information on the ingredients of the food they are serving. Also, when preparing food, they have to display the food on the food menu exactly the allergenic food. And in case of food contaminating with the product, they may cause intolerance. Then the customer has to be also warned. And during food handling, extra care should be practiced by staff to avoid contaminating other food with allergenic food. Also, this implicates that they do have, they should allocate a specific working place to prepare food for allergenic, to avoid this allergy contamination. They have to clean, sanitize all the equipment and service used to avoid the contact with the product, and also if they have any ingredient information copy, they have to actually keep on the side of any food that has been removed from their original packing. Customer also has to be advised if they are allergic to, they have any food allergy, they have to basically warned and avoid eating from open buffet, for example, or self-service area. Meal prep for families with patients with food allergy, they have to be aware of the which ingredient they have to avoid. They have to know how to read labels. Also, they have to have a designated place in their kitchen for utensils and for the product, allergen-free products such as gluten-free product. They have to learn about the substitution, for example, what to use. In case if they are having cow milk allergy, they can use soy rice or coconut milk. For example, wheat, they have to use gluten-free flour mix or rice flour. So this awareness is really important for those individuals. And when preparing allergy-free foods, they have to clean all the equipment, and they have to wash their hands between tasks. And also, when they prepare meal for allergic individual in the family, they have to do it first before the rest of the family. So take-home message is that the food allergy is a common and potentially fatal, and strict avoidance is the main treatment option. Epinephrine awareness, position awareness is really important to prevent death. Also, lifestyle management patient with food allergy and food intolerance, really important, and including the allergen avoidance, exercise modification, and caution with food preparation. They are very tremendously important to reduce the mortality in such patients and to improve their quality of life. Thank you very much.
Thank you so much. شكرا دكتورة. Thank you. So the next speaker, Dr. Sultana Al-Utaibi from the Al-Habib Hospital in Sweden. She's a dietitian, and she will gonna talk about the danger and refined and the ultra-refined foods on the health. So welcome, Dr. Sultana.
من 20 إلى 35.
Can we have a PowerPoint, please?
Assalamu alaikum wa rahmatullahi wa barakatuh. First of all, I would like to thank the organizing committee and Dr. Saleh for inviting me for this topic. I was planned actually to have my speech in 20 minutes, but as per the instruction, it will be only 15 minutes. So I will try to focus on the more important slides. I will speak about processed food and its classification and its implication or impact on health. Then we will have speak about policies to control and increase awareness about processed food and some small talk about food labeling system. Processed food, any food have any change from its natural state considered as processed food. This includes the addition of any ingredient. The most common classification of processed food is NOVA classification, up to date. As you see in the slide that the unprocessed food and minimally processed food is the food that unaltered or have only minimum change, and the aim for this is to preservation only. And no substances was added in the first step. The second one is food from step 1 go under manufacturing, and the aim for this step is only for preparing for seasoning and cooking and elements or product to use in the production. In the third one and fourth one, it's food from step 2 or group 2 added to group 1. And they use preservation method like canning and bottling. Mostly in this processed food, use 2 to 3 ingredients and it's ready to eat. And in ultra-processed food, it go beyond the step 3 to add more preservation, colors, flavors, and other. And it's also ready to eat. Mostly for the manufacturing, they use ultra-processed food for maximum profit and increase craving for the consumer, so they will eat more and more. I have to clarify something here. In the researches, if you will try to search, you will find there is no clear cut off between processed food and ultra-processed food. So if you'll ask nutritionists or dietitian, they try to ask them to classify food. Is it processed or ultra-processed? So they don't have clear decision on this, but you will find also in the research, every researcher, they will show up what kind of food they consider it as ultra-processed and what kind of food they consider it as only processed. There is good side of food processing, but also there is bad side of food processing. As you know, it has full of fat and sugar, poor nutritional value, quick digestion, artificial ingredient that might affect our health, and they have harmful chemical substances that might move from food packaging to the food itself. The salt, most of the salt intake that the people might have comes from food, not from come from processed food, not from natural food. And the imbalance between the sodium and potassium, as we see in the processed food, have implication in our health, and it will double the risk of heart disease and the death from any cause. Saturated fat, partially hydrogenated fat, which was mostly found in the processed food, used mostly from the manufacturer because it's can tolerate the heat without any breaking down. And for trans fat, we have global and national action regarding this to decrease, to avoid the harmful effect. Here is the global study on ultra-processed food consumption, as we see that the highest research conducted in Brazil and North America than in other countries. This study was searching the effect of ultra-processed food and processed food among children and adolescents in many countries. And as we see, the highest proportion of the intake was in UK and US and Australia, with the lowest proportion in Colombia, Brazil, and Mexico. And based on this study, they are saying there is urgent need for a strong action policy to address the growing unprocessed food globally. We know that there is effect of ultra-processed food in many health outcomes. The effect of ultra-processed food in obesity, as we know that the more ultra-processed food was consumed, the more refined carbohydrate was intake and with poor nutritional value. And they found that the higher maternal consumption of ultra-processed food during child-rearing period was associated with higher risk of overweight and obesity. And also the highest intake of ultra-processed food was linked to higher risk of obesity and abdominal obesity and percentage of body fat. Also, there is a study in British, they found there is a link between the consumption of ultra-processed food and 115 metabolic traits, including lower level of branched-chain amino acid, aromatic amino acid, and higher level of citrate, glutamine, and MOVA, which is monounsaturated fatty acid, which were also associated with greater fat accumulation. The link between ultra-processed food and diabetes also was shown that if the intake of ultra-processed food reached to 22% of the diet, they had higher risk of developing type 2 diabetes. Also, every 10% increase in ultra-processed food was associated with higher risk of type 2 diabetes by 15%. This study, based on 3 cohort study in US, and as you see that they conclude that every 10% increase in the total ultra-processed food was associated with 12% higher risk of type 2 diabetes. And you can see in the other side, the subgroup of food element that was linked with increase or decrease the risk. Ultra-processed food and cancer, as we know that, the most linked part of ultra-processed food or processed food with cancer is processed meat, which is high in nitrate, which is linked with cancer risk. Colorectal cancer is the second leading cause of death from cancer worldwide, and in Saudi, it's one of the top 3 cancer diagnosed in KSA. The link between the ultra-processed food and cancer, mostly because it's poor nutritional value, food additives, and potential elements that might move from food process, might be appearing during food preparation and heat. And also migration from food packaging to the food itself. The higher consumption of ultra-processed food linked with higher mortality rate of overall cancer. Also, every 10% increase in ultra-processed food was associated with more than 10% increased risk of overall and breast cancer. And as you see that every researcher, they are showing what type of food they consider as ultra-processed. Here also they found that the total ultra-processed food intake was linked with increased risk of colorectal cancer in men and women. In subgroup, they found that the meat and poultry, seafood-based, ready-to-eat food and sugar-sweetened beverages in men and ready-to-eat food mixed in women, it was associated with increased risk, while yogurt and dairy-based dessert was negatively associated with the risk among women. And you see the example also of ultra-processed food down. Mortality, the higher intake of ultra-processed food, the higher risk of mortality rate with different percentage. Also, it was linked with cardiovascular. And every extra additional intake of ultra-processed food, it increased the risk more. In this slide, they showed that even if they are following a healthy diet and eating ultra-processed food, it might have some kind of risk of cardiovascular disease. Ultra-processed food and mental disorder, poor nutrition in ultra-processed food, it will affect the severity of depression. And also for monosodium glutamate and artificial sweetener, it might be linked to the mental disorder. Also, processed food has emulsifier and antimicrobial agent that might alter the gut microbiome composition and function, which will increase the inflammatory response. Exposure to titanium dioxide, which is food additives, and this recently was banned worldwide and also banned by the Saudi FDA. This might cause the destruction of the dopamine neuron, and it has potential genotoxic and carcinogenic. Also, bisphenol A, it might disrupt the sensitive endocrine system. Also, it was linked with depression among graduate study. The proposed mechanism I mentioned before for food additives, as we know about monosodium glutamate and the link with multiple health outcomes. Chemicals like bisphenol and phthalate commonly used in plastic containers. Bisphenol A recently banned from many countries and replaced with bisphenol S, but unfortunately there are some researches showing that it might be absorbed orally much more than bisphenol A. Phthalate also, it might go through food packaging to our food and having some health implication. And the higher the consumption of ultra-processed food, the higher the exposure. Policies to support the consumption of healthy food, fiscal policies like adding taxes to the sugary drink, energy drink, junk food, and the researcher proposing that more than 20% taxation, it might have meaningful impact. Also, school food environment protection, like banning the junk food and sugary drinks.
3 minutes.
Marketing
Sorry.
restriction, restrict any marketing that targeting the children for the unhealthy food. Also encourage healthy food intake, like having subsidies, incentive for healthy food store. Front of this last 3 slides almost. Front of package warning label. It could be simple and mandatory and clear, like the one we see in down. It's clear for consumer to decide if this food is really high in this element or critical element. And if we have nutrient profiling model, we could help the regulator to decide which food is subjected for taxes and which food could be subjected for marketing restriction and should be banned from school. And the good example of the black warning, this one is related to Pan American Health Organization, which is, we can name it BAHO, and it's focused in the most critical nutrient that might affect the health, including sweeteners. This model was adopted by Chile, Mexico, Peru, and Uruguay, and proposed to be mandatory in Brazil and Canada. And as we see, the consumer don't need to have more knowledge to understand this warning label like what we can see here. So here down the criteria that they use to decide this is high in fat, high in sugar, high in saturated trans fat or sodium. And here, as we see usually, the most common labeling system, like endorsement system, summary system, that giving from A to E, or the health star system, which is giving points from half star to 5 star, and as we see usually, which is the color-coded system and the other. In conclusion, we should read the label very well. We should be familiar with ingredients. The higher the ingredient we have, the more processed food is this food. Also, we should try to eat more food at home. If we go to a restaurant, avoid deep fried food. And we need more research to understand the impact of food processing on health and identify the specific factors related to. And more researches should be conducted in our kingdom and even in Arab countries to link the effect of processed food to health, and also high need for policies that limit the proportion of ultra-processed food in our diet. Here are my references, and inshallah on time.
Shukran. Thank you, Dr. Sultan Artebi. Thank you so much for your interesting presentation. Yeah, thank you so much. The organizer of these sessions, Mona Shamri, and thank you so much for organizing this session, and she pushed me up to finish on time. And she provided me a list of the CV for the presenter. For the next speaker, I didn't receive any information about the presenter. They didn't give me any CV about him. So apologize if I cannot introduce the next speaker very well. The next speaker is core crown of the lifestyle medicine, the conference, Dr. Salih Al-Rajhi. So Dr. Salih Al-Rajhi, he worked in King Fahd Medical City as a consultant and very well known. I can't introduce him. And welcome Dr. Salih, and I can see all the presenters come to the stage. Start with thank you. Thank you, Dr. Salih, for organizing.
Thank you everybody for being here, and I'm very glad to see all of you this morning. And also last night was a very special night, and I think all of you experienced the same thing I experienced with the opening ceremony, and how the governor of Ha'il and all the dignitaries and all of you saw how things happen, and the things we're trying to do in taking science into the community, not just in lecture halls and also at work. This is a lifestyle medicine. I'm using a lot of pictures and photos to get some messages across. So it's not only talk. Sometimes a picture is worth maybe 1,000,000 words, not just 1,000 words. بتكلم بالعربي والإنجليزي, so I'll be mixing things up. طبعا I'll be talking from personal experience. I may mention some studies and stuff if I need to. An apple a day keeps the doctor away, which is you know. Okay. Target audience, clinicians with interest in food as medicine, physicians and dentists, registered nurses and nurse specialists. These are the people who are targeted with lifestyle medicine. Also physicians in training, registered dietitians, physical therapists, occupational therapists, pharmacists, other allied health professionals, certified health coaches, and clinicians in training. So this means everybody in the healthcare system who's taking care of patients should be doing lifestyle medicine practice in their own capacity based on training. Now, when I discovered I have high cholesterol, I could not take lipid-lowering agents, so the treatment was what? Food. So I had to take food for 20 years just to treat my own high lipids. And almonds was one of the treatments that I started taking on a daily basis with walnuts. And it did help a lot. Also adding garlic, salads, and etc., that did help. Now, learning objectives will describe the overall dietary pattern for disease prevention and management, apply lifestyle medicine nutrition guidelines, develop a nutritional prescription for your patients, specific. One of the colleagues yesterday talked about personalized medicine. I think lifestyle medicine is personalized medicine, but you talk about their nutrition, their exercise, their sleep, their relationships, their faith, their mindset, their mindfulness, if they have any difficulties in their marriage, difficulties at work, work stress, work burnout, etc. There is a lot of things that influence wellness and illness, so you need to discuss this with your patients. Now, I love color. I love colorful meals. They make you happy and you can enjoy things. But you discover most people eat the same thing again and again and again every day. You tell them, let's make changes. No, I cannot make changes. It's non-sustainable. It's not sustainable. It's emotionally not sustainable, but they could do it and they could be trained to do it. So don't be afraid of making change yourself to see the difference, and trying new things, new healthy things, you will see also the difference. Food is medicine. It's a key pillar of lifestyle medicine therapeutic interventions. Healthful eating prevents, treats, and reverses many chronic diseases. We see it in the clinic, and everybody who takes care of patients, and many of you do that on a daily basis, and you see this in your patients. Most clinicians do not receive nutritional education and food as medicine. Clinicians need knowledge of dietary plans that prevent, treat, and chronic disease. And we say prevention, proactive care, or preventive care, proactive care, and preemptive care. Very important in disease management. Lifestyle medicine is also population health management. Now, when we talk to the community, we talk to everybody, it's public health. We did a lot of public health yesterday. We're doing it today. We're doing it in the next 3 days, and we need to continue doing that. So everybody has a role. Nobody doesn't have a role. It doesn't matter where you are, you have a role. This is why we emphasize that training of lifestyle medicine should be from the bottom up. Everybody should be trained. Even leadership training. There is master degree for those who are interested in lifestyle medicine management. There is a master degree in lifestyle medicine and population health management with Duane University. This is not advertisement, but it's one of the best master's degrees that's available out there, and you could do it online too. And it's not expensive either. Pharmaceutical use in food as medicine, patient care, you could use them, it's okay. But the goal of lifestyle medicine to reduce the burden of pharmaceuticals, not increase it. So if you do proper management, you will see the number of medication decrease, not increase. Good stuff. Who ate this yesterday? I did. It's available. So there is multiple choices when you go to eat. There is on the right side, always right is good. Healthy food, salads, plant-based proteins, maybe some, smoked salmon and others. On the other side, there is junk food if you want to, but we do not encourage junk food. Now, you are what you eat, remember that. Also, your patients, they are what they eat. Now, where is the gap? The education is significant. Evidence shows significant impact of the right nutrition and chronic disease, and we see this on a lot of diseases. Dean Ornish and others showed the effective intensive lifestyle therapy even in cancer by doing epigenetic studies, not just regular studies, also epigenetic studies. And there's other studies showing the reversal of type 2 diabetes, obesity, hypertension, hyperlipidemia, and we see it in the clinics on a daily basis. Now, these healthy oils, olive oil, Saudi Arabia is one of the big producers of olive oil now, and it's considered one of the best in the world, so recommend it to your patients. Now, a clinical application of lifestyle medicine, food as medicine, there's a lot of things you could apply it to. Obesity is pandemic in our country, type 2 diabetes, heart disease, and even cancer. So we need to really push for this, even OBGYN disorders and psychological disorders, etc. One of the most common complaints I get in the clinic is, especially from young females, my hair is falling. I have brittle nails. My skin doesn't look good. It's not my health. I just want to look good. I don't care what I eat, what I do. I just want to look good. So we go back and find there is a lot of patients with malnutrition. Please look for and diagnose malnutrition. It's very rampant. It's very prevalent. Otherwise, you will give them this. If they don't eat well, this is what they will take on a daily basis. So I tell patients, either you will be living on pills and some food, or implement lifestyle principles in your life and interventions in your life, and you will eat real food and enjoy it at the same time. Comprehensive clinical application and management. Basically, this is a lot from the clinical application that we do. Now, lifestyle exam room should be really nice. It should not be a crammed room. So we need to have an overhaul of where we meet our patients. We need to change, the concept of clinics and hospitals to make it more friendly, more representative of what patients should find and use. Now, when you get your patients, this is a clinical practice. So the first thing you want to do, which is I see a lot of residents and sometimes physicians, consultants, the history present illness, you need to really dig deep into it. So you want to find out about why they're here, find out the hidden complaint, and also make sure you dig deep into their nutrition, with their eating, with their eating, do they eat breakfast, what time they eat, how much they eat, who they eat it with. You know, eating food with others is different than when you eat food by yourself. There is a big difference. And because the time is very valuable, everything affects everything. Don't think that something you do or eat or drink or smell or see doesn't affect your health. Your hormones, your heart rate, your blood vessel constriction and dilation is affected by everything you encounter on a daily basis. Even your faith, your iman, your mindset, your thoughts, your beliefs affect how your body functions. This is why lifestyle medicine is extremely important. Now, physical activity, life stressors, false pretenses. Some patients live on false pretenses. They think this is true, and when it's not true, either food or some practice. Even, I sleep 9 hours a day. We want you to sleep at night, not during the day. Day sleeping is not similar to night sleeping, so there's a big difference between the two. Mindset management, this is a big area of research, and it's amazing. So if you're interested how people think, you want to understand people, you want to change your patient, change yourself, your family, you need to study mindset management, which is اللي هو العقيدة والفكر مرة مهم جدا. Mindfulness in Arabic, الإحسان بالعربي is very comprehensive, more what it means in English. الإحسان starts with having great faith, strong faith, then social connectedness, especially your parents, and then your family, and then your extended family, your friends, your neighbors, the environment, everybody. It's not as it sounds in English. The way we apply it here is very big. And it helps people to calm down, to relax, to focus, to be productive, to be happy. Social connectedness is related to all the other ones. Financial and economic health, family structure and role, family and social dynamics, very important stuff. And you could solve a lot of problems for your patient, not just the physical stuff. Do not focus on the disease. Focus on the patient that has the problem. If you focus on the disease, you'll be looking at the lipid numbers and you look at A1C. You need to look at those, but focus on the patient. Is the patient improving or not improving? You really need to focus on the individual. And sometimes I invite the whole family. Even if it's a little child that's coming, I need to see the mother, the father, the siblings. If they have a maid, the maid is coming. Who's taking care of this child? If it's an older parent, I need to see the children. I always ask one of the children to come. Children, these are adults, not little children. So one of his offspring should come with him. And in our society, we are lucky. We have a lot of birr or, taking care of our parents. Now, when you treatment plan is an agreement plan. It's not just patient, you have to discuss. It's one of the things I get from patients. This is really, I want to say something. I say, what is it? This is the first time somebody discusses my plan, my treatment, and ask me if I agree or disagree. Usually take this pill, see you in 6 months, in a year, do good, make sure you eat healthy, exercise, and I'll see you in 6 months. And sometimes even the prescription doesn't match the follow-up appointment. So you need to match your plan to the follow-up appointment, and you need to have goals and expectations. So the patients will come with exact goals to achieve. We need to lose 2 kilograms. I want to see your A1C from 11 to 9 next time. Maybe it doesn't become 9, maybe it's 10. But we see patients improve because there is specific goals we are following. Medications, usually I look at the medication and I tell them based on the number of medication, we want to lower the number, maybe we'll get rid of some of the medications. And they're very happy because I do ask them, do you want lifestyle interventions, food, nutrition, exercise, being happy, enjoying life, or you want food, or you want pills? Almost all patients want lifestyle interventions. They don't want to start with pills, especially when they are newly diagnosed with type 2 diabetes, they have obesity, they have hypertension, hyperlipidemia, even depression. So training, but you have to be patient with your patients in order to see improvements. Medication management, which is being able to lower, increase, or decrease dosages, stop some medication. If you don't know how to do this, we'll be happy to help you. You could contact me. How many minutes do you have?
2 minutes.
2 minutes? Okay. Lifestyle, long-term planning, very important. Key care indicators. It's not the A1C and lipids only and the blood pressure numbers, no. It's their overall quality of life. Are you happier now? I have a 72-year-old man. I started treating him. He came in with diabetes, hypertension, obesity, and chronic constipation. You know what was the big problem for him? A chronic constipation. When I started with him, I told him we'll be managing all of these together, but we will solve the biggest issue for him that day. 2 weeks later, he came crying after he said that this is the first 2 weeks in many years that I don't have to take medication to go to the bathroom. It has to do with his food. So he started eating vegetables. He took probiotics to help him out. We repopulated his gut with good bacteria. So there is a lot of things you could do. And he was really crying. I'm not just kidding. You know, he has tears in his ears, in his eyes, not his ears, of course. Lifelong management is very important. Don't be afraid to ask your patient, do you smoke? Do you take drugs? Do you drink alcohol? Do you have good relationship with your mom and dad and your wife or your husband, your children? Sometimes they need somebody to direct them where to go. And they really appreciate it. Driving a smart technology, very important. A lot of patients come in with high blood pressure. Why? They have driving disturbance. There is a diagnosis called driving disturbance. Look it up on ICD-10, ICD-11, you'll find it. Also, smart technology, disturbance. It's there also. Is it done? No, it's not done.
The IT, please.
Is
And we
it-
have the PowerPoint.
Is that it? Is that it? Alas. Thank you in a way. That's it. We're done, right?
So much. Thank you so much, Dr. Saleh. So we will have the panel discussion at the end of this session. So the next speaker, Dr. Gamar, she will gonna talk about the protein, vegetarian, and diet. Dr. Gamar works as a consultant in a family medicine, National Guard affairs in Riyadh, and also she's interested in a lifestyle medicine. And welcome, Dr. Gamar.
Assalamu alaikum, sabah al-khair, everyone. I'm very glad to be here with you. Thank you for the invitation and for the great organization. So, someone help me start this? So today we will talk about protein and vegan diet. Let's start with the vegan diet. So a vegan diet is a dietary plan that eliminates all animal products. So people who follow vegan diet, they don't consume poultry, they don't consume meat, fish, eggs, and even honey. They instead focus on a plant-based food, fruits, legumes, grains, seeds, vegetables. So this dietary choice is becoming increasingly popular due to its potential health benefits. Some people follow the vegan diet for its environmental benefits, some people for their ethical consideration, and we will talk about that. So why people are following the vegan diet? So a vegan diet, as we said, it can be full of health potentials, and we will talk about that. But please bear in mind that once a person chooses to go on a vegan diet, it has to be carefully planned. You can't just say, I will start eating fruits and vegetables and I will be healthy, because there is also disadvantage to a vegan diet that we will explore. Okay. But first, let's talk about types of vegetarians. So are all vegans the same? No, we have people who are just vegan, as I said. They don't eat meat, honey, poultry, dairy products. And we also have raw vegan. They don't even eat processed vegetables, cooked vegetables. Everything has to be in its raw model. We have, for example, ovo-vegetarian. These can consume eggs. We have lacto-vegetarian. These can consume dairy products. We have pescatarian. These can eat fish. So it depends on each individual preferences on which they want to eat, what they don't want to eat. So as we said, the advantage of a vegan diet, we said first for health benefit. It has been shown in studies that it lowers the risk of chronic diseases, diabetes, coronary artery diseases, and sometimes of cancers. Why is that? People who are consuming more of a plant-based diet, they are getting all the necessary nutrients. They are getting antioxidants. They are getting fibers. And in the same way, they are eating less cholesterol, they're eating less fat, less high sugars. It helps in weight loss. If you are getting fibers, you are more highly to be very satisfied with your meal. Early satiety, you are very full. Also, it's high in fiber, the same way, so you are more full. Improved digestion, the same way, it's high in fiber, so it's more likely to have a good digestion. Environmental benefits. Now let's talk about this one. Why people will think that a vegetarian diet is better for the environment? First of all, land use. Animal agriculture requires large amount of land for grazing, for growing feed crops that can lead to deforestation with time and soil degradation. On the other hand, a vegan diet, it needs less land, so we can have more efficient and densely grown plants. Water use, let's think of it. When you have kettles, when you have agricultural animals, you need to water them, you need to clean them, you need to make crops for them to eat, so you need to water that. But when you have a plant-based farm, it's only you have to water the plants. Greenhouse gas emission. Animal agriculture is a significant contributor, mainly to the gas of methane and carbon dioxide that is produced by the livestock and the animal feeds. Moreover, it contributes to pollution through using of pesticides, fertilizers, antibiotics. And if we compare it to the plant-based diet, it's less intensive and fewer chemical is used when you are growing plants. Energy consumption. Let's think, for example, for Al Mara'i factory. They need large energy to make the factory work, to produce, to milk the kettles, to transport the milk to the stores, and so on. And the last one is ethical consideration. The same. Some people, they don't think about the health benefit, they don't think more about the environment, but they think about the ethical impact on the animals. Because they assume that there is a cruel and inhumane practices for the animals, like confinement, overcrowding, physical abuse, the slaughter practices. And some people, they also believe that animals have actually an inherent right to just live. It's not for the human to use them for production of food. So this is one of the systematic reviews and meta-analysis. It was published in 2020. It studied the association between inflammatory markers and the use of plant-based diet. They see, like, for interleukins, C-reactive protein, and they actually found that a vegan diet was associated with lower level of inflammatory markers like CRP, and this was more strongly associated in people who already have an impaired kidneys. Another study that's published in 2022, it looked for a vegan diet on cardiometabolic health, and this is a systematic review meta-analysis. It found that people, if they followed a vegan diet for 12 weeks and compared these to control who are omnivores, who eat animal products, they found that a vegan diet can help reduce the body weight, the BMI, the A1C, the total cholesterol, and the LDL. There was no difference in blood pressure, in triglyceride, or in HDL. But they found that if a person having diabetes, having obesity, just following a vegan diet for 12 weeks can help him lower their glycemia and their weight. So what about the disadvantage of a vegan diet? As I said in the beginning, a plant-based diet or a vegan diet has to be carefully planned because it's common to have nutrition deficiencies like B12, iron, calcium, vitamin D, omega-3. So some people need to take supplements. Also increased food costs. Let's think about it. When you go to the supermarket, you want to buy cow milk, the largest size may cost you up to 6 riyals. But if you want to go take almond milk, for example, it can be up to 30 riyals. So yeah, the cost is higher. Now we are paying more money to be more healthy. Social challenges. Think about it. Do you have a vegan person in your family? It's always causing some conflicts. They don't have, most of the restaurants, they don't have vegan options. In social gathering, especially in our hospitality in Saudi, in the Gulf country, in the Arab country, we like to provide meat, chicken, fish at least. So we always have this big gatherings. So vegans in Eid, let's say Eid al-Adha, they have a big problem in the mornings. Digestive issue, we said fiber is good for constipation, but on the other hand, it can cause diarrhea, it can cause gases and bloating. And also food preparation time. For example, you want to grill a steak, it might take you 4 minutes for each side, but if you want to cook lentils, if you want to cook beans, it will take you more time. The last problem is protein. As we said, if you are not planning your diet, you may be not getting enough protein, but this is not true. If you just planned your diet right, you put quinoa, you put tofu, you put legumes. This is an example how a vegetarian or a vegan person can eat a 120 grams of a protein in a whole day, just by planning your diet. Okay, now let's move on to the protein diet. Protein is an essential nutrient. We need it to build our muscles, to build our tissue, needed by organs, by hormones, by enzymes, for healthy skin and hair and nails. As Dr. Saleh said, it's very important for us female. I will move this one. Okay. So let's start talking about the types of a protein. We have animal-based protein and we have plant-based protein. The main difference is animal-based protein, it has the whole amino acid. You can take one steak, you have the whole amino acid, the 9 important ones. But if you take plant-based protein, you need to combine the sources because usually they have partial number of the amino acid, not the full of them. So you need to combine different sources to get the whole amino acid profile. Now let's talk about the advantage of the amino acids. I will show this in picture later. So in literature, they said, and in some studies, it showed it's helpful. As we all know, it's important for lean muscle growth. It's important for the things I mentioned in the early. But they also said it may improve the bone health. It showed in studies that a high-protein diet can help maintain bone density and reduce risk of osteoporosis. It also showed it may lower the risk of chronic diseases and certain types of cancer. But let's see the evidence on that. So how much protein do we need? A regular person might need up to 0.8 per kg per body weight per day, but athletes and people who want to follow a high protein diet, they may take up to 1.6 gram per kg per body weight per day. So this one of the studies about the impact of high protein diet on cardiovascular outcome. So the researcher was thinking, is high protein diet related to strokes, to cardiovascular death? And they found no. You can be using a high protein diet and it will not increase the risk for cardiovascular death or stroke. Another study, it was done on elderly, published in 2022. It was looking for the effect on bone. They found that if people are consuming high protein diet, it may increase their lean body mass, but it will not affect their bone health. So some studies showed there is effect, some studies showed there is no effect, so they did a systematic review, and this is the result. Okay, on weight changes in obesity. As we said earlier, hypothetically, if you are consuming protein, you are more full, and your body is consuming more energy trying to digest this protein compared if you are taking carbohydrate. So hypothetically, you should be losing weight if you are following a protein diet. But in this systematic review, actually, they found there is no difference. Okay. Advantage, disadvantage. As we said earlier, if you are focusing on a high protein diet, don't forget about the other micronutrients. It's not meaning that carbs are bad, fat is bad. We need all of this. And consuming too much protein can put strain on kidneys, potentially, and people who already have kidney impairments. High protein diet can increase your water loss from the body, leading to dehydration. So you have to maintain a good water consumption. Also, if you are taking this protein with high saturated fat, you are then going back to increasing your risk for cardiovascular disease. So how can I take a high protein diet and be fit, be healthy, choosing the right protein? Protein doesn't mean animal products all the time, as I said earlier. Okay, so it's not a marble rib-eye steak, for example, every night. So they did, sorry, this is not protein, it should be animal versus vegan protein. They did a study. Like, if I am a vegan person, I want to increase my muscle mass, can I be completely on plant-based diet? I don't want to eat fish, I don't want to eat meat, I don't want to eat eggs. I want to only take plant-based diet. And they found actually that the muscle strength, the lean mass, muscle cross-sectional, there is no difference. You can take all the protein you need only from plants. Another example, here for example, we have protein from beans and beef, the same, exactly the same, 20 grams of a protein from a portion of beans and from a portion of meat. But look at the differences in the other nutrients. Here we have fiber, here we don't have. Here we have more micronutrients, here we don't have. Here we have cholesterol in the meat, in the beans we don't have. The same for chicken and chickpeas. Minus, of course, in the chickpeas, the hormones, the steroid, the antibiotic. So if you want to follow a high protein diet, always think of the source of your protein. Where are you getting your protein from? So what is better, to follow a high protein diet, to follow a vegan diet, to go plant-based, to go raw? Actually, it depends on your individual needs and your individual preferences. So my bottom line here is just please be aware of what you are eating. You are following a vegan diet, plan it carefully. You are following a high protein diet, plan it carefully. Choose your sources. And that's it for me.
Thank you so much, Dr. Gamal. So just we have an announcement from the organizer. Please do the registration for today to have the account for the credit hours. If you can, scan the barcode in your badge, or if you have any issue, please go to the reception. They will help you for the registration. So welcome Dr. Sultana Al-Utaybi again. She's from Al-Habib Hospital, and she will gonna give us a short talk about the medically tolerated meal plan and food packages. And welcome, Dr. Sultana.
Good morning again.
Actually, due to timing, we was planned to cancel this topic, but I feel like I should speak at least about the most important points in the slides. Medically tailored meals. First, we will speak about why the nutrition is important, and the Food is Medicine initiative, which include medically tailored meals and food pharmacy program and produce prescription, and the health and economic benefits of medically tailored meal, samples of some of medically tailored meal standards. As we know that poor nutrition is leading cause of disease and early death, and based on World Health Organization, 2/3 of all death is related to lifestyle, including nutrition. Increasing fruits and vegetables intake might help to reduce the risk of diabetes and most of chronic illness, like Alzheimer's, heart disease, and some cancers. This study showing the healthcare cost per person annually, and comparing that between those who's food insecure and those who's severely food insecure person. And they found that the people who's really food insecure, they have higher cost per year. Medically tailored meal concept, it was started by this lady, which is retired food service, and she was helping her neighbors who's suffering from AIDS to provide them with meals during their illness. Then later on, it was expanded to cover more and more. It was consists now from home delivery meals that planned and prepared based on patient nutritional status and condition, as per the recommendation and approve of registered dietitian, also after nutritional assessment and consultation. Here is supportive food and nutrition services. Food is Medicine program model consists of nutrition incentive programs, food pharmacy program, medically tailored meal and food, nutrition education and teaching. All of these is based on nutrition education, behavioral education, and cooking. And the goal of all of these initiatives is to provide healthy food to manage diet-related chronic disease. We can see in this slide the concept of food as medicine. As we see, when we go from down to up, we are providing supportive food services to prevent, to treat disease. At the below, there is healthy food for those who's only at malnutrition risk or food and insecure to support them. Then once we go up, we are supporting with medically tailored food for those who's at risk only of chronic or acute illness. Then medically tailored food for those with really acute or chronic illness. And on the top is medically tailored meal for those who's recently discharged from hospital or suffering from acute illness. In the top, it's focusing on the people who's really sick and might cost the health care sector more cost. So they are trying to manage them at home with proper nutrition instead of having them readmitted again to the hospital. And in the left side, you can see what kind of explanation for each element. Medically tailored meal, as we said, it's fully prepared based on individualized assessment, and the target is the people with chronic disease or those who's unable to shop or prepare their meals. And the outcome is that this initiative helped to decrease the hospital admission and ER visit, and also decrease the health care cost, and increase the quality of diet and adherence of patient to medication. Medically tailored grocery, it's grocery items selected by the dietitian based on the patient's status, and the patient will prepare them at home. And also the target is the same group of people. Produce prescription, they are providing vouchers or debit card for the people who's food insecure, so they will be buying them, they will taking them from the market. And also, it's for the people who's suffering from or at risk of chronic disease like prediabetes or obese. This will help to increase fruits and vegetable intake and decrease fast food intake and reduce hemoglobin A1C. The detail and eligibility of this program, the number of meals, they are providing them 10 to 21 meal per week, which equal to 2 to 3 meal per day, depend on nutritional need. The duration is at least 3 months, and it need for reassessment every 6 months. It need referral to a registered dietitian to plan, and the target is, as I said before, the chronic illness, those who's recently discharged, those who's at risk of hospitalization or extensive care need. Here are the health and economic benefits of medically tailored meal. It will encourage the healthy eating, treat and manage chronic illness, less hospital visit and readmission, tailored based on patient care, and the patient will understand the concept of long-term change. The researches vary between the outcome in the medically tailored meal because every program is targeting different group of people. Some is targeting elderly only, some is targeting the high-risk people only. So it decreased the ER visit 22% to 58%, decreased hospitalization, decreased hospital readmission within 30 days, improve health outcome, decrease the healthcare cost, and increase the dietary adherence. Here, example of some of the standards for the medically tailored meal that one of the agencies follow. Here also example of some plan of the diet to control cholesterol level. Medical nutrition therapy for kidney disease, for diabetes here. DASH diet recommendation, example. Portfolio diet to manage blood cholesterol. Here comparison of different diet type and different specific food on its effect in hemoglobin A1C and different disease outcome like blood lipids, weight control, cardiovascular illness, and some of its disadvantages that might affect the patient. Food pharmacy program, the target is food insecurity. The aim is to increase the accessibility for healthy food through coupons or financial incentives. The patient provide with the resources because we will give them meal plan, recipes, cooking, classes to provide the awareness and skill in preparing their meal at home. Interprofessional care team was consisting there, and it was effective strategy to change behavior based on systematic review of 30 studies. Produce prescription, the target is the low-income patient who have diet-related disease, who is unable to buy food, and the aim is to promote fruits and vegetable intake in high-risk patients. The prescription will be used to obtain subsidies, produce, and food items through various community partners. The subsidies range from saving $5 per week to free complete meal. This will give the patient message that the food is just as important as medicine. Here is the steps for the produced prescription from screening. Then they will refer to the dietitian. Then the patient will have the produced prescription. Then he can receive the redeems at the redeem side. Then he can have education, and some is not mandating the education. Then they will have data collection and evaluation to proceed in the next. I have some video. I'm not sure if the team can play. No?
The IT, please. Can I
At
apply
least
the
one
video?
video. It's about food pharmacy program.
الصوت لو تكرمتوا.
To conclude, just return to the slide. You can search about food pharmacy program, produce prescription in the YouTube. You will find multiple videos, but it will give you clear understanding of this program and its implication and its also outcome. Can you back to the slide? To conclude, medically tailored meal for patients with acute illness or those who's really at risk of readmission could be implemented even in our area and evaluated for its effectiveness in healthcare outcome and even healthcare cost. Food prescription for healthy food, and as we know that there are some patients, they are trying to really follow healthy diet, especially those who's very obese, and they are feeling that the healthy food will be more costly on them. So produce prescription could be also implemented. Nutrition education and healthy cooking classes should be supported also for people who's at risk of chronic illness, like morbidly obese patients and those with really high risk of developing chronic illness. Instead of searching and trying to find people through social media to help them, we can support this service in any way. And we should understand that there is no one plan fit all. Even if we have one standard, we can give the patient instruction, but we should tailor every meal plan and every diet instruction based on the patient preferences. We should ask them what they need and what they prefer before making a plan and setting goal with them, and we can follow up later on with them to achieve goal. It's the end. Not moving. أعتقد إنه خلاص. This is the end. Thank you so much.
شكرا Mrs. Sultana. Great presentation. This is just a quick comment. This one of the initiatives that will be introduced this year, which is medically tailored meals. We'll be working on this program to introduce it in our society. And also Dr. Abdelaziz Al-Uthman will be introducing the second one, which is nutrition in the food retail program, which is a huge program, will benefit patients and also nutritionists, and hopefully you'll see it in your nearest supermarket soon, inshallah.
Thank you. Welcome, Prof. Abdelaziz.
السلام عليكم ورحمة الله وبركاته. صباح الخيرات والسعادة في اليوم الجميل. Despite I tried to my best to enjoy the marvelous ceremony, opening ceremony last night, and enjoying the healthy meals, I was thinking how I can present my talk. I have an idea, but I didn't know what's the best way to present it and make it clear for you. But I will try my best. Now we are thinking about these, the people with chronic disease. How many people, or what's the incidence of diabetes? Say 30%? What about these 70%? Hypertension, what's the incidence of hypertension? Maybe you can say 25%. Okay, what about this 80%? how can we stop, if we are talking about prevention, how can we have a real application to stop these people to not going to the disease site? This is what I'm trying to present it today. Now, we are talking about the diseases, and I don't know how I can make next slide. الأخضر بس doesn't. الأحمر صعب. Anyway, you can see this study of Lancet. You are maybe familiar with this. It's study the dietary risk on 195 countries for almost 27 years. What they found, they published in Lancet. They found the cardiovascular disease, as you know, how many people get more, the mortality rate or even the disability adjusted life year by year people in cancer, diabetes, diet-related diseases, high intake of sodium or whole grains or fruits. There are many people dying due to this. And also some of them, they get disabled due to this malpractice. And these slides show how many people eating fruits. If you can see, if you compare it with how many people getting enough fruits, vegetables, legumes, whole grains. And most of them under the recommended daily allowances. Also milk, calcium, fiber, omega-3, etc. And also some people even eating more than required in red meat or processed meat or other foods, as Sultana presented. Now, what do you think the most important factor attribute to mortality? What type of nutrients, if I can say, or practice attribute to high mortality rate? Is it fat? Is it sugar? Is it processed foods? Is it salt? Is it meat? What is it? What do you think the highest food or we should avoid to lower the mortality rate? Is it sugar? Fat? Animal fat? Actually, it is sodium. The highest risk for your health is sodium. Either sodium chloride or also the monosodium glutamate. What is the second, do you think? The second risk. It is low in whole grains. What is the third? Low fruits. What is the fourth? Low nuts and seeds. What is antioxidant? Then low vegetables. So it is the same for disability. So also low whole grains, low sodium, high sodium, low fruits, or low nuts and legumes. They are leading to these diseases. Now we are in front of real problem. We are talking about it and we have some research, but we need to apply a real way to prevent people from these diseases. From consumption, high consumption of sodium or processed meat or very low fruits and vegetables, especially for young generation. Food as medicine. We are talking about sustaining health, well-being, as Dr. Saleh mentioned all the time. How can we prevent diseases, or how can we encourage or improving quality of life? How can we treat some cases with using food and nutrition? So these are the main principles of food and as medicine, you know, to encourage health and well-being by many approaches, to improve nutrition security, to provide all foods, to also focus on local foods. We believe that if you eat from your local foods, this is healthier than getting foods from different countries. For example, do you think that strawberry is vital, is very important for us? No. Despite it has antioxidants, vitamins, minerals, but we can live without it. Why do we have dates in our country, in Saudi Arabia? And in Scandinavian countries, they don't have dates. أحد يقدر يقول لي ليه؟ ليش عندنا نخل وتمر ما عندهم؟ يمكن تقولون والله النبات النخل ما يعيش إلا في درجة حرارة عالية، صح؟ هناك برد. طيب أسأل أنا ليه القمح ينمو عندنا وينمو عندهم؟ الله قادر إنه يجعل النخل نفس الشيء، نفس القمح. So there is something else. We need some nutrients that suitable for us in our areas. Even seasonal variation, to eat the fruits that in the winter or in the summer. As you eat from your local foods and seasonal foods, that will be better for your health. And also how can, in food as medicine, how can we manage and treat diseases with lifestyle medicine? And how can we promote food safety, contamination? كثير من الناس, for example, now monosodium glutamate. Do you know monosodium glutamate is? تعرفون هو وش ايش؟ الناس يقولون له الملح الصيني، ملح النكهة. طبعا هو يعني مسموح يباع في المحلات. لكن the requirements is very little. What's happening now, because it's improving taste, the foods, all people use it. يعني in restaurant they use it, in مطاعم البيكريز المخابز الجميع using this. ليس فقط في الناس اللي يتكلمون مشكلة الأندوميا ومشكلة other foods, and all people using this. So if the child taking 2% from this and 2% from 3% of this, then the sodium glutamate will be very high. So also this is another issue. What is medicine? How can we have food retail? Now, if we have a health condition, the person or the patient will come to your clinic. Okay? As I mentioned, how we can stop this? How can we educate them? How can we prevent people to get diseases? So this is the new project we'd like actually to introduce it to you, as Dr. Saleh said, and also it's a new job opportunity for clinical dietitian. Now, suppose some patient, again, diabetic patient, or patient with allergy, celiac, go to the supermarket. How can he or she choose the right foods? Tell me. Reading the labels, as Sultana mentioned? Yes. But it's not enough. For example, what about these foods without labels, fruits and vegetables? For diabetic patients, how I can know these food high glycemic index or the carbohydrate counting is high? How I can know these foods may get gluten in it? Yes, it's not wheat, but it's one of the components, maybe it's gluten. How I can know the highest the energy? How I can know what is the cheese and similar cheese اللي هو شبيه جبن وشبيه جبن أو القشطة شبيه جبن. What is the difference between them? What is the difference between milk and lebanon or yogurt? How I can choose this food? when we go as family, we are choosing the right we think it's okay. Who said that this is okay for you? So we need somebody in the supermarket helping us, redirecting us to choose that food. Means the supermarkets company should find somebody or employ somebody to do this. Oh, the company said, oh, how I can pay the cost of this service? How I can pay the salary of maybe 10,000 riyal minimum per month? Actually, this person will be the best one who will encourage people to choose the right foods and to buy more from the right foods. For example, if I am a dietitian in the supermarket and somebody come to me looking for, or he may or she may said, I get constipation, for example, Dr. Saleh said. Okay, I can direct them to foods that high in fibers. But I can tell them, oh, you may need antioxidant. Oh, what about this type of carrot? What about this type of tomato? Do you know this food is better than that one? What about your kids? Do you have kids? Yes. What type of milk or formulas? They said, no, we don't know. We just use the same formulas. What is the difference between infant formulas? So marketing, healthy marketing. So we need, I'm not saying to this dietitian to say, oh, don't go and buy Coke. But at least I can help people to choose the right foods. Huh? This is what we meant by the food retail and the role of the clinical dietitian in the supermarket. Is the ROI is high? Yes. And also how I can make, walk in between the ROI or the cost and how I can improve the positive health outcomes, how I can train these people to choose the right. What about the marketing? And we need actually to improve the skill of marketing to choose the food that we want, the food that we like, and at the same time, healthy food. So these are the programs can be applied to achieve this by prescribing some prescription program. And an active program means, as Sultana said, I don't need to write a prescription. I can give coupons. So if you have your bill is 200, I can give you 2 coupons to buy healthy foods. Okay? I can have integrated program with other supermarket or other people. And I can have a medical tailored nutrition as Sultana mentioned. And also I need to personalize my nutritional education, either to have like classroom to educate people or redirect them or have connection with them or, so it is sort of healthier advertisement that this dietitian can do. So it is, at the end, I can focus on the family, how I can encourage family to choose their right foods and also to improve their lifestyle, improve the security of foods, how can they put foods in refrigerators. Do you know that many people, they don't know how can even put food in refrigerators? They put meat in the top and vegetables in the bottom and eggs. They don't know where they should put foods even in refrigerators or even store them. All of these skills need to be trained to improve health and also to secure food from any contamination. So this program, like we need some pharmacy of food, of healthy food in the supermarket, and somebody to help us actually to focus on not only foods, but also skill of eating. يعني احنا نبغى أحد يقول لنا how can I can use مثلا black seeds. كثير من الناس ما يعرفون يستخدمونها. how I can يعني مسألة المضغ، مسألة البلع، enzymes, how I can, I need to put foods together or focus on one food, how I can make meal plan for family.
2 minutes, please.
Okay. So also I need actually to protect people and educate them with the safety foods. I need to tell them what does that mean of healthy labels. Healthy labels, it's a label using in the supermarket to tell you that product, this having healthy label, to have this product having low salt, low sugar. So it's not suitable for us, but at least to know this is, when I see the label, I know healthy label, I can see that this is low salt or low sugar or no saturated fat, etc. So this is the program, training program or fellowship. It has many parts. One of them the role of the dietitian in the supermarket or in the place of grocery, and also evaluation, the food and retail setting evaluation. How I can train people or dietitians to evaluate this person and to evaluate the foods and to find a way to find a match between foods and person. And also even interns can be trained to on using this programs. So thank you very much, and I hope that I convey a message in the right way or simplest way. But we'll work on it. Inshallah, you will see it, inshallah, in future. We need actually your input to help us. How can we implement this preventive program in our supermarket, in our grocery, in a place, or also how can we train people? And also we will work on this fellowship, inshallah, with Dr. Saleh support. Inshallah, we'll have fellowship in this. Thank you very much.
Thank you, Prof. Abdulaziz. Thank you so much. So the next talk is about the lifestyle medicine training. Dr. Raja Raddadi, she's associate professor and a consultant in preventive medicine and public health, head of the Department of the Community Medicine at King Abdulaziz University in Jeddah. Welcome, Dr.
السلام عليكم ورحمة الله وبركاته. بسم الله الرحمن الرحيم، والصلاة والسلام على أشرف الأنبياء والمرسلين سيدنا محمد وعلى آله وصحبه أجمعين. Again, I will thank the organizing committee, especially Dr. Saleh Al-Rajhi. He communicates with us frequently to ensure that we are on track with the program. حقيقة اليوم يعني دائما تقريبا يوميا أتكلم عن الميديكال education وبحكم يعني التخصص لكن اللي وجدت انه اليوم كان عندي صعوبة في كتابة هذه المحاضرة او صياغتها، لكن في النهاية باختصار انا حطيتها على extensive literature review وmy experience. I will start with the time to put the lifestyle medicine team in place. We talk about team, there is heterogeneous specialty with different background talking in the same topic. So the continuum of lifestyle medicine education should be implemented across all levels of medical education, and a lot of paper published talking about including medical school, residency, fellowship program, CME, and special certificate. One of the landmark paper published by Polaki et al. Talking about the continuum of teaching and education, teaching and learning, education and lifestyle medicine, starting from undergrad to grad in the residency program, curriculum, fellowship, CME hours, and special certificate, together with interprofessional education during the training, either in the undergrad, postgrad, or during post-professional education programs. One of the most important paper published on the mapping lifestyle medicine in undergraduate medical education, a lever for enhancing the curriculum, talking about the importance of introducing lifestyle medicine from the start of graduation. This is the Faculty of Medicine Lifestyle Medicine Spiral curriculum in the first year, second year, and clinical year, it's third year of them, with 44 teaching hours, starting from population health in the first year. As Dr. Saleh mentioned, population health is one of the core in the preventive medicine and lifestyle medicine, using bioengineering tools for health behavioral changes, smoking, physical activity, and sleep in the first year. Mindfulness session, exercise session also. In the second year, they are talking about motivational interviewing, theoretical lifestyle counseling, and nutrition. And they start in the clinical year in preventive medicine, importance of the lifestyle behavior, practicing motivational interviewing, and online coursing, practicing this. And finally, they select the learning objectives for each of these components of the curriculum in the undergrad with the teaching methodology and the hours needed for that training. They start to classify the topic that present in preclinical and clinical. As you can see, the preclinical years have the majority of the content of lifestyle medicine teaching. Also, in this paper, they present the attitude of medical student toward lifestyle medicine, and they use the scale from strongly disagree to strongly agree, and asking the medical student about their attitude regarding the patient, if the patient expects their doctor to be role model in the healthy, and the majority of them agree with the response, the mean response of 3.4, that they agree on the side of agreement for that. However, they disagree on that the advice regarding healthy lifestyle is the role of allied health professional and not doctor. They think that there is a role for physicians to practice lifestyle medicine. Also, they ask them about self-perceived confidence in providing lifestyle medicine counseling using the scale from 1 very low confidence to 4 very high confidence. And they ask them about general lifestyle, exercise, each of the components, smoking, obesity. They found in the first 3, general lifestyle, exercise, and smoking, they think that they are confident to practice that. However, obesity, nutrition, alcohol, stress, mental health, and well-being, sleep, and sexuality and health, they think they are not confident to provide that for the patient. Another paper by Jennifer talk about the continuum of care, and they introduce the concept that educational pathway starting from 100 hours during medical school and more than 400 hours during residency program, starting from 400 lifestyle medical related patient encounter, 20-hour intensive therapeutic lifestyle changes, and 20 hours group facilitation on lifestyle medicine. Again, to the Pollack model, my experience, I present my experience in King Abdulaziz University and in the Saudi Council for Preventive Medicine Board. First, we introduced lifestyle medicine in the 4th year في community medicine curriculum. There is project and clinics and lifestyle modification methods, smoking cessation, and all of this. And we put clinical preventive part in the curriculum more than previously approached public health approach for community medicine presentation in the medical school. Second, we have an experience with development of fellowship curriculum for preventive medicine, talking about lifestyle, concentrated on lifestyle, extended from the curriculum for the residency program. This is lifestyle fellowship program. We base our content on this pyramid. This is the level of prevention, starting from primordial prevention in general population, to reduce the emergence of risk factor. And this is one of the components of the curriculum. The second is primary prevention for the susceptible population to decrease the incidence of the disease based on the management of the risk factors by lifestyle medicine. And third, for asymptomatic and early disease by reduced prevalence and complication of the disease. Also, we apply primary, secondary, and tertiary prevention. Based on that, we expect that the fellow can critically appraise the assessment tools and all resources and supportive resources for lifestyle medicine to adapt that tools in our country or our region. Also, we expect that the graduate from the fellow can participate in the guidelines development, and we make a lot of sessions for them now in the Preventive Medicine Board to critically appraise the national guidelines using agreed-to instrument and other international instrument, and try to rank the guidelines according to the suitability for our community. And second, the graduate can grade the evidence according to our local context, turn research into practice, and turn research recommendation or the level of evidence into grade of recommendation based on our context. Assess the practice and outcome using research methodology related to the assessment of programs and the evaluation of implementation of this program. Identify the gap in research and prioritize the research related to lifestyle medicine. So lifestyle medicine and education continuum, Pollack also published a study that summarized the existing literature and provide knowledge and tools to dean, administrators, faculty members, students to guide them to establish their programs. One of the points that talk about is lifestyle medicine CME programs and the variation in the objectives, methodology, duration, and participation. They found that the length of the program ranged from 1 hour to 32 hours of training. This depends on the target. Sometimes the target is specific condition, for example, pediatric obesity, and sometimes the target is behavior, like smoking or other behavioral factors. And they measure the outcome by increase in patient counseling and improve in patient-reported outcome to evaluate the implementation of lifestyle medicine in any context. And if you want to fill the gap, lifestyle medicine team, in addition to lifestyle medicine trained provider, usually we are talking about physicians and nurses. The lifestyle medicine team include dietitian, exercise specialist, psychologists, counselors, sleep specialists, and all other healthcare providers could be involved in this process. Again, my recommendation for all healthcare workers in all specialty to revisit the curriculum in undergraduate, to introduce the concept of lifestyle medicine, and after that, during residency program, fellowship program, actually I was interested in Dr. Rafai's presentation about the food allergy and using lifestyle. I think each specialty, they have their own their own background, their own need to introduce lifestyle medicine according to their background and to their specialty. And finally, lifelong behavioral change is the missing evidence-based component in our region. Thank you very much.
Thank you so much. We finish on time. We start from 7 to 10 for 9 sessions, 9 presentations. Now we will open the panel discussion for like 5 to 7 minutes. Okay, Dr. Saleh, just guide us. We will have a break now. We're going to start, and also we will open the panel discussion for the questions. And we were going to take a a few questions. And as we mentioned today, our lifestyle medicine changed the conference style. So we ask the audience, please feel free to reach our presenter today. They will gonna stay with us 3 days. And if you have any question or opening conversation, you are welcome. And now I will give the mic to Dr. Saleh.
Just a comment on training, and then I'll turn to Dr. Saad al-Battal afterwards. It's our belief for the past 5 years that lifestyle medicine training should be open to all specialties. I think Dr. Raja and us agree on this, regardless of their preventive medicine, family medicine, internal medicine, general pediatrics, because our patients need it, and no number of physicians will be able to do it by themselves. It's a national need, it's a regional need, because we have pandemics. We cannot cover it, you know. Like obesity, can we just leave it to obesity-trained, fellowship-trained individuals only? No, we should open the training for everybody who needs to be trained, because it's obesity now in women is 49%, in men it's 39%. So we have a big problem. So we need everybody's effort to do this together. And opening fellowship programs, training programs for the rest of the specialties is very important. Turn it to Dr. Saad for more.
طيب السلام عليكم صباح الخير جميعا. في البداية قبل ما يعني I comment about this issue, I would like to thank the scientific committee for crafting just such an amazing schedule for lifestyle. إذا سمحت لي دكتور صالح بتحدث باللغة العربية يمكن توصل المسج بشكل أسرع. أنا حاب أحيي دكتور رجاء اليوم موجودة معنا. She's chairman of Preventive Medicine Scientific Council. وفيه ongoing discussion right now في أروقة الهيئة السعودية لتضمين الفاميلي ميديسن بالفيلوشيبس. ما وصلنا إلى قرار الآن، ولكن what I'm saying إنها very promising discussion، وإن شاء الله نسمع أخبار جيدة بإذن الله في القريب العاجل.
طيب السلام عليكم. دكتور أيمن عفيفي، استشاري طب الأسرة المستشفى العسكري. طبعا I am one of the advocates to open the specialty for all the primary care encounter specialties. Not only family physician, not only preventive medicine, general internal medicine, general pediatrician, general dentist, allied health specialties. الحقيقة أنا بتصور كل البرايمري كير are the frontliner to apply holistically what is needed in Saudi Arabia. Besides, as mentioned correctly by Dr. Raja, international professional education courses for the ultra specialty. We need lifestyle touches for surgeon, for obstetrician, for ultra specialties in the officer. But the frontliner, the main worker will be the primary care staff working in primary health care level.
معنا سعادة الأستاذ الدكتور عبد الرحمن مزروع رئيس جامعة سليمان الراجحي. نبغى ناخذ his perspective from undergraduate training program, and I would say that جامعة سليمان الراجحي is the leading university supporting lifestyle medicine في المملكة العربية السعودية اليوم مع جامعة الملك عبد العزيز إن شاء الله.
طيب نتحدث بالعربي ولا بالإنجليزي؟ طيب الحقيقة طبعا كلام حول الممارسات في اللايف ستايل ميديسن ربما مبثوثة داخل كثير من المقررات منذ القدم، لكنها كما أشير في المحاضرات السابقة ربما تأتي كسطر واحد دون الانفسيس الكافي لها. أعتقد المرحلة التي ينبغي أن تتم بعد أن يعمل في أي جامعة أو كلية طب أو غيرها المابينج للبروجرام وتحديد ماذا يطرق من جوانب اللايف ستايل ميديسن، وبعد ذلك يتم وضع موديولز ربما أكثر وضوحا، لأن الحقيقة أنا لست مع أن يكون هناك كورس خاص لوحده. هذا طيب لو وجد، لكن الأفضل أن يكون مبثوثا في جميع المقررات التي تدرس في الأندر جراديويت حتى يتشبع بها الطالب، وأيضا تبقى معه في كل ممارساته، فلا يكون وضعها في مقرر انتهى منه، وإنما وهو يدرس الجراحة يعلم أن هناك أشياء تتعلق باللايف ستايل ميديسن، وهو كذلك وفي البيدياتريكس كذلك وفي جميع التخصصات المختلفة. فربما يكون هذا هو الأنسب، ونحن إن شاء الله بإذن الله في الجامعة عازمون على أن نعمل المابينج، وبالتالي نحدد هل ما هو موجود كافي أو يحتاج إلى تعزيز على الأقل في بعض المقررات إن شاء الله.
دكتور عبد الرحمن، معنا ضيف، عندك تعليق دكتورة؟ معنا ضيف من عمان الأستاذ الدكتور خالد الرصادي، بناخذ رأيه في الموضوع وتعليقه.
السلام عليكم ورحمة الله وبركاته. أعتقد أنا أتفق مع الدكتور أن فعلا الموضوع محتاج أن يدرس على أكثر من مستوى، يعني مستوى الأندر جراد ومستوى حتى الفيلوشيب نفس الشيء. فمهم جدا. احنا مثلا بعطيك تجربة في عمان مثلا، اللي هو الريسيرش موديول عندنا، بدينا حتى في الأندر جراد عشان طبعا نحث الطلبة من البداية أنهم يفهموا إيش أهمية البحث، بالتالي ما يتفاجئوا طبعا لما يتخرجوا يكون إيش هي مبادئ البحث أو إيش أهمية البحث. يقول لك أنا طبيب مثلا، خلاص يعني أكون كطبيب ممارس، إيش لي علاقة بالبحوث. فأعتقد أن اللي هي نسميها الكلتشر أو الإيكو سيستم هذه مهمة جدا في كل هذه المراحل، يعني من المراحل الأندر جراد إلى البوست جراد. سالفة اللي هو طرحها كمقررات بعدين اللي هي أكثر تقدمية أدفانس، مثلا كماستر كورس اللي ذكرته مثلا، هذه مثلا تخص الناس اللي هو عاد اللي يشوفوا الناس باحتياجات دقيقة مثلا، اللي هو تكلمنا عنه إنه اللي هو البيرسوناليزد ميديسن. زين، يعني خلاص مثلا أنت كطبيب تشوف هذا ممكن إنه تعطيه بعض الوصفة اللي ممكن تفيده، لكن لو شفت إن هذه مثلا الوصفة ما نفعت هذا، فمفروض إنك تحوله إلى شخص يكون يعطيه يمكن نصائح بشكل أفضل أو الطريقة بشكل أفضل. فأعتقد محتاجين نفس الشيء ناس متخصصين جدا في هذا المجال.
ننتقل للدكتورة رجاء هذا الردادي الآن.
السلام عليكم. طبعا أنا أشكر دكتور صالح لإتاحة الفرصة نتكلم في هذا الموضوع. وأنا من وجهة نظري إنه أقل شيء نحتاجه اللي هو الفيلوشيب، لأنه الفيلوشيب هم راح يكونوا ليدر ايفالويشن بوتينج بروجرام، لكن في التخصصات في البراكتسينج هي اللي احنا نحتاجها الآن أكثر تو امبروف. I think إنه في البرايمري في الأندر جراد we need إنه يكون عندنا unified curriculum، يمكن كان ليد باي الراجحي دكتور العثمان يونيفرسيتي، إنها تكون هي الليدر في إنه يكون في unified curriculum في الأندر جراد في جامعات كلها. بالنسبة للبورد، كل بورد revise their curriculum إنه يكون في عندهم part related to lifestyle. And I think with family medicine, Dr. Saad al-Battal here, we can join family medicine, preventive medicine, and public health to make the fellow to be a leader, translating the international recommendation, try to tailor the international recommendation and guidelines according to community. On the other side, other specialty, they need to revisit their curriculum to include lifestyle inside this curriculum. شكرا.
جميعا شكرا لكم جميعا. أعتقد أنه وصلنا لنهاية مرحلة السيشن الأول. طبعا في ستايل تبع المحاضرة في السيشن أن يكون فيه تكريم للمتحدثين في نهاية هذه المحاضرة، لكن ننتظر بس توقيع هذه الشهادات. لكن أنا أعتقد أنكم يعني لو سمحتوا لي المقدمين اليوم راح نشكر من يستحقون الشكر في هذا السيشن، اللي هو زميلتي منى الشمري، أخصائية ومن الشؤون الصحية، وزميلتنا سعاد الشمري الإعلام من جامعة حائل. هم القائمين على هذه السيشن وهم موتيفيتد، وإن شاء الله بإذن الله في المؤتمرات القادمة راح نجد من الشباب المتحمسين ومن شابات هذا الوطن أنهم هم يكونون قائمين على هذه الفعاليات بقيادة مثل الدكتور صالح المبدع والمحفز دائما لنا جميعا. فشكرا لكم جميعا. Okay, so 5 minutes break.
Co-chairman of the sleep lab and director of the pediatric pulmonology section at King Fahad Medical City in Riyadh, as well an assistant clinical professor of pediatric at King Saud University. Welcome, Dr. Wafa. Dr. Wadha, sorry. حيجون مع البداية.
Assalamu alaikum wa rahmatullahi wa barakatuh. It's my pleasure to talk about the effect of sleep, and I would like to thank the organizer and scientific committee on ahead of Dr. Saleh Al-Rajhi. My talk will be today about the sleep health and the effect of nutritional, and I divide the nutritional to be macro and micronutrient, and what is the effect of the obesity in our sleep, and the timing of the meal with your sleep, and what is the coffee and how it is effect on the sleep, and the time of taking some time of nutrition to get a healthy sleep. First of all, I will define simply what is the sleep. Sleep, you have to know it's a natural and reversible condition that's controlled primarily process, and it is a physiological part of a human by neurobiological life. It is necessarily for us to maintain a good health and also to be a well-being. When you go to the sleep, it is reversible condition. You will go through many stages. We call them REM and non-REM. Each one, it's affecting nervous system. So REM stage, it is affecting on your sympathetic, so responsible for increasing temperature, blood pressure, and also your pulse. And the non-REM stage, it will affect on your parasympathetic, which is responsible to decrease temperature and decreasing also your pulse and the temperature. How is important of that? It's important for the growth, and that's why the need for the REM in children responsible for developmental of their brain, and the non-REM is also important for growing of the somatic. This is simple graph showing you what is the stage you are going and how many hours. We have to know that the sleep stages, it is non-REM stage, and the other, it is rapid eye movement stage. Sleep is very important. How it is very important? Because during the sleep you will have reduced energy consumption and also increase the recovery of the energy storage in the brain, and it will regulate your immune system, and also very important for the memory consolidation and very important in hormonal. That's why when you receive something bad or you have a problem or you receive bad email, all the psychological, they will say to you, please wait for the next day to answer, or get relaxed, go to your home, take shower, take a nap, or if you receive it late evening, wait and reply to the second day. And if you get well asleep at that time, so your action, your response, it will be a different. Why? The reason for that, because there is many things happening in your brain. Hormonal regulation and the change, there is many hormone released during sleep, which is like cortisol, and also the growth hormone, which is very important for our body. Also, the other hormone, which is serotonin and melatonin, to maintain good sleep. The other thing, all of the sleep is very important for our growth and neurological development. So suppose you have poor sleep. When you have poor sleep, quality and the quantity, we mean by that somebody, they will sleep for 10 hours, but the second day, they have a mood swing. It's not a matter of how many hours you sleep. Very important is the quality of that. Somebody, they will go for only stage 1 non-REM and arousal, then go for non-REM, and they stay for that for around 8 hours. So we say they have poor sleep. Some people, they sleep only for 4 hours, and on the second day, they are very energetic. So we can say they receive good quantity of the sleep. And you have to know and to keep in your mind the amount and the quantity, quality of sleep. It's affected by many factors, by your diet, by your physical activity, the day before your sleep, genetic factor, and the environmental is playing the role for that. So if you have poor sleep quality or quantity, it will cause for you many diseases and affecting your cardiovascular, affecting your emotional. So they will get severely depression, and they will have liable to development of the cancer. And they blame the reason for that of releasing irregulation of releasing of some hormonal or affecting on the growth hormone. And it will be liability for getting increase of infectious disease. That's why in the previous lectures, they notice about when you have poor dietitian, you will have increase in the C-reactive protein that indicate a marker for infectious, and also increase in the inflammatory marker. So what is the good food for your sleep? This is a big question, but I will divide it into two. I will divide it into macronutrient, which is carbohydrate, protein, fatty acid, micronutrient, which is vitamin supplement, which is very important. So the food that the people consume not only influence on their wakefulness on the day, but also it will affect on their quality of the sleep. So sleep is not influenced by the energy efficiency of the diet, but also by the content of the macronutrient. So now macronutrient, I will try to make it as simple. What is the relation between our fatty acid and the sleep quantity? First of all, we divide them into three. We have saturated fatty acid, polyunsaturated fatty acid, and we have a trans fatty acid. Usually in normal population from the study, we are consuming more of the saturated fatty acid. Do you think it is healthy for us? Which is usually it will increase the percentage of the energy in the diet, where you can find it in the meat, in the animal fat, and you can find in the cold cut. The other, like dietary sources, which is not natural, like the French fries, the chips, and the cookie, and the sweet, and the food. Why these or saturated fatty acid affect your sleep? They found the reason for that because the fatty acid, it will make competition to cross the blood-brain barrier. So fatty acid, it is a group of amino acid. Important for us is the amino acid like the tryptophan. Why? Because the tryptophan is a precursor for the melatonin, which is responsible to initiate sleep and maintain sleep. So once you have many other amino acids like leucine, isoleucine, so it will compete, so block the blood-brain barrier to transmit the important amino acids, so you will have deterioration in your sleep quality and to maintain. So what is the good thing is polyunsaturated fatty acid. Why? Because it's very rich in omega-3 and omega-6 and also micronutrient like vitamin D. So where you will find it? You will find it in oily fish, you will find it in avocado, in olive oil, and in the walnuts. It will improve the sleep quantity. The reason for that, because once you are receiving polyunsaturated fatty acid, it will release more amino acid, which is rich in tryptophan, and the tryptophan, it is a precursor for a serotonin and the melatonin, which is responsible to initiate your sleep. And this is a hormonal release from the pineal gland in your body. The other thing, the relation between the protein and the sleep quality. A protein, a group of amino acid, and that is very important for you. So it should be percentage. So I noticed the other lectures, especially the vegan people, they concentrate in the protein, but you have to know I should not exceed 16 to around 19%. Why? Because if I receive less than 16%, I will have decreased the availability of the tryptophan, which is responsible for releasing of serotonin, which is a precursor for the melatonin. Okay, so in the other direction, if you receive large amount of protein, it will block also the release of the tryptophan and decrease in the brain serotonin, and will be difficult to initiate the amino acid. The other thing, the relation between the carbohydrate. We have to know we have two things, low carb and high carb. The low carb, it will affect in your REM stage. So some they will go, if they receive low carb diet because they are on diet, usually they will have decreasing going to the REM stage, which is the deep sleep. In compared to the high carb, which is percentage 70%, usually they are study about the carbohydrate with high glycemic index, and they have decreasing in the fiber. In the beginning, they said if you have hyperglycemic index is very high, you will increase releasing more benefit of the amino acid like tryptophan, so it will initiate your sleep. But if you stay for a long time, there is many side effects. Why? Because if you have very high index of, very high glycemic index, it will increase the releasing of the insulin. So you will have hyperinsulinemia. So if I have hyperinsulinemia, it will stimulate releasing of cortisol and the growth hormone, and this you will go for another direction of the other disease. And it will be increase the risk of insomnia. Insomnia, it doesn't mean you are not able to go to sleep. No, either to start sleep or to maintain your sleep with a frequent awakening and arousal. The other thing, it will stimulate other inflammatory markers. So when they do for them study to monitoring of their CRB and ESR, they found it very high and they don't have the symptom. Also, they will have high carb disorder on maintaining of regular sleep and awake. All of that, not only by the diet with the physical activity and also the environmental factor. Now I will go to the micronutrient. We mean by this one vitamin D and zinc and B12, especially the one who is only on a special diet and they forget to take the supplement. So there is many evidence show that supplement certain micro, it will help to promote better and more consolidated sleep.
5 minutes.
Okay, so this is caloric intake. This is one study in Saudi Arabia showing that obesity is more in female, more than the male, but also the male, they have index. It was in 1992, the obesity, it was 10%. The other then after that, it will be increasing to 60% in the female, and then compared to the male, around 40 to 40. And this is, we need to pay attention, and all the government, they are starting to work on that. What is the side effect of the obesity? We have to know there is very bi-directional between sleep and obesity, either in children or in the adult, because it will affect them. They will have poor sleep, causing for them awaking all the time, so they will try to eat, caloric intake, and this, when they have obesity, they will have very poor quality of the sleep. Why they will have very poor quality of the sleep? Because the obese people, they will not get a good quality of the sleep because from snoring, obstructive of the upper airway, and other associated disease. Correlation between that, we have two very important hormones, which is ghrelin and leptin. Each one has a duty. The leptin is ghrelin is responsible for feeling of the hunger, and while the leptin is responsible for feeling of satiety. So once you have obesity, you will have all the time releasing of the ghrelin hormone. So when you can measure it, you will find that's why they are feeling hunger all the time, especially in children. And they will end with a gastric sleep. Really, it is not the solution for that. And this is this is diagram. It is summarize what I said. When you have lack of sleep, you have to check that hunger hormone, it will be more higher, and satiety hormone, it will be decreasing and will lead to more complication. Obesity can cause many sleep disorder, which is obstructive sleep apnea, and you will have nocturnal hypoventilation, and we find many people now, they are using non-invasive ventilation, and also they progress usually to hypoventilation syndrome. This is summarize the inadequate sleep duration and caloric intake. And now we'll go to the coffee, because especially in all workers, they think caffeine,
2 minutes.
Caffeine is consumed by many people, and we have to know it's not only in coffee and tea, in many beverage, in chocolate, and we have to know decreasing taking it. early morning. Avoid taking it 6 hours before your bedtime. Timing of the meal is very important, and the type of the food to fall asleep is very important. You have to avoid many medications that cause heartburn, like spicy food and the other containing stimulant for the children. So the home message from this lecture, you have to know that balanced diet with both macro and micronutrient, it helps you to promote healthy sleep, and the obesity will lead to poor sleep quality, quantity, and subsequently lead to more weight gain. You have to avoid consuming coffee at least 6 hours before sleep onset. Coffee is not only coffee and tea, it is maybe in the chocolate, it is maybe in the power beverage and many soft drink. Fixed, carefully selected light meal, which is 2-3 hours before sleep onset, it will lead to better sleep. And also very important, don't make a lot of change in your time of sleep over the weekend, especially in the children who is less than 18 years of their age. If you want to delay it, not exceeding 1 to 2 hours. We need to change also the light, which is responsible for stimulant for our releasing of melatonin in our kids. And I hope, inshallah, I give you the benefit from that. And nobody should sleep. And when you sleep, you have good quantity, quality of sleep. Thank you.
Thank you, Dr. Wadha, on time. Now, with the next lecture online with Dr. Khalid Al-Ma'atham about sodium, potassium, and renal hemostasis. Dr. Khalid, nephrology consultant, assistant executive director of American study, King Fahd Medical City, associated professor Al Faisal University. Welcome, Dr. Khalid.
Thank you for this kind presentation. First thing, Assalamu alaikum wa rahmatullahi wa barakatuh. And Bismillah ar-Rahim. I would like to thank the organizing committee for the invitation, and special thanks to Dr. Salih Rajhi for his kind communication. It's my pleasure to be here in this great event. And this is the my slides for today. So I have nothing for disclosure. And this is the outlines. I'll talk about the renal functions in general, sodium homeostasis, and potassium homeostasis. So to start with the definition, what's homeostasis? It's the maintenance of total body content at a stable and normal level, even in the face of changes in dietary intake or endogenous production rate. So we have to keep this balance all the time around the clock. And the main functions of the kidney, we have to maintain the balance of electrolytes like sodium, potassium, chlorides, and others. Also, we have to keep the osmolality in check, and this is through water regulation. We have also to regulate the bicarb, which is the main buffer in the extracellular fluid volume. And this is part of the acid-base function. Minerals like calcium, phosphorus, magnesium, balance, and the waste material, the kidney to try to excrete them, like urea coming from protein, creatinine, and uric acid, and other functions. Also, there is some endocrine functions like erythropoietin production, which is important for the hemoglobin in the body, and 1-alpha hydroxylase, which is important to activate the vitamin D in the body. Production of renin hormone, which is important for the regulation of blood pressure and the homeostasis of sodium and potassium. There is some paracrine and autocrine functions like production of bradykinin, prostaglandins, and endothelial factors like nitroxide and water. And by maintaining the normal extracellular fluid volume and the control of the axis of renin, angiotensin, aldosterone, which is important for retention of sodium and the release of potassium from the body, and the production of vasodilatory substances, as we mentioned before, the nitric oxide and others. There is also some other kidney functions, for example, like catabolism of small peptides like insulin. And this is really important. So once the patient start to have renal failure, so we notice that the requirement of the insulin is less, and even in some dialysis patients, they stop taking insulin because the catabolism that usually happens through the kidney is not there. So the requirement for insulin is less than usual. Also, the kidney can produce glucose via gluconeogenesis during fasting. Also, the kidney is responsible for the elimination of some medications, and that's important to keep it in mind when we want to prescribe a new drug for someone who have renal impairment. Another function for the kidney is the normal fluid and electrolyte balance. And as you know, that 60% of healthy adult weight is water, and it's important for normal cellular function, the water, and it's a medium for metabolic reactions, transport of nutrients and waste products. Also, it acts as lubricant and helps to regulate and maintain the body temperature, in addition to many functions that we cannot list because of short of time. So if we look at the distribution of the water in the body, so we know that we have different compartments in the body. So we have the intracellular fluid, which refer to ICF, and the fluids is inside the cells. It's almost 2/3 of the total body fluids is inside the cells, while 1/3 of the body is in the extracellular fluid or outside the cells, and it can be either in the interstitium or intravascular or transcellular. Now, if you look here on this diagram, just if you allow me, I'll use the laser pointer. So once we have an intake, you can see that whatever fluid we take, it will be distributed, and you can see that we have intravascular almost 3 liters and 11 liters in the interstitium, and almost 2/3 of the fluid inside the cells. And you can see here the output. It can be through the kidney, lung, sweating, or feces, or skin. Now, what's the water and the sodium balance inside the body? So what do you mean by balance? It means that whatever we gain, it's equal to the losses. And there's relatively small changes in the sodium, which is accommodated by the changes in the ECF volume or extracellular fluid volume. And this hemostatic responses involve two parts, actually, is the antidiuretic hormone control of water, and this lead to loss or retention by the kidney and thirst mechanism, and fluid exchange between the ECF and the ICF, and I'll explain them in the coming slides. So if you see here in this table, we can see that almost the total body content of sodium is 110 gram, and it's primarily in the body fluids. And we lose the sodium through the urine or sweats and feces, and this is the recommended allowance of daily intake of sodium is only 1,500 milligram per day. And this is important to keep it in mind, that this is the actual need on our daily basis. Now, if we look at the homeostasis of sodium, so for example, we ingest some salt through the food, or we take it IV or whatever, what will happen actually is that there will be rise in the ECF. So usually the normal sodium will be in check between 135 and 145 in the ECF. And whatever we ingest, this will lead to increase in the sodium level, and this will stimulate the hypothalamus, and this will lead to release of antidiuretic hormone. And this will lead to restriction of fluid loss through the kidney, and will stimulate the thirst mechanism. So the person will start drinking water. And once we start to drink water, also the osmolality in the blood will goes up. This will shift the fluid from the intracellular to the extracellular. This leads to lowering the ECF sodium, or dilution of the sodium in the ECF. And then we restore the homeostasis again, because the sodium concentration will drop. On the other hand, once we go out of the homeostasis level by, for example, decreasing the sodium level for whatever reason, this will inhibit the hypothalamus, and any change in the osmotic concentration of the sodium or the ECF by 2% or more, this will lead to inhibition of antidiuretic hormone secretion, and the patient also will not, or the person, I mean, will not have a thirst mechanism. So we start to have loss of water in the urine, and this will lead to reduction in the ECF volume. So the sodium will be more concentrated, and then we will restore the homeostasis in the body. So also the sodium balance, it's well accommodated by changes in the blood pressure and volume. So it's not only the hormones. So for example, if someone ingests a lot of salt and this is retained, what will happen? This will retain fluid and the blood pressure will go up. This will lead to a release of the natriuretic peptide release. This will lead to increased sodium and water loss in the urine, because the sodium, it will drag the water with it in the urine, and this will reduce the thirst and inhibit the antidiuretic hormone, will suppress the aldosterone axis, epinephrine and norepinephrine release. On the other hand, if someone have a drop in the blood volume or pressure, what will happen that we will have a release of antidiuretic hormone, so we will not lose the fluid in the urine. This is like a defense mechanism. So, for example, if someone is hypotensive, we will not lose the fluid in the urine. We'll have a release of aldosterone, and aldosterone will cause retention of the sodium in the body, and also the RAS mechanism or renin-angiotensin system activation to restore the volume and pressure.
5 minutes.
Okay, so for dysnatremia complication, we can see here that if we have a rapid changes in the sodium, for example, if you develop hyponatremia or hypernatremia, if we correct this very fast, what will happen? We will develop complication in the nervous system, and we can have osmotic demyelination. So it's important we correct, especially the chronic hyponatremia if it is more than 48 hours carefully. And look here, this is from the American Heart Association. This is the recommendation about how much is the intake of sodium. So this is the recommended sodium intake. But you can see here that the American people, they take higher level, and they looked from the study, they found that this lead to a lot of complications like a large heart, headache, kidney disease, osteoporosis, and others. So taking excessive sodium on long term is not appropriate. And if you can see here that the relation between sodium and mortality, that sodium, when they looked at this study over 20 years, that there is a relation between the amount of sodium intake and the risk of mortality. It's going up. So excessive salt intake, it's not appropriate. Now we'll move to the potassium, and the potassium, again, balance, it means gain equal to losses, and the daily intake or requirements is almost 100 milliequivalent per day. And the major loss is through the excretion in the kidney. And it's important to mention that if you have normal kidney function, regardless how much potassium you will take, you will not have hyperkalemia, because the kidney is smart. And if you don't take potassium, the kidney will preserve the potassium from secretion, so you will have it in check. So if there is anything that can affect the mechanism, either drug or disease or whatever, then we will not have a good regulation. So the major loss is excretion by the kidney, as I mentioned, and the primary ECF potassium regulation by the kidney, since it's have intake fairly. This is what we mentioned above, and also it's controlled by the aldosterone, so it will lead to release of the potassium in the urine. And also, if we have low ECF pH level, it can cause hydrogen ion to be substituted for potassium, and we will lose potassium in the urine. And the potassium mainly, it is intracellular. This is the concentration in the intracellular, while this is the concentration in the ECF. It is the opposite of the sodium. The sodium is mainly extracellular, while the potassium is intracellular. So whenever we take a large amount of potassium and we absorb it, there will be a rise in the potassium level. This will stimulate the kidney to lose the potassium in the kidney. And once the potassium goes down, there's a feedback mechanism to reduce the excretion of the potassium.
1 minute.
Okay. If we look here, we can see that mainly the potassium is stored in the liver and the muscles. And also there is a new theory that also it's regulated by the brain. So we have different mechanisms to control it. And also it's important for the function of the contractility of the muscles. That's why it's stored in large amount in the muscles. And if we look here, we can see that if there is any abnormality, any one of these, there's a decreased filtration and excretion. If there is decreased or there is decreased excretion from the colonic or cellular uptake, if there is any medication or increased dietary intake and factor that can cause cellular release, we will have hyperkalemia. This is the main functions that, or the main causes that can lead to increase of the sodium. So one of them is renal failure, because once we have reduced renal mass, we cannot regulate the potassium. Another mechanism, if we have abnormality, for example, in the renin, like in diabetic, they have chronic under renin production, or if we don't have aldosterone like in Addison. If we have acidosis or metabolic acidosis, so we will have a lot of hydrogen. That's why the kidney have to release the hydrogen and will retain the potassium. The last one, if we have any medication that can interfere, like non-steroidal anti-inflammatory drugs, calcium inhibitors, beta blockers, directory inhibitors, AS or ARB, low molecular weight heparin, aldosterone antagonist like spironolactone, or potassium-sparing diuretics, or some antibiotics. Just it's important to mention here that if we have hyperkalemia, it's not necessary that we will go through the regular arrhythmia, so we can go from silence rhythm to cardiac arrest in 50% of the patients, so we have to take it serious. And once we have hypokalemia and the level go less than 3, it can be caused by diuretic or aldosterone excess, and this can be manifested as muscular weakness and paralysis. And if we have hyperkalemia with a level above 6, it can be caused by chronic low pH, kidney failure, or drugs that I mentioned can cause increase in the potassium level. This will lead to muscular spasm and cardiac arrhythmia. Just here, this is the last slide. I want to show you here, this is from a study. When they looked at the serum potassium level and the mortality, you can see it like a U-shape. Okay. So it's like a U-shaped mortality. So if it is low or high, you will have increased mortality. So I'd like to thank you for listening, and I hope I was able to show the homeostasis and the effect if we have abnormality in that.
Thank you, Dr. Khalid. On time. Now the third speaker online with Dr. Rana Imara from Egypt, talk about nutrition for serious illness. Dr. Rana, she is a clinical nutrition consultant and clinical nutrition lectures at Alexandria University in Egypt. Welcome, Dr. Rana. Welcome, Dr. Rana. You are in
Yes, thank you. Thank you for the presentation. And I would like to thank you, all the organizing committee, and for inviting me for this prestigious conference. And actually, my talk is about lifestyle intervention for diabetes remission. I'm going to talk about the diabetes remission And how can we achieve this with lifestyle intervention? The American Diabetes Association has considered for decades that diabetes is a progressive disease, and this has changed since 2009, and now we have the term diabetes remission. This term was called reversal or cure, but now it is called remission. In 2009, there was a definition that divided the remission of diabetes into partial or complete, depending on the level of hemoglobin A1C reached, and depending on whether the patient uses anti-diabetic drugs or not. But this has changed recently in 2021, when the American Diabetes Association reached a consensus report about how to define remission. Remission, it is when reaching hemoglobin A1C below 6.5 and maintaining this state for at least 3 months without using any anti-diabetic drugs. The same definition is shared by the British Diabetic Association, and it is extended more than 3 months. They really define diabetes remission by achieving this level of A1C and continuing it for 6 months without also using the anti-diabetic medications. So how can we achieve diabetes remission? There are many ways, and the first notice was that bariatric surgery induces diabetes remission, and it really helps patients to reach diabetes remission. But we are talking about lifestyle intervention, and we are not talking today about pharmacotherapy. Bariatric surgery was the first method that highlighted the possibility that a patient with type 2 can reach remission, and it has a more profound and a more sustained remission, reaching up to 64%. Lifestyle intervention also can be used, and it reaches a lesser degree of remission, but we can use it for also remission. And pharmacotherapy can induce remission in type 2, but the duration is quite variable. How can bariatric surgery reverse type 2? The process of reversal is independent. Actually, it's independent of weight loss. There are hormonal shifts that happens during the surgery, where the GLP-1 secretion increases from the stomach, and this helps increases the insulin sensitivity, decreases the ghrelin, and normalization of the postprandial glucagon secretion. All of these mechanisms help to the patient to lose weight, but actually the type 2 remission starts before even the patient loses his weight. There are histological changes that happens after the bariatric surgery, where the liver and the pancreas lipid content decrease, and this helps the insulin sensitivity to be regained. And also there is a decrease in the chronic inflammation, and all of this improves the glycemic control. Another thing that happens is the alteration of the microbiota in the GIT, and this also helps to improve the insulin resistance. And it's crucial when we think about type 2 diabetes remission is to tackle the twin cycle hypothesis that has been proposed as a pathophysiological mechanism for type 2. Actually, type 2 diabetes is a liver problem. It is when the liver fat accumulation increases, it causes the resistance to insulin suppression of the glucose production, and this will increase the level of insulin. The hyperinsulinemia associated will drive the fat to produce de novo lipogenesis, and the de novo lipogenesis will accumulate the fats in many parts of the body, in many subcutaneous tissue, and one of the sites are the pancreas. And when fat accumulates inside the pancreas, the beta cell, they de-differentiate, and they do not respond to the food adequately, so the acute insulin response decreases, and then hyperglycemia starts, and this is where the patient is diagnosed by type 2 diabetes. So lifestyle intervention is very important, and it aims to decrease the liver fat. And that's why it is important to achieve a huge amount of weight loss, because this huge amount of weight loss really mobilizes the liver fat, it decreases the de novo lipogenesis, and it mobilizes the fats stored in the pancreas, and it gives a relief to the pancreatic cell to redifferentiate and to produce insulin again and to start the process of remission. Well, apart from bariatric surgery, we have many non-surgical interventions for diabetes remission. One of them is the intensive lifestyle intervention. The other is using very low calorie diet using the meal replacements, using low or very low carbohydrate diets, and lastly, the intermittent fasting. The American Diabetes Association, since 2020, have acknowledged the importance of nutrition. And in this consensus report in 2019, it has stated that there are 2 trials up to this date that has shown success in the remission of type 2 diabetes. One is the Look Ahead trial, and the other is the Diabetes Remission Clinical Trial and the Direct Study. The Look Ahead trial is a very long study. It started since the 2001, and it continued for almost 11 years, and it examined about 5,000 participants, and they compared an intensive lifestyle intervention compared to a standard diabetes education. And to highlight that, the Look Ahead study, its primary outcome was not the diabetes remission, but it examined the cardiovascular disease morbidity and mortality. The goal is for the Look Ahead study is to lose weight by 7%, and this was a moderate weight loss goal, and to reach the physical activity to 175 minutes per week of moderate intensity exercise. And again, this was a moderate goal that ensured that the patient does not regain his weight. This amount of weight loss or this amount of exercise does not guarantee that the patient can lose weight. The phase 1 of the study, which was for the first year, and here is the aim was weight loss. They gave the patients an energy, a low calorie diet, which average about 1,500 kilocalories. Of this diet, 30% came from fat and 10% came from saturated fat. And actually the study used meal replacements. For the first 6 months, they replaced 2 meals by liquid shakes, and they gave the patient a snack, and they maintained the meal, the dinner, which was a real food, a plate with food. And they instructed the patient to consume fruits and vegetables. And this was decreased, the level of meal replacement, for the next 6 months during the first year by only 1 liquid shake and 1 snack and 2 meals. And the patients were instructed to increase the level of exercise until they reach it at 4 months to 175 minutes per week. And they were instructed also to increase their basal lifestyle activity to reach 10,000 steps per day.
5 minutes.
A very important component was the behavior modification. This behavior modifications continued to the first year, and the importance for the behavior modification was to reverse the small weight gains and to motivate patient and to cope with dietary lapses and to expand the exercise options. The patients after 4 years, at the first year, they had a remission rate of 11.5%, and at 4 years, the remission rate was 7.3%. In this study. The amount of this remission is not great compared to the second study, which was the direct study. The direct study used total meal replacement and a very low calorie meal replacement protocol, and they examined patients, 149 type 2 diabetic patients for a duration of who had diabetes for a duration less than 6 years and who are not using insulin. They gave them for the 6-month total meal replacements using a very low calorie diet at 150, and they instructed them to drink a lot of fluids and to give a fiber supplement, and here there was no an exercise recommendation. And the aim for this period is to lose a great amount of weight, which was the 15 kilograms recommended. When the patient started direct study, and when you start a meal replacement therapy with your patient, you have to stop all your oral hypoglycemic drugs. You have to stop all your antihypertensive and diuretic drugs, but continue your aspirin, beta blockers, and other cardiovascular diseases, protective drugs. Then they reintroduced food for the second 2 months by giving one real meal that consists of a half cup milk with 90 grams of high protein food, 2 portions of starchy vegetable, and 1 portion of fruit. And still there is no recommendation for exercise. And this is an example for the food reintroduction. And lastly, they maintained follow-up for patients for up to 2 years to ensure that the patient does not regain his weight. And once they regain their weight, they were reintroduced for the meal replacement therapy once again. And this study showed that the patient at the first year achieved 45.6% of remission, and the amount of remission is proportionate to the amount of weight loss. Patients who lose more than 15 kilograms, they had a chance of 86.1% of remission of diabetes.
2 minutes.
What are the predictors for remission in the direct study? Weight loss is the strongest predictor. Early weight loss, higher program attendance, males, those who had fewer anti-diabetic drugs, and those who had low serum triglyceride and GGTs. Those who who did not achieve diabetes remission, those are the people with anxiety or depression, or those who used antidepressant drugs. And why were meal replacements used in these 2 studies? Because meal replacements are of known calorie, they have high protein, and also the carbohydrate is low in glycemic index. But not all studies use meal replacement. We have another study, an important study, which is the U-turn. And the U-turn used an extensive exercise prescription that included a structured supervised physical activity of 420 minutes per week, and a combination of aerobic exercise with strength training. And those patients received 2 coaches that supported them. And also they received a normal diet, a low calorie diet with 45 to 60% of carbohydrates, 20% of proteins, and 35% of fat. And they were instructed to maintain their step counting to 10,000 and increase their sleep duration, and to monitor their dietary habits. And they used a Facebook page group for support. The remission was evident in 34% of the patients at the first year and 23% at the second year. And amazingly, this study resulted in remission only by exercise and not by the dietary changes.
1 minute.
Lastly, I would like to highlight the low carbohydrate diets. And we know that low carbohydrate diets is the diet that contain less than 26% of energy. And in this meta-analysis, in this very recent meta-analysis, they found that low carbohydrate diet compared to low fat diet can achieve remission in 59% of the patients, and they can at 6 months, and 49% of the patient at 1 year. There is no significant side effects of low carbohydrate diet. There is a slight increase of LDL at the first year, but the low carbohydrate diets improve the weight loss, they reduce the medication use, they improve the triglycerides in the 6 months, and all of these effects of low carbohydrate diets are independent also of the weight loss. We should stop all sulfonylureas if we are going to instruct our patient to low carbohydrate diets, and we have to stop the SGLT2 inhibitors and stop the antihypertensive, the diuretics. And lastly, there is still no enough studies about the effect of intermittent fasting or intermittent calorie restriction. Only one study, which was recently published in 2022 from China, on 36 type 2 diabetic patients who were followed by a 15-day cycle of 5 modified day fasting followed by 10-day fasting. They were given 840 kilocalories of a meal that was prepared by the research team, and the 47.2% of the participants achieved complete revision in compared to 2.8. Thank you. And if there's time, I can conclude.
Thank you, Dr. Rana.
Thank you.
Discussion will be in the end of session, panel discussion. Now the fourth speaker online with Dr. Saud Al-Umar, pediatric and adolescent consultant at King Abdullah University Hospital, Princess Noura University supervisor at training and practitioner support program at the Saudi Commission for Health Specialists, founder various of workplace psychological aid program, former 3 years director of the pediatric program at King Fahad Medical City. He will talk about the antidote to provider burnout. Welcome, Dr. Saud.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you for inviting me to talk in this wonderful conference. Actually, my talk today about burnout solutions at personal and also at institute level. I choose this topic, which is elephant in the room. Usually this is said when there is a problem or a big issue that people do not want to talk about or to ask. There's no disclosure. This is just brief about objectives about this talk, just to talk about the concept of burnout, concept of well-being definition, what's the impact of burnout on healthcare providers, also on the institutes, and what are the antidotes at the personal and at institute level. Sorry, this slide is in Arabic. And I think just this is the only slide which is in Arabic, or maybe there's another slide at the end, but all the talk will be in English. العافية أو مفهوم العافية والويل بينج تقريبا هو نفس المفهوم. وأنا حرصت إني دائما أترجم مفهوم الويل بينج على مفهوم العافية. مصطلح دارج بشكل كبير، ورد في حديث النبي صلى الله عليه وسلم في أكثر من 50 أو 52 موضع، من ضمنها بعض الأحاديث اللي قدامكم في السلايد. من العباس رضي الله عنه النبي صلى الله عليه وسلم قال: يا رسول الله علمني شيء نسأل الله عز وجل. قال: سل الله العافية. فمكث أياما، فأعاد عليه نفس السؤال كل مرة النبي صلى الله عليه وسلم يقول: سل الله العافية في الدنيا والآخرة. حديث الطائف: غير أن عافيتك هي أوسع لي، ما سئل الله شيئا أحب لي من أن يسأل العافية، أسأل الله العفو والعافية فإن أحدا لم يعطى بعد اليقين خيرا من العافية. كلها أحاديث تصب على مفهوم العافية، اللي يعني ممكن أقرب مصطلح له باللغة الإنجليزية اللي هو مصطلح الويل-بينج. Mental health is defined as more than by the WHO, it is more than absence of mental health disorders. And also the well-being is defined as a state of mind in which the individual is able to realize his or her own abilities to cope with normal stresses. That means there are normal stresses that we face in our life, either in our personal, social, or even career life, and can work productively and thoughtfully and is able to make a contribution to his or own community. So if one of these are compromised, so we are losing our well-being, and maybe we are going in the stress or more in burnout. A key component of individual mental health is the ability to adequately fill his or her own role, including capacity to work. Mental health problems such as depression, anxiety, stress, they are very common, affecting the individual their families and co-worker and broader community. What are the prevalence in general? And by the way, most of these numbers, they are before Corona. After Corona, all numbers has double and triple. But those are some numbers. 121 million people suffer from depression. At any given time, 450 million people are suffering from some form of mental or brain disorders. 37 million they are suffering Alzheimer's disease. 50 million from epilepsy. So mental health disorder, they take a large number or large portion of a disease that affect people and their work. Again, one of the studies showed that 18.2 of employed people had evidence of mental health disorder which impaired their work performance in the previous 30 days. As we said, this is the number before Corona. After Corona, depression has doubled, anxiety has tripled, and also suicidal ideation and suicide has also doubled than before Corona. What is burnout? احتراق الوظيفي, احتراق النفسي. It is a special type of job distress with the state of physical, emotional, mental exhaustion combined with doubt about your competence and value of your work. It is exactly the opposite or the polar opposite of engagement, اللي هو الاندماج الوظيفي أو الحماس. So it is the other opposite polar of burnout. How big it is? A lot of studies, either here in Saudi Arabia or after. يعني in 1976 or 1979, there was just very few papers, يعني around 5 or something like this about burnout. In 2018, it reached more than 2,500 papers. Again, this is before Corona. After Corona, the papers about burnout, it reached more than 5,900. So there are a lot of studying the prevalence of burnout, its impact, its causes. One of the studies, again before Corona, it shows that more than half of US physicians experience substantial symptoms of burnout. And again, also before Corona, there was the report that stating that every day there is one physician committing suicide in the state. Locally, many studies showed that burnout, either in medical or non-medical, even in the industry. I have seen some study in the industry section showed that their burnout reached about 60% in their field. So it is also common in non-health organizations. One study we have done among healthcare trainees, it showed that the burnout reached up to 56%. What are the causes? Usually there are a lot of causes, but to make it simple, we use the job demand and resources balance model. Showed that if there is less resources and more demand, the burnout will increase. Just some example of resources like the culture in the institute, job control and autonomy, relationship, social support, meaning at work and rewarding, admin support also. The demand like excessive workload, admin burden or administration burden, workflow interruption, client factor, moral distress, السياسات واللوائح تبع المنشأة, electronic health records, all are demands. If it increased, the burnout also will increase. Again, this is another example of the model. This is some list of the some of the causes like role ambiguity, role conflict, lack of recognition at work, inequity, poor interpersonal relationship, poor working condition. Excessive workload and loss of control is one of the top of professions cited as the top reason for burnout among physicians. Work politics, again, also it will cause work-family balance or integration failure, especially at Corona when their working was remote or online. So there is no clear cut between work and family time, because sometimes you might get some emails or some online online meeting after working hours, like after 6 p.m., 7 p.m., 8 p.m. So this is one of the causes. Those are some symptoms like physical, emotional, behavioral. You feel tired, drained, low immunity, sense of failure, self-doubt, detachment, يكون في نوع من العزلة, decreased satisfaction, behavioral also, procrastinating or tasweep. We need to protect the workforce that serve our clients. What are the consequences? There are a lot of studies that focus on the consequences on the healthcare provider, on the institute, also on the client. It will affect the quality, risk of medical malpractice. This is one of the framework that give overview about the burnout. There are some environmental factors, some drivers, then the process, what happened exactly, then the outcome will affect the worker. Sorry, maybe it's not that clear, but this is the just overview about the model, how the burnout affect people, affect the community, affect the organization, and also affect the society. On the patient care, decrease compassion, increase hostility, affect the decision making, because increased level of cortisol and stress will affect the prefrontal area, which is involved in the decision making. Medical errors also increase absenteeism. 35 to 45 of absenteeism from work is due to mental health problems. حتى even if they brought that they have some kind of organic or somatic symptoms.
5 minutes. 5 minutes. 5 minutes.
Okay, so it will affect also reduce the productivity. Why we care? Quality of life program, VRO workforce initiative across the 5 components. They focus on well-being. Also, there is also VRO of MOH. They focus on well-being, promote workplace physical and mental health, and decrease burnout by 50%. Improve satisfaction score, increase productivity, improve patient quality of care. Many professionals, they are reluctant to acknowledge that they have a problem, as we said, elephant in the room. There are some national and international examples. Google, Starbucks, they have mental health program to support their employees. Stanford, also Johnson and Johnson, Intel company. Here هيئة مثلا سوق المال, الهيئة السعودية مثلا في برنامج داعم, which is a psychological support for all healthcare provider and trainee. These are some what they said about داعم and feedback and impact. It was a great alhamdulillah impact. Level of intervention, prevention, intervention. What we can do at personal level, there are a range of ways that we can help to increase the resilience. يعني بالله سبحانه وتعالى تتابع الصحة, العافية, تبعد عن السلبيين المتذمرين, تذكر قيمة كممارس أو متدرب قيمة الآخرين. Meaning at work, to connect with others, don't isolate yourself, be active, take notice, mindfulness, meditation. Also this will help give others without يعني عطاء بلا مقابل, volunteerism also, keep learning some strategies, good healthy lifestyle, balance exercise, sleeping is very important, which is a big issue for our trainees and healthcare worker. Also the relationship and the support with the families, meaning at work. What we can do at institute level, على مستوى الإدارات, make mental health strategic priority, enable sustainable work model, improve access to resources, create supportive growth environment, eliminate toxic workplace behavior. وبالمناسبة, there is a report from McKinsey, the company, that they talk specifically about the toxic workplace behavior between the manager and their employee, which is very prevalent and affect their mental health.
1 minute.
Eliminate stigma around mental health, hold management accountable, foster inclusivity and belonging. This is a model by the US General Surgeon about the framework for workplace focusing on protection from harm, connection and community, work-life harmony, mentoring at work, and opportunity for growth, which is good to be applied. What we can say, happy organization is a successful organization. Thank you very much.
Thank you, Dr. Saud, on time. Now, with fifth speaker, Dr. Hamdan Al-Baghawi. Dr. Hamdan, he is a professor at the University of Ha'il, Saudi Arabia, College of Nursing. He served as Vice Dean of Academic Affairs and Dean of the College of Nursing for several years. He will talk about life medicine intervention for optimal health. Welcome, Dr. Hamdan.
السلام عليكم. سعد الله صباحكم جميعا. في البداية أنا سعيد بالمشاركة صراحة في هذا المؤتمر الجميل. جزيل الشكر والعرفان للدكتور والزملاء دكتور فرحان والدكتور صالح وطاقهم المميز على هذا التحضير والتجهيز لهذا المؤتمر الجميل. قبل عدة سنوات حضرت دورة تدريب المدربين اللي هي TOT أو Training of Trainee. كانت الدورة عبارة عن 12 يوم. كانت مع المبدع ياسر حزيمي وهو من المتحدثين المميزين. فكنا من different specialty. We are requested also to give an advice in one word, in Arabic word, and each letter indicating something. فطبعا أنا تكلمت كتبت مفترق. قلت إنه نسمع الآن كثير من الناس يعني أعمارهم 30 سنة و40 سنة ويصير عندهم جلطة ويصير عندهم diabetes وهايبرتنشن و a lot of diseases. كذلك استندت أو ذكرت حديث الرسول عليه الصلاة والسلام حينما قال أعمار أمتي من 60 إلى 70. فلو أخذنا متوسط 60 سنة, the first 20 years you are a student and you are doing very hard. The second 20 years also you are working very hard and building yourself. The last 20 years is the period that you have to enjoy your life without a disease. So it's your decision whether to spend it with your family, with a great health, traveling, enjoying, or you're gonna spend it in hospitals and taking a lot of مواعيد و X-ray و a lot of things that you can take your decision right away. Unfortunately, the big food company and food industries are tricking us by replacing the fibers which we needed in our food by sugar and a lot of sugar. And I don't have to ask why, because you know the reason why they are replacing it with sugar. They want us to consume their products a lot and a lot. عشان كذا هم يشيلوا الفايبر أو الألياف الموجودة في الطعام. الله سبحانه وتعالى خلق الطعام فيه فايبر, وإحنا نعرف benefit of this fiber. It's going to reduce the absorption of sugar, so our sugar will not goes very high. That's why they are taking the fiber and replace it with sugar in order to consume a lot of their products. عشان كذا يمكن كلنا نحس لما تحس بالجوع وتاخذ وجبة أو sweet, after 1 hour you feel hungry, يجيك جوع شديد جدا, وذلك بسبب ارتفاع السكر بشكل كبير وانخفاضه بشكل أسرع. This diagram showing the insulin resistance, and my mashallah colleagues, they cover it. بس يعني الادفايس we always saying try to avoid sugar as much as possible, otherwise you will end up having an insulin resistant and that could affect your health. يعني حتى لو كان الانسولين من حديد لا بالية بعد 10 أو 20 سنة، فما بالك يعني ب human being. أيضا أنا أشبه الخلية والأنسولين زي المدمن اللي بالبدايات يأخذ جرعات بسيطة من الدراجز، then later on it doesn't satisfy, he will request more of the drugs, وهذا يأثر بالطبع على الأنسولين وعلى البنكرياس وعلى أعضاء الجسم. These are different names of sugar. اختلفت الأسماء والمادة هي نفسها، جلوكوز، فركتوز، جلاكتوز، مالتوز وغيره من الأسامي الكثيرة الموجودة في المنتجات. طبعا منظمة الصحة العالمية أوصت أن الاستهلاك اليومي من السكر لا يزيد عن أكثر من 10%، وهذا يعادل تقريبا 50 جرام أو من 10 إلى 12 جرام من السكر. طبعا الكين أو الصودا الواحدة احنا نعرف that contains around 8 to 10 spoon، فأنت لو تأخذ بيبسي أو كولا أنت تقريبا you consume your daily limit of sugar. This diagram showing the high glycemic index versus the low glycemic index, and that's what we mentioned before. If you consume sugary food, that will rise your blood sugar, and otherwise if you will take low glycemic food, your sugar will be steady and will continue stable and steady. These are different category of foods that we have to focus, whether it's low, medium or high. عشان كذا دائما أخصائي التغذية ينصحونا أنه نستخدم البذور الكاملة، المكسرات، الناتس، البقوليات، الخضار، وأيضا الفواكه والحليب واللبن. عند اختيار أي منتج قرارك في السوبر ماركت، your decision in the supermarket, it affects your health, it affects your family health as well. That's why it's important to check the content and to compare which better for your health. For example here عدد الحصص تقريبا 8، ولتكن 8 حبات بسكوت أو كيك أو whatever. الحجم الحصة الواحدة ثلثين الكوب تقريبا، وهذا ما يعادل 55 جرام. نشوف هنا كميات السعرات الحرارية which is 230 which is very high. في أشياء طبعا لازم احنا ننتبه لها تكون عالية، وفي أشياء لازم تكون low. فمثلا الدهون الكلية هنا 10%، الدهون المشبعة، الدهون المتحولة والكوليسترول. طبعا هذه من الأشياء اللي we try to avoid it as possible because we know that it causes a lot of heart problem and atherosclerosis and others. أيضا الصوديوم أو الملح من الأشياء اللي try to avoid it as possible. هنا مجموع الكربوهيدرات 37 جرام، الألياف الغذائية طبعا 4 جرام، وهذه من الألياف من الأشياء المهمة اللي يجب أنها تكون المنتجات محتوية على أكبر قدر من الألياف. مجموع السكريات هنا ذاكرين 12 جرام which is not true or fake because if we look for the carbohydrates it's 37, and if we take the fibers from it it's gonna be 33 gram, which is this is the total sugar in that food. If we want to know how much sugar on that product, we divide it by 4, and that give us around 8 spoons of sugar, which is very high. Also, you have to look to the other nutrients like protein, vitamin, calcium, iron, and potassium, which is very important to be very high. الهيئة العامة للغذاء والدواء أصدرت بطاقة تسوق للأغذية السائلة والصلبة، وتقدر تشوف من خلالها كمية هل الكمية بالنسبة للدهون والدهون المشبعة والسكر والملح، هل هذه الكمية منخفضة أو متوسطة أو عالية. that give us an indication about the content. The worst food, I think we start with hydrated oil. للأسف أغلب البيوت ما زالت تستخدم الزيوت المهدرجة، أيضا المطاعم. we know that causing or rising the cholesterol, atherosclerosis and heart disease. كذلك المشروبات الغازية، الصودا وغيره والبيبسي والسفن اب. المشكلة ليس في فقط كمية السكر الموجود فيها، احنا مثل ما ذكرنا يمكن فيها 8 ملاعق، لكن أيضا كثير من الناس يأكلوه مع الوجبات، ونعرف أنه المعدة عند الأكل تفرز عصارة حمضية، والمشروب الغازي هو عبارة عن قاعدي، فأنت لما تشرب المشروب الغازي أنت تعادل الحمضية، فكذا أنت ما استفدت من عصارة المعدة.
5 minutes.
المقليات طبعا تفرز مادة الأكريلاميد، وهذه مادة سامة. الجبن السائل أعتبر أنه من أسوأ الأغذية الموجودة في المنازل. كثير من الزيوت المهدرجة، والربع أو الثلث تقريبا زيوت أو جبن أو شبيهة بالجبن. الخبز الأبيض احتواء على السكر والجلوتين، حبوب الإفطار، كورنفليكس، وللأسف أغلب أطفالنا يتناولون الكورنفليكس كل صباح. اللحوم المصنعة على احتواء على الأملاح والملح الصيني كما يقال، فراخ البطاطس والشيبس، الآيس كريم. الأغذية أيضا تحتوي على ألوان صناعية ومواد حافظة، وأغلب المنتجات تحتوي على هذا. few weeks ago, my little daughter came back from the school and she shows me what her teacher gave her, and I really feel shocked. لأنه هذا مؤسسة تعليمية يفترض أنه تقدم للطفل الشيء المفيد، ولكن مثل ما تشوفون أنت يعني عبارة عن salt وشجر وألوان صناعية، خصوصا المنتج الأخضر هذا كله ألوان صناعية ومواد حافظة. The best food يعني يفترض أنه everybody of us should include one of these foods. الأفوكادو مصنع أو مخزن من الألياف والمعادن والدهون وغيرها. الشوكولاتة السوداء، البروكلي، الناتس، الفيجيتابلز، كلر فيجيتابلز، الجرين تي، بلو بيري، سي فود. البيض كان من للأسف الأغذية اللي كانت مظلومة لسنوات، الآن أغلب الأبحاث توصي وأغلب النيوتريشنز يوصي باستهلاك البيض بشكل مستمر. الزبادي، الليمون، زيت الزيتون والخل. في أيضا فوائد التمارين. الساركوبينيا أحد المصطلحات الطبية التي تعني أنه يحدث ضمور العضلات بعد سن 40 أو 50. الإحصائيات تقول أنه بعد سن 30 أنت تفقد تقريبا، أو كل 10 سنوات تفقد من 8 إلى 10% من اليور ماسلز. عشان كذا تشوف بعض الناس عمره 40 سنة جسم، بعد 60 تلقاه عظم وجلد، فهذا الساركوبينيا. أيضا 70% من الناس الكبار أو أعلى من 65 يسقطون ويموتون، وهذه عايشناها في كثير من الأقرباء. طبعا الهرمونات كثيرة التي تفرز، دوبامين، اندروفين، سيروتونين، التستيرون، وهذه كلها تؤثر عليك جسديا ونفسيا وغيره. If you are over 40, you don't have a belly, you are one of the top 20 of the population. If you lifting iron, lifting weight, you are top 5. If you are doing cardio weekly, you are one of the top 2. And if you are eating healthy, you are from the top 1. Advices in very fast. طبعا التحاليل للأسف احنا ممكن نشيك الواحد على سيارته أكثر من ما يشيك على تحاليله وعلى صحته، فالأفضل أنك تشيك كل 6 شهور. زيارة الأسنان وطبيب الأسنان وبشكل دوري. أيضا تجنب السهر والقهوة وأيضا استخدام الجوال، خصوصا بعض الناس يخلي الجوال شغال عند راسه ونعرف تأثيره أنك ما راح تصل للنوم العميق. تجنب الطعام المحروق، وعرفنا المواد السامة. اختر بدائل الصحية للملح مثل الليمون. اتبع نظام الصيام المتقطع، وهذا عرفنا فوائده كثيرة. أحد الدراسات أشارت أنه ليش الكانسر مو منتشر بالدول العربية وإحنا we consume a lot of sugar، وطلع أنه صيام شهر رمضان سبحان الله هذا يعطي ريست للجسم، فالصيام جدا مفيد. تجنب البلاستيك، للأسف صار البلاستيك جزء من حياتنا. المضادات الحيوية والمسكنات، وهذا للأسف we consume it، نتعامل معه زي المكسرات. أغلب الناس يمكن يأخذ الأنتيبيوتيك without asking the doctor. الإكس راي للأسف في بعض الناس يجي he requested X-ray although it's not important or it doesn't need it but he requested. المكملات الغذائية طبعا والكولاجين. أيضا الكولاجين من المنتجات اللي اعتبر أنها ضرورية بعد عمر 40 سنة، لأنه تقريبا بعد 30 أن تخسر 3% من نسبة الكولاجين، وصعب أنك تعوضه من الأكل. تجنب أكل المطاعم، ومثل ما ذكرنا أنه يكون فيها الكثير من أحادي جلوتيات الصوديوم. تجنب المواد مثلا الشامبوات، في كثير من السولفات، وهذا أحد المنتجات الكيميائية يعني تسوي رغوة ولكن لها تأثير سلبي على الهرمونات. فمثل ما أنت you pick up a healthy food you have to pick up المنتجات الشخصية بشكل carefully. الباربنز أيضا من المواد اللي هي من الريزيرف، وأيضا لها تأثير سلبي على الجسم تسبب السرطان. البوليثيلين جلايكولز أيضا مادة بروتينية تستخدم للشعر وأيضا تؤثر سلبا على فروة الشعر، فعند اختيارك للشامبوهات تأكد عدم وجود هذه المواد. أيضا في موانع التعرق زي الألمنيوم، هذه تسبب السرطان. والثايليت أيضا مادة مثبتة وتسبب السرطان. وكذلك في معاجين الأسنان، يعني الفلورايد مهم ضروري جدا، ولكن يعني أنا أعتبر أنه مجرد أنك أنت ما تسوي brushing your teeth after each meal مع الخيط أتوقع أنه كافي. These يعني some of the products that I usually use. من اليمين الشامبو هذا، ومثل ما نشوف أنه ما في سلفات، ما في جلوتين، ما في باربنز، خالي من جميع المواد المضرة. على اليسار أيضا من المنتجات اللي مانعة التعرق وفيها free of aluminium وباربنز، المواد أو اللي ذكرناها. في الوسط الكولاجين، واعتبر أنه supplement ضروري، وأنا شفته استخدمه شخصيا، وشفته في الأظافر والشعر يعني، وأيضا المفاصل. هنا المعجون الأسنان، وخالي أيضا من السلفات والجلوتين. These are my best two scientific. دكتور ديفيد سينكلر، وعنده كتاب مشهور. He is he is a professor in Harvard Medical School. وأيضا إريك بيرغ، he is also dietitian، وله مقاطع كثيرة على اليوتيوب. This is my reference. في النهاية نتمنى لكم حياة سعيدة ومديدة إن شاء الله، خالية من الأمراض بإذن الله تعالى. شكرا لكم.
Dr. Hamdan, he is my best friend. He looking to me to help him about time. I said for him, you are in time. Now the last speaker, Dr. Nibal Abdurrahman. Dr. Nibal, she is a clinical nutrition professor at Cairo's National Nutrition Institute and the general organization of teaching hospital and institute. She will talk about carbohydrate and diabetes mellitus. Welcome, Dr. Nibal.
Bismillah ar-Rahman ar-Rahim. First of all, I would like to thank Professor Dr. Salah al-Rajhi, all scientific and organized committee for their great effort and giving me this great opportunity to participate in this important conference and to visit the lovely city Ha'il. My talk is carbohydrate and diabetes mellitus. What is the latest evidence? As all you know, that type 2 diabetes, with increasing prevalence of overweight, obesity, and sedentary lifestyle, there is a marvelous increase in the prevalence of type 2 diabetes, not only among adults, but also among children and adolescents. And now type 2 diabetes seen in children. Before it was an adult disease, but now seen in all age groups. And there is a big debate about carbohydrate percentage recommended for type 2 diabetes, and this is why we try to present the latest evidence about this topic. Type 2 diabetes, as you know, is a multifactorial disease, and diet quality and quantity considered at the heart of its pathogenesis. So we have to put this in mind. And according to American Diabetes Association 2023, the strong evidence support the efficacy and cost effectiveness of dietary therapy as a component of quality diabetes care and its integration of the medical management of diabetes. And from the recent guidelines, the most important recent guidelines, that the most challenging part of the treatment is to determine how and what to eat and following a meal plan that should be individualized according to nutritional assessment. And each person with diabetes should be engaged in self-education, self-management and treatment planning with her or his healthcare team. Also, there is one important conclusion stated 2023 that there is no single ideal distribution of calories among carbohydrate, protein, and fat. It should be individualized, and we're keeping in mind total calories and metabolic goals. As all you know, carbohydrate is divided into simple or sugar and complex carbohydrate or starch. We recommend for diabetes to take low glycemic index complex carbohydrate to receive the adequate amount of fibers, same as general population. The term carbohydrate may be confusing to many consumers and healthcare providers because a lot of terms related to carbohydrate. We sometimes simple carbohydrate, complex carbohydrate, high carbohydrate diet, low carbohydrate diet, glycemic index, glycemic load, carbohydrate counting, insulin carbohydrate ratio, correction factor, all these terms are related to carbohydrate, so we have to teach them how to use this term. However, carbohydrate is the key strategy in managing diabetes. It is responsible for early postprandial glucose rise. This is not mean that protein and fat are not important. They are responsible for late postprandial high glucose rise. So why we focus on carbohydrate? Because early postprandial, within 2 hours after eating, carbohydrate is the responsible for it. And carbohydrate enters the bloodstream within 5 minutes after eating, or 5 to 15 minutes. When we eat carbohydrate, about 100% of all carbohydrate converted to glucose within 2 to 2.5 hours, while protein start to enter the bloodstream after 45 minutes and converted only 50% converted to blood glucose within 8 hours, while fat only 10% of fat we eat converted to blood glucose. But however, as nutritionists, we have to count all carbohydrates, whether healthy or unhealthy, whether simple or complex, because all will convert it to glucose in the blood and should be covered by anti-oral medication or insulin, whatever the person uses. This is the recent distribution of calories according to American Diabetes Association. We recommend up to 45% of calories from carbohydrate, up to 40% from fat, but it's healthy fat choices from monounsaturated and omega-3 fatty acid, and up to 20% from protein. keeping in mind total energy intake and weight management goal and metabolic goals, as we said, like glycemic target, lipid profile, hypertension. We have to keep in mind part of physical activity, food preferences, availability. All this we have to put in mind when we plan diet for a patient. The key strategy of achieving glycemic control, first of all, we have to estimate the current carbohydrate intake, followed by individualized guidance to how to self-monitoring your carbohydrate intake. We use a lot of methods of dietary assessment, like 24-hour recall, food frequency, food dairy, whatever. We have to, all this, we have to teach a patient how to use it and to estimate his current and to self-monitoring his carbohydrate intake. And we have to be assured that he receives the recommended amount of fibers, at least the same as the general population. Carbohydrate restriction is not new term in these years. It is since long time before discovery of insulin. The recommended diet was high fat, low carbohydrate. في أواخر السبعينات والثمانينات بدأوا there is increased preference of cardiovascular disease and the diet prescribed for type 2 diabetes to be low fat and high carbohydrate, and this يعني continues for a long of years. آخر 15 سنة a lot of meta-analysis and randomized control tried to prescribe low carbohydrate diet for achieving glycemic control. واخر حاجه بقى الامريكان دايابيتس اسوشيشن في 2019 اعلنت two important statement في الكونسنسس بتاعتها. اول حاجه low carbohydrate or reducing overall carbohydrate is most evidence for improving glycemia, بالذات في حالتين مهمين جدا. لو there is a priority to reduce anti-diabetic medication and there is no achievement for metabolic control، في الحالة دي بنستخدم اللو carbohydrate diet عشان to control his diabetes. طبعا ده الهيستوري بتاع الكربوهيدرات انتيك اللي احنا قلناه. طيب المشكلة إيه؟ إن في confusion about what is the low carbohydrate diet. اللو carbohydrate diet ranged من 5% up to 10%، ودي اللي بيقولوا عليها ketogenic diet، ودي is not prescribed for diabetic which is dangerous for them. up to 35% برضو دي تعتبر low carbohydrate. هنشوف ال definitions المختلفة. ال very low carbohydrate less than 10% of carbohydrate or 20 to 50 gram per day. This is not recommended at all for diabetic. Low carbohydrate less than 26 carbohydrate or less than 130 gram per day. المودريت كربوهيدرات دي اللي احنا بنوصفها دايما وهي دي الكومن اللي بنستخدمها من 26% to 45%، والهاي كربوهيدرات above 45%. But also there is another factors we have to consider when determine the percentage of carbohydrate, which is the age. كل ما بنكبر كل ما بنحتاج كربوهيدرات اقل. السكس طبعا ميلز بيتحركوا وعندهم ميتابوليك ريت اعلى فبيحتاجوا اكتر. الويت طبعا كل ما ازيد في الويت احتاج كربوهيدرات اقل. الفيزيكال اكتيفيتي كل ما ازود الفيزيكال اكتيفيتي احتاج كربوهيدرات اكتر. ممكن اللي بيحب كربوهيدرات يزود الفيزيكال اكتيفيتي. وطبعا الميتابوليك جولز، يعني مثلا لو حد عنده هايبر ترايجليسيريديميا لازم يقلل الكربوهيدرات خالص، لان اي كربوهيدرات ممكن تتحول لترايجليسيرايد. فكل الفاكتورز دي بنحطها في الاعتبار when we plan diet for them. طبعا في اللو كربوهيدرات دايت كان بي ابلايد ان ا فرايتي اوف ايتنج باترن، هنستعرضهم كده ممكن كلهم ممكن يستخدموا. اول حاجه الميديترينيان ستايل، وده a lot of systematic review and randomized control diet بتقول ان الميديترينيان دايت طبعا هي بتعتمد على البلانت بيست دايت، هول جرين، ليجومز، نون ستارش فيجيتابلز، فروت، اللين ميت زي الفيش والناتس والاوليفز، والليست او مينيمايز as possible as we can الريد ميت. وليها potential benefit reported على بتقلل risk of diabetes، hemoglobin A1C reduction، بتقلل triglyceride، بتقلل risk of major cardiovascular events.
5 minutes.
اوكي. بالنسبه لللو كربوهيدرات باترن ده بريسكرايب باي يونايتد ستيت ديبارتمنت اوف اجريكلتشر اللي هم كرييت الدايابيتك بليت، وبرده ليهم تاثير على الهيموجلوبين A1C ريدكشن، الويت لوس، اللور بلاد بريشر، الاتش دي ال بيزيد والترايجليسرايد بتقل. الفيري لو احنا قلنا كريتيكال سيتويشن مش بنقدر نوصفه للناس كلها. اللو فات برضه باترن مش يعني اقل من 30% توتال كالوريز فروم فات، والفيري لو اقل من 10%. في الداش دايت برضه دايتري ابروش تو ستوب هايبرتنشن بيستخدم برضه ليه بنفيت افكت. الفيجيتيريان او الفيجان طبعا مش لكل الناس، والباليو ليها دراسات قليله جدا عليها. المهم ان الايفيدنس بيقول to prevent diabetes or to manage pre-diabetes احسن dietary patterns اللي هو الميديترينيان واللو كارب واللو فات ايتنج بلان. وبالنسبه دول كلهم بيشتركوا ان بيدي نون ستارش فيجيتابلز، بيقلل الادد شوجر والريفاين جرينز، بيستخدم الهول فود اوفر ذا بروسيسد في كل الدايت بلان بتاعه. اما بالنسبه للتايب 2 دايابيتس معظم كل الراندمايز كنترول ترايل قالت ان الميديترينيان ستايل هو احسن حاجه ليه تاثير على كل الميتابوليك كولز بتاعت الدايابيتس. طبعا في a lot of studies ما فيش وقت ليها، انا بستعرضها اللي حد يطلع عليها دي سبورت البرزنتيشن بتاعتي. مهم جدا ان انا اخد بالي ان احنا يعني البيست ريكومنديشن فور تايب 2 دايابيتس من 26 ل 45. اللي بيقلل قوي عن كده في ديس ادفانتجز لو كربوهيدرات، في لونج تيرم ديس ادفانتج لو كربوهيدرات دايت ليها تاثير على الرينال فانكشن، كالسيوم ابزوربشن، لاك اوف اسينشال نيوترينز، وكارديو فاسكولار ريسك. كل الدراسات والميتاساليسيس بتقول ان هي ليها significantly higher risk of all cause mortality. ممكن تعمل هايبوغلايسيميا، ممكن تعمل كيتوزيس ويتحول لاسيدوزيس ويورينري كالسيوم لوس ولو بون مينرال دنسيتي واوستيوبوروز. we have to take care when we prescribe low or very low carbohydrate diet for people. We have to differentiate between low carbohydrate diet and no carbohydrate. When we tell the patient you have to take low, this means that you can take legumes, cereals, non-starchy vegetables, but high carbohydrate ده traditional الميل بتاعتنا كعرب، طبق رز كبير، طبق مكرونه كبير، عيش كتير، ده طبعا we have to avoid. ده الدايابيتك بليت هو ده اللي احنا بنقول عليه، وده نصه نون ستارش فيجيتابلز والنص الثاني هيلثي بروتين اند هول ستارش او هول جرين ستارش. We have to avoid these plates, please. Not only diabetic, all people should avoid this pattern of eating.
3 minutes.
Conclusion, today the evidence suggests that low carbohydrate diet are effective for weight loss and improvement in glycemic control and cardiovascular risk reduction, but they are not superior to other dietary approaches. It is suggested that low carbohydrate diet appear to be safe and effective over a short term, but show no statistical difference from control diet with higher carbohydrate content and cannot be recommended as default treatment for people with type 2 diabetes. Whether people choose to follow a low carbohydrate diet or not, they should be encouraged to include foods with good evidence to support health. This includes fruits, non-starchy vegetables, whole grain, dairy, seafood, pulses, and nuts. And people should be encouraged to reduce their intake of red meat, processed meats, sugar-sweetened food, particularly sugar-sweetened drink, and refined grain as white bread. Thank you very much for listening.
Thank you for Dr. Anibal. Now, panel discussion. Any question about this session for our speaker today? Second session.
يعطيكم العافية جميعا. أنا بس عندي اقتراح إذا كان الأخوان في اللجنة العلمية يضمنونا في المقترحات، هو إنشاء قناة إعلامية يعني تحاكي عامة الناس. احنا لازم ننزل إلى المستوى الإعلام الحديث بالسناب شات والتيك توك، ونرسل الرسائل هذه للأمهات والأولاد والأطفال، ومن يتابع هذه القنوات يعني الإعلامية في مقاطع صغيرة يعني 5 دقائق 4 دقائق. كل هذه الرسائل اللي سمعناها اليوم وأمس وفي الأيام القادمة أتمنى صياغتها يعني بصيغة حضارية سهلة ممتعة، الجميع تصل هذه الرسالة. وأعتقد المتحدثين اليوم متميزين جدا، يعني لو تكاتفوا بيطلعون منتج متميز يحاكي مجتمعنا وخصائصنا وطبيعة حياتنا. والأمر الثاني لا يمنع يكون لها دعم، يعني أعتقد مجرد ما يكون هذه القناة موجودة راح يكون فيها داعمين، ونستفيد من هذا الدعم في يعني تعزيز الصحة العامة على مستوى الفرد والمجتمع.
شكرا لك دكتور صالح. اقتراح وجود قناة للسوشيال ميديا. دكتور صالح الراجحي. أعطيه الميكروفون. وجود اقتراح لقناة السوشيال ميديا تتضمن المعلومات اللي وردت في المؤتمر لتصل لأكبر طبقة وشريحة من المجتمع.
طبعا اقتراح جميل جدا من الدكتور سعد البتال. في أيضا ناقشنا الموضوع مع الدكتور ناصر الجهني أمس، بحيث أنهم يدعمون موقع الطب نمط الحياة يدعم مجلس الضمان الصحي، يدفعون التكاليف حقته بحيث ننزل فيها الكتب على شكل PDF، وأيضا ننزل الرسائل. لكن ما نستغني عن الزملاء في العلاقات العامة والإعلام في المديرية لإنزال المقاطع القصيرة هذه، لأن عندهم التكنيكال نو هاو ومتميزين جدا في العمل هذا.
ممكن تكون من التوصيات يعني من توصيات المؤتمر؟
إيه إن شاء الله بإذن الله تعالى. اليوم عندنا بيصير 3 توصيات، اللي هو medically prescribed meals، والثاني اللي هو meal planning through the retail stores، الثالث اللي هو الرسائل التوعوية اللي ذكرها الدكتور سعد.
دكتور فرحان.
شكرا دكتور صالح. السلام عليكم ورحمة الله وبركاته. جزيل الشكر صراحة للخبراء والمتحدثين والعلماء، والمحصل اللي أو المقترح اللي اقترحه الزميل، وجود قنوات تحاكي جميع الفئات المجتمعية. فنحن أحيانا ننظر للسوشيال ميديا أنه دائما هي مصدر خطر يجب أن نحذر منها، وهي موجودة في أيدينا وأيدي أطفالنا، فيجب أن نزاحم الشر بالخير. لذلك أنا أعتقد أنه يجب أن نسير في مسارين: مسار سريع وهو من خلال منصة المؤتمر أو المواقع الخاصة بالمؤتمر للرسائل اللي صراحة ذات القيمة العالية والسريعة، لكن نحتاج إلى استدامة في هذه القنوات. فالاستدامة تحتاج إلى مظلات رسمية مثل الضمان الصحي أو الجهات الأخرى في الوزارة أو الهيئات الأخرى. ممكن تكون التوصية توصية لوجود استدامة لتوصيل أو نقل توصيات أو معلومات الخاصة بطب نمط الحياة بطريقة احترافية وطريقة مستدامة في وجود المظلات الرسمية. نضمن بأمر الله أنه المخرجات اللي نخرج فيها تستدام، ونكمل عليها إن شاء الله في السنة القادمة بحول الله ووجودكم جميعا.
شكرا دكتور فرحان. Any question؟ تفضل دكتور.
الحقيقة هذا أيضا تعليق إضافة لما ذكره الزملاء. ربما إحدى الجوانب المهمة هي الأنظمة والتشريعات التي تساعد المستهلك على أنه يتجه على الأقل خطراً، ومن ذلك يمكن دور هيئة الغذاء والدواء. فربما لو كثفت قضايا الريجوليشن التي تنظم ما يوجد على الرفوف في الأسواق، لربما تساعد على أيضا تقليل اتجاه الناس لها، أو على الأقل تساعد التوعية التي تتم بوجود هالأنظمة هذه.
Any question؟ وين الميكروفون الثاني؟
السلام عليكم. I'm consultant pediatric rheumatologist. I attended this conference looking for solutions for the children who's coming with joint pain early in their age and they don't have actual inflammatory problems. وصراحة تفاجأت جدا بالعلماء وكمية الأطباء وكمية المعلومات اللي رغم إحنا نعتبر من الناس المتعلمين إلى الآن لم نصل إلى هذا القدر من العلم، فشكرا لهذا المؤتمر الرائع أولا ولكل المنظمين والسبيكرز. أنا عندي حلم بس حابة أشاركه معاكم. أنا أحلم إنه في يوم من الأيام يكون الأورجانيك فود والهيلثي فود أرخص من الجنك فود ولا النون هيلثي فود، بالذات في بلدنا اللي راقي ورائع ويعتبر من البلدان المتطورة والكبيرة في الإنتاج الزراعي والبيئي. الحلم الثاني أتمنى أنه يكون في مادة في التعليم، طبعا هذه الأحلام ما يحققها إلا ناس مثل الناس اللي في المؤتمر اليوم والجهات الرسمية العالية اللي بتنظر لهذه المؤتمرات. الحلم الثاني أنه يكون في مادة مجبر الأطفال أنهم يدرسوها على الأقل من المتوسط والثانوي، مادة الويل بينج or the health and nutrition. يكونوا الأطفال بيدرسوها، وبالتالي الأهالي كمان حيقرأوا معاهم أو يذاكروا معاهم أو ويكون عليها علامات، بحيث إنه لأنه أكبر فئة صعبة إن إحنا وكل اللي عنده أطفال يعرف هذا المعلومة. يعني أصعب فئة إنك تقنعها إنها تأكل هيلثي فود هم الأطفال من عمر 8 و9 سنين والمراهقين والأعمار اللي هي الأطفال الأعمار اللي هم يعني they are going into adulthood و they want to force their opinions و personality. لما ندخل إحنا الويل being والhealth والexercise as subjects in school and they know يعني they took it from other يعني persons other than their parents who forcement، ويفهموا إن هي يعني شيء علمي، يتهيألي إنها حتساعد في الأوبجكتس أو الأهداف اللي يعني المؤتمر واحد من مخرجاتها إنه to decrease the sickness, improve the health being, to decrease the cost of treatment.
شكرا
لكم.
أظن حلمك الثاني عند الدكتور صالح كان recommendation the last conference.
شكرا دكتورة. معنا الدكتورة رولا القويفلي، ما أدري موجودة ولا ما هي موجودة. دكتورة رولا ما هي موجودة. طبعا وزارة التعليم أو أشكر وزارة التعليم لأنهم لهم دور كبير جدا، وشفت مادة أنا معينة أو يشتغلون على مادة معينة لها علاقة باللي هو طب نمط الحياة، لكن ما هو تحت اسم طب نمط الحياة، لكن نمط الحياة الصحي له منهج يدرس ويتم تطبيقه إن شاء الله قريبا، ونسعى الآن للقاء وزير التعليم أيضا لبث زي ما قال الدكتور الأستاذ الدكتور عبد الرحمن مزروع، بث اللي هو ممارسات نمط الحياة في جميع المناهج من الصغر حتى نهاية الجامعة، حتى برامج التدريب للمتخرجين أيضا. بالنسبة للحلم الثاني كلنا عندنا حلم بالنسبة للأورجانيك فود، وأدري أنه في الآن برامج في حائل منتج الأسماك وغيرها من البرامج لها الموضوع هذا، لكنه ما يكفي انه اللي احنا نسويه، نحتاج زي اللوبينج كوميونتي لوبينج، يعني كلنا نحتاج ندعو للشيء هذا عن طريق وسائل التواصل الاجتماعي وغيرها من الوسائل بحيث نصل الاهداف جميعا. يعني واحد لحاله ما يكفي، في كل المناطق، الجامعات، في المستشفيات وغيرها، لكن الممارسة الشخصية مرة مهمة أيضا.
شكرا دكتور صالح. The last question.
Yes. السلام عليكم. طلال البشري. أنا ربما أني أوظف سؤالي في الجانب القيادي والإداري لدى مؤتمر طب نمط الحياة. الجميع شاهد على النجاح المتميز الذي حققه المؤتمر العام الماضي والسنة هذه. فربما أن هذا السؤال نبع من لما ذكروا الأخوة في مجال كيف نوصل الصوت من خلال وسائل التواصل الإعلامي. حاب أني أسأل الدكتور فرحان والدكتور صالح الراجحي اللي هو توظيف الليدرشيب ستايل في اللايف ستايل ميديسن، كيف ضرورة هذا المجال والتوصيات اللي راح تنبع من هذا المؤتمر للسنة القادمة. يعني الجميع شاهد على القيادة والإدارة لدى الدكتور فرحان الشمري والدكتور صالح السهل الممتنع. كان النجاح الباهر اللي حققه أمس في كلمة الدكتور صالح لما قال أمير طب نمط الحياة، أعتقد أنه تبني القيادة والليدرز لموضوع اللايف ستايل أثره كبير جدا في المجتمع. اليوم احنا تدشن عدة برامج نوعية كلها تخدم في مجال الصحة. هذه البرامج النوعية في التوعية الصحية هي تساهم في تحقيق الرؤية. فسؤالي لهم جميعا: كيف أثر القيادة والإدارة في توظيفه في طب نمط الحياة؟ هل سوف نرى شيء قادم السنة القادمة؟
يعطيك العافية دكتور. دكتور صالح. دكتور فرحان.
طبعا سؤال ضخم جدا كبير، يعني ما شاء الله تبارك الله.
أتمنى الجواب يكون قصير.
لا، وقصير جدا إن شاء الله. لكن هي من أهم الأشياء بقولها، يعني يمكن ما أتوقع الجواب، لكن حسن الظن بالله هو الواحد. الشيء الثاني، الشيء الآخر أنه العمل قلبا وقالبا وتستمر فيه، يعني never quit. دكتور عبد الرحمن يعرفني، دكتور فرحان يعرفني، لما أبدأ موضوع نستمر فيه. ومن فضل الله علينا أنه نجد زملاء ونجد قادة موجودين، الدكتور فرحان، سمو الأمير عبد العزيز بن سعد بن عبد العزيز، وغيرهم من الزملاء الموجودين في حائل. أنا أقول حائل فيها قيادات ما شاء الله، بس يبغى مثل الذهب، يبي من يطلعها ويبرزها شوي، والمناطق الأخرى فيها نفس الشيء. ومعنا قادة، مع الدكتور سعد البث، معنا الدكتور رجاء الردادي، ومعنا مجموعة من الزملاء ما أقدر أقول أسميهم كلهم، لكن نحتاج نتعاون جميعا لخدمة بلادنا، خدمة ديننا، خدمة المواطنين أيضا، وأيضا خدمة البلاد الإسلامية والعربية والإنسانية جميعا، يعني ليس فقط نحن. لكن أنا أقول اليد 5 أصابع، ما يكفي إصبع واحد، كلها تعمل مع بعض بشكل فريق. وأنا بشكر الدكتور فرحان اليوم على جميل يعني قيادته وحرصه، وأنا تعلمت الصراحة السنتين الماضيات ما لا تعلمت يمكن خلال 10 سنوات من ناحية القيادة والإدارة.
شكرا دكتور صالح، يعطيك العافية. دكتور صالح الراجحي العام الماضي أحضر لنا بذرة صغيرة اسمها نمط الحياة، وأخذنا هذه البذرة ووضعناها في وادي مشار بجانب تلك الطلحة. اجتهدنا جميعا كأفراد ومنظومات في حال وموظفين، زملاء وزميلات، بعد أن آمنا بهذه البذرة وبمستقبل هذه البذرة. ثم نمت هذه البذرة في وادي مشار بإطلاق المؤتمر الأول، ثم أسقيت بجهود الزملاء والزميلات، ليس فقط في منطقة حائل، وإنما كل المشاركين اللي حضروا من المناطق الأخرى في المؤتمر الأول، واللي يتوقع 70% موجودين معنا في المؤتمر الثاني. إيماننا كأفراد بهذا المشروع، واللي طبعا ينبثق من مشروع وطني، ينبثق من مشروع التحول الصحي، ينبثق من رؤية المملكة مجتمع حيوي. لن يكون هناك مجتمع حيوي إلا أن يكون هناك مجتمع صحي، ولن يكون هناك مجتمع صحي إلا أن يكون هناك فرد صحي. لذلك هذه الفكرة التي آمنا بها ويؤمن بها الجميع، كل من حضروا لهذا المؤتمر مؤمنين بهذه الفكرة. إيمان سمو أمير المنطقة فيها هو بوابة كبيرة للانطلاق إلى مستقبل يعني واسع في هذا المجال. نمط الحياة يميزه، ولا أقول يعني يعيبه، ولكن من التحديات الموجودة فيه أنه يشمل كل شيء. في كل جزئية هناك نمط حياة، وفي كل تخصص صحي وغير صحي هناك نمط حياة. لذلك هذه البذرة تنمو ونسقيها سويا، ونعمل على إقناع القيادات، إقناع المسؤولين، ليس فقط إقناع المسؤولين بهذه الفكرة، وإنما بنتائج هذه الفكرة التي نراها تلوح بالأفق. وللحمد الأمثلة دائما اللي نراها الآن للمتشافين بأمر الله بدون خضوع لأدوية، أو كانوا على أدوية ثم صار ريفيرس المرض ورجعوا أصحاء. كل هذه نماذج حية يعني تجعلنا نضاعف الجهد. دكتور فرحان الشمري هو أحد أفراد هذا الفريق، ربما يعني بكون البوزيشن كمدير عام هو اللي يضعني بمكان القيادة، لكن لا قيادة بلا فريق رائع، ولا قائد بلا نجاح وتكامل مع القطاعات الأخرى. فنحن بكم ومعكم بعد توفيق الله، وبدعم سمو الأمير، وبدعم معالي الوزير، وبدعم القطاعات ذات العلاقة، سوف نبني هذا المشروع، وسوف يستمر هذا المشروع. وبوجودكم معنا سوف يكون هناك مؤتمر ثالث ورابع وخامس واستدامة إن شاء الله، حتى نحقق ما نتمناه ويكون نموذج للدول الأخرى بحول الله. فشكرا لكم جميعا.
شكرا دكتور فرحان.
أنا بس بختم وكذا كلام الدكتور فرحان في نقطة أساسية استراتيجية في العمل في أي مكان في السعودية ولا في غير السعودية، أنه القطاعات الأخرى 80% ما يؤثر على صحة الإنسان وجودة حياة الإنسان وعمر الإنسان وكفاءة الإنسان خارج المستشفيات والعيادات وكلية الطب وغيرها، هذه برا. فلذلك من أذكر أنا أول لقاء أنا والدكتور فرحان في إمارة منطقة حائل، كان فيه ممثل وزارة الرياضة ووزارة البلديات والبيئة والزراعة والمياه وجودة الحياة، يعني مجموعة أنا ما أقدر أذكرهم كلهم، لكن كل له دور وكل له شيء يستطيع نعمله حتى مع نفسه. يعني لو نسأل بعض الزملاء اللي الآن والزميلات اللي معنا، أول ما نستفاد هو نفسه، الشخص نفسه وأسرته، وبعدها صار مرضاه وجيرانه إلى آخره. فتوافر الجهود والتعاون وكل له دور. أنا أقول المرور له دور، يسألوني وش دخل المرور في الموضوع. المرور له دور في فهم أنه بعض قادة المركبات عندهم اضطراب القيادة، هذه مشكلة صحية. عندهم اضطراب استخدام الأجهزة الذكية، اللي ما يترك الجوال يسوق ويقرأ الجوال، ما تجي مع بعض يعني. فالكل له دور من وزارة الداخلية إلى جميع الوزارات الأخرى والقطاعات والهيئات العامة والخاصة.
شكرا دكتور صالح. 1000 ميل يبتدي بخطوة، وحنا إن شاء الله أننا بدينا بالخطوة. Thank you for all. I know you have a lot of a question, but we have a system and program we should follow it. Now إن شاء الله تكريم السبيكر session 1 and session 2. دكتور فرحان تفضل.
أو بسم الله الرحمن الرحيم. أول تكريم للدكتور صالح الراجحي، لو سمحت تفضل. This honoring for speakers and moderators. So دكتور صالح both ما شاء الله today. دكتور هاني الفهيد. نعم تفضل. دكتور سعد البتال. دكتور أنس. دكتور أنس العنيزان. دكتورة راشا الردادي. دكتور خالد الرصادي. دكتور فايز الغانمي. دكتور فايزة الغانمي سوري. دكتورة سلطانة العتيبي. دكتورة قمر خوجة. دكتور عبد العزيز العثمان. دكتورة رجاء الردادي. دكتورة وضحى العتيبي. دكتور حمدان البقعاوي. دكتور نيبال عبد الرحمن. موجود هذا دعيناه. دكتور نايف التميمي. دكتور طلال الحربي. We finish here. We're closing our the first morning sessions, and this is the break time. Please, we have to come back here at 1 o'clock, inshallah. Thank you very much.
Welcome everyone again. Third moderator today, Dr. Iba Filimban, Associate Professor at Nursing Taif University. Welcome, Dr. Iba.
Thank you for introducing me. Hello, everyone, and good afternoon. I really hope you had a satisfying and good lunch break, and thank you for coming back. Our first speaker, he's an acting consultant in family medicine. He's a trainer at the Family Medicine Academy at the King Fahd Medical City. And he is a quality projects team leader. He got his Saudi board and the Arab board in family medicine. Please help me welcome Dr. Anas Alonizian.
السلام عليكم، مساكم الله بخير جميعا. كيف حالكم؟ أموركم تمام إن شاء الله. أول شيء حاب أشكر الجميع على حسن التنظيم، وأشكر بالأخص الدكتور صالح على الدعوة، وأشكر أهل الحياة جميعا ما قصرتوا، ويض الله وجهكم جميعا. So our topic today will be about food as medicine evaluation framework. The objectives that will be covered is the introduction and background about the framework, the steps of the framework, and standards of evaluation, how to apply the framework, and also talk about food as medicine in retail, and some case studies. So, consumer nowadays is not only caring about the price of the food, they're not only caring about how tasty is the food, they also want to be healthy, and they care about the health and well-being of them. And it's been noticed that their decision-making in terms of grocery shopping, going to the restaurants, sometimes they go with the more healthy option, and they choose it to feel better, and it will make them feel better, as they say, the result of it. As a result, a lot of programs have been implemented to support the food as medicine, but those programs need to be evaluated to make sure that they're doing properly. Now, program evaluation is a very important step and very crucial, but the problem is it's not doing, or it's not being done consistently. So why is it important that we need to do it consistently? Because we want to achieve the public health goals of the CDC. We're trying to reach the outcome. We're trying to make decisions based on science. We're trying to make an effort and being responsible, and to try to perform effectively as a service agency. Now, what are the steps of the framework for evaluation? First step is to engage stakeholders. Whoever is responsible, whoever is involved, those are affected should be incorporated to describe the program. What's the map itself, how it is done, the program. Focus evaluation design. What part of the evaluation is important and what need to be focused on. To gather credible evidence, data. It's very important so we can move on and make basic scientific judgments and decisions. We need more data. Justify conclusion. It needs to be justifiable and evidence supported. And finally, we ensure use and share the lessons that we learned from the program itself. Now, who are the stakeholders? As we mentioned, whoever is responsible. They could be an individual, it could be a group, it could be an organization. All who's responsible, all who's affected should be included. Now, the stakeholders can be involved only in the first step, or many steps, or all steps. It all depends on how contributing through the process have been. Now, the second step is to describe the program. Basically, it's a map, what we will do, how will we reach our goal, what are the steps, what are the inputs, what are the outputs, and what are the outcomes of our plan itself. It needs to be clearly stated so we can know where are we. Afterwards, we will talk about the focus evaluation. Focus evaluation means that at what parts of the program we should focus our evaluation. What is important to us most. Now, to do that, there are many criteria for standards evaluation. There are around 30, but they're usually grouped into 4 groups. First one is utility. The second one is feasibility. Proprietary and accuracy standards are the most important ones. Now, the step afterwards is to gather credible evidence. It's very important for us to make sure that the evidence is credible and relevant to our program. After that, to justify conclusion, make sure that the evidence is justifiable and related to the stakeholders and reach their benefit. And finally, to ensure the use and share the lessons learned from the program itself, so we can either try to evolve the program itself or even use it in other programs in the future. Now, we talked about the standards of evaluation. The standards of evaluation, they have been developed by the Joint Committee for Educational Evaluation. Although they have been developed for educational evaluation, but it has been used even for public health goals. Why do we need to use them? Because they usually result in reliable and impartial evaluation. They usually result in preventing unfair assessment of the evaluation. That's why they are being implemented in public health programs. The first one are utility standards. Utility standards make sure that the evaluators are satisfied with the results. Second one are feasibility standards. They make sure that we're doing the evaluation is practical and easy and feasible. Third one is proprietary, to make sure that the evaluation is moral. And the final one is to accuracy, to make sure that the evaluation is accurate and reaching our goal if it was repeated 100 times. After that, the step is to apply the framework. How can we apply the framework? So we try to conduct optimal evaluation. We need to ask ourselves multiple questions. The first one is, what is the best method to evaluate? Afterwards, what is being learned from the evaluation? And finally, how will lessons learned from evaluation can be implemented in public health? If your program have been done correctly and your evaluation have been done correctly, you should answer all these questions without a doubt. But if there are some mistakes, you might have some issues with it. Now, another step about applying the framework is evaluation teams. Evaluation teams need to be from multiple people who are in different specialities, who are well chosen, who are knowledgeable about the situation, who can make a proper evaluation and decisions upon them. Now we'll talk about food as medicine in retail. So in retail, usually when a program is implemented, it needs to be evaluated. They usually follow the CDC framework that we just talked about. Now, as a food retailer, would ask themselves, why would I do a program evaluation? There are many reasons that they could do the program evaluation for. The first one is to make sure that their objectives and the goals are reached, to make sure that their plans is outcome-oriented, to make sure that the quality improvement continues on and not just stop at here, and to justify the need for further resources and funding. Now, what are the subjects that they can be involved in? It can range from gut health, diabetes, heart disease, allergies, nutritional deficiencies. All of these are subjects that they can be involved in. How can they be involved? They can be involved either through tailored meals. They can be involved through prescribed meals or prescription programs. They can be involved through incentive programs. They can be involved through path to purchase marketing and so on.
5 more minutes.
Now, here are some examples of case studies that happened in the US and how they implemented a food as medicine program. First one is from Kroger Health. They have implemented a telenutrition service. It was during COVID, so the patients were not being able to reach the clinics to get proper nutritional advice. So the patients were contacted, were given specially tailored meals depending on their risk factors and their chronic diseases. And the patient have showed major satisfaction with the specially tailored meals, and they have increased, and the payoff for the company itself, showed that increased their telemedicine about 300%. Another example is from Spartan Nash. They have developed a family meal program. The program was focused on supporting families to go together to groceries and shop together and decide on their meals and cook at home. It showed that they were eating more healthy and supportive of each other as a family, as we discussed before, that it's not only the individual that presents to the clinic, also the whole family need to be oriented about healthy lifestyle. So these are my references that I have used, and thank you so much for your time.
Thank you, Dr. Anas, for your informative presentation. I would like to remind all the audience that questions will only be discussed later during the Q&A panel discussion. Please allow me to introduce our next speaker, Dr. Najat Eltoum. She's an assistant professor at the Department of Clinical Nutrition in the College of Applied Medical Sciences at University of Ha'il. She's a registered consultant dietitian at the Sudanese National Council for Medical and Health Professions. And also, she's a registered nutrition specialist at the Saudi Commissions for Health Specialists. Her topic will discuss nutrition impact on epigenetic trait changes and chronic disease risks. Please welcome Dr. Najat.
Assalamu alaikum. First of all, I would like to thank the organizing committee for inviting me for such a very important event. I will talk about the nutritional impact of epigenetics and how it affects the generations after, how the parents' food intake and nutrition before pregnancy and during pregnancy, and after that, how it impacts their offsprings. So the main points that I'm going to discuss is giving an overview of epigenetics, what's the meaning of epigenetics, and its role in the chronic disease developments, focusing on diabetes, cardiovascular diseases, and obesity. Also, I'm going to highlight how the nutrition and diet can modulate the epigenetic regulation and how early life exposure can lead to epigenetic changes affecting health outcomes in adulthood. And how are we going to fix these problems by using personalized and precision medicine? Epigenetic it's a term that was introduced by a biologist, a British biologist. His name is Conrad Waddington in 1942. And he defined epigenetics as the branch of biology which studies the causal interactions between genes and their product, which bring the phenotype into being. And also, it discusses the alterations and changes in the chemicals that affect how the body interprets the DNA, and how our, not genes are changed, but how our genes are imprinted by the changes of our lifestyle and diet. The most extensively researched epigenetic modifications include DNA methylation, histone modification, and non-coding RNAs. Nutrition also and diet can modulate epigenetic regulation, influencing chronic disease risk, in addition to other factors like pollution and exposed to other lifestyle factors. So the main idea is that we eat the food and then we get the nutrients. The main nutrients that are involved in methylation are pectin, choline, B vitamins, folic acid. All of them will help in producing methionine that will involve in the process of methylation and turning the genes on and off without causing a change in the gene itself. This illustration shows how this process is happening. As you can see, the methyl group function is only to change the gene on and off. These are some nutrients that are involved in the epigenetic process. Includes methionine, folic acid, B vitamins, and sulforaphane, piturate. All of these are found in the food that we eat mostly, like sesame seeds, where we get methionine, folic acid from leafy vegetables and sunflower seeds, vitamin B12 from meat and other meat products. All of them are involved in methionine synthesis or breaking down the toxic byproducts of the S-adenosyl methionine synthesis. Also increased methylation and cancer prevention. This is for a product or a nutrient that is found in soybeans. This is also a common modifications or epigenetic modifications and associated effects on the mammalian genome. And we can see that the DNA methylation main function is to promote the sites associated with the gene silencing, as I said, turning it on and off. In histone acetylation, it will allow the genome-wide reprogramming in the sperm protemination, which means that it affects the sperms, and this can be transmitted to the offsprings. We have histone variants. These also specialized in functioning or functions including DNA repair, gene regulation, and centromere. So there is a theory about the development, origin of health and disease. This theory suggests that environmental factors in early life can profoundly affect our vulnerability to disease development later in life. The proper nutrition during critical developmental stage, especially in the first trimester, can prevent adverse epigenetic changes that can lead to chronic diseases. And one of the famous examples is the deficiency in folic acid and how it affects the pregnancy outcome, how it affects the baby and leads to spina bifida and such problems. The most or extensively studied, let's say, phenomena was, or a crisis we can say, is the Dutch famine, where they studied a birth cohort of a group of pregnancies outcomes in Amsterdam. This Dutch famine birth cohort is a cohort of 2,414 men and women born as term singletons in the Wilhelmina Gathos Hospital in Amsterdam between the time of 1943 and February 1947. This famine happened towards the end of the Second World War, and the parents of these children were exposed to the famine. So since that time till now, the study is ongoing to study the effect of this famine and the nutrient deficiencies on the offspring. They are old now, and also they are studying their next generations or grandchildren. As you can see here in the graph, that the babies born before famine, they had almost normal birth weight and normal height. Or babies who were born before or during the famine, they started to be smaller in size. During the famine, the weight also reduced more, and after the famine, they started to have more weight and going towards a normal weight and height. The first problem that is a complex problem that I'm going to discuss is obesity. We know that it is a multifactorial disease. In the past 5-6 years, it was classified as a disease influenced by genetics, environmental, and lifestyle factors. The modifications that happens epigenetically has a very important role in the development and progression of obesity, where it changes the expression of the gene involved in the metabolic pathways and adipocyte differentiation. The Dutch women birth cohort studies link the intrauterine exposure to maternal undernutrition during the hunger winter and metabolic syndrome in adulthood. And this includes obesity and elevated blood glucose and cardiovascular diseases. The methylation pattern in genes involved in lipid metabolism, insulin signaling, and adipogenesis also happen. This figure here shows how the offspring of mice fed a diet rich in methyl donors has a reduction in agouti gene expression. The agouti gene is the gene that's responsible to give the yellow coat. So if we have a mice or a mouse with agouti gene, both of them, they have agouti gene, but one of them was fed the methylation inducing nutrients like folic acid and B12 and all of this. And although the mouse has agouti gene and obese, but after feeding the mouse all of these nutrients, the offspring become normal, which means that there is an effect of the nutrients on the outcome of the pregnancy. So this means that there is a transgeneration effect where the change can move from one generation to another generation. And if it is from one generation to the second generation, it's called intergenerational change. If it is from one to the second to the third, it's called transgenerational change.
5 minutes, doctor.
Okay. Diabetes also, the same effects. Studies prove that almost the same genes involved in diabetes are involved in obesity. Cardiovascular disease, many studies done in animals prove that the negative impact of diet high in fat also can lead to heart function changes. And this was proved by a study done in Drosophila fly. Also, the maternal exposure to high-fat diet, this is a study also done in animals, shows that the gene expression was affected and leads to inflammation and cardiac dysfunction. Here we can see that the changes even before pregnancy can affect the sperms that will lead to the formation of the fetus, and the imprinting or the changes can affect the baby after that. All of these functions and effects like the change in behavior, milk composition, chemical exposure, and the environment during pregnancy, either from the maternal side or the paternal side, can also affect the children. So how are we going to combat that? There is a new field called precision and personalized nutrition. These terms, although they are different, but they are used interchangeably. It is used it uses individual genetic, epigenetic, and metabolic profile to provide tailored dietary recommendations. The modifications in the genes influenced by environmental factors like diet can be used to provide personalized dietary recommendations while considering the individual epigenetic profile to improve the health outcomes and also to prevent the chronic diseases. The omics technology like genomics, proteomics, metabolomics, all of these can help in identification of biomarkers. The dietary intervention, thank God, it can affect the epigenetic modifications. Challenges to implementing is that we need to consider epigenetic modifications, include the need for large-scale validation, as I said, validation studies. As I said, this is a new emerging field. Also, the personalized and precision nutrition considers epigenetic modifications. It is a promising approach with new opportunities for personalized dietary interventions. These are the steps that we need to follow. Usually, in general, we talk about healthy eating and food pyramid and the healthy plate, and then we move to the targeted nutrition according to the disease that the person is suffering from. And the personalized nutrition is to have individual specific information using sometimes even informatics and merging all of these omic sciences together to have more precision nutrition provided for those people. In conclusion, epigenetics plays crucial role in chronic disease development, including obesity and diabetes. And nutrition in early life or exposure to nutrition in early life can modulate epigenetic regulation and affect health outcomes in adulthood. We need more researches to elucidate and uncover the complex interactions between epigenetics, environment, and lifestyle factors to develop effective prevention and treatment strategies. Thank you.
Dr. Najat, for your inspiring talk. Now, before I introduce our next speaker, and in keeping with the spirit of the conference theme, lifestyle, can I ask everyone to stand up, please? No exceptions. Raise your right arm. Put it down. Raise your left arm. Put it down. If you're happy and you know it, clap your hand. Thank you. Sit down. Thank you so very much. عشان تصحصحوا شوية. Our next speaker, Dr. Banan Al-Malki. She is family medicine assistant consultant who graduated from Al Qura University, trained and finished her Saudi board at the King Fahd Military Medical Complex in Tehran. And currently, she is coordinator of the cancer programs in the Eastern Health Cluster. She'll be talking about nutrition and cancer. Dr.
Assalamu alaikum jami'an. Thank you, Dr. Iba, for the quick exercise. Thank you for having me. I would like to thank the organizing committee, على رأسهم دكتور فرحان الشمري, Dr. صالح الراجحي, for this beautiful event. أن نتطلع للإيفنتات القادمة في السنوات القادمة إن شاء الله for the lifestyle medicine. So today I'll talk briefly about a nutrition that could help us in preventing the cancer. The objective will be covered. Excuse me? It's not working? Okay. The objective will be covered in the presentation. The epidemiology and most common types, the risk factors that we can prevent it, the rules of vitamins and micronutrient, and the type of diet. So we define the cancer as abnormal generation of the human body cell that appear in any age and any time. It could be benign or malignant, and we can define it. We can divide the malignant cancer as 3 categories: as sarcoma, lymphoma, and carcinoma. As globally, it's one of the leading causes of death. And in Saudi Arabia, as we see, this is the statistics in 2021, there's around 27,000 new cases of cancer in Saudi Arabia, and accounting, and the breast cancer, colorectal cancer, accounting the most common type of cancer in Saudi Arabia. So there's risk factors. We can categorize it into two categories, either modifiable or non-modifiable risk factor, like the age, the ethnicity. Some ethnic group, they are having a greater risk factor of getting some cancers. Being female, you are having higher risk of having breast cancer than the male, and the genetics. And the modifiable risk factor that we can prevent it and by eliminate it, like exposing to chemical and substance, tobacco use, whatever the type, like smokeless tobacco, cigarette smoking, and even the passive smoking, they will have risk of having lung cancer. Alcohol consumption, air pollutions, and exposing to UV light, whatever natural or artificial. Some viruses could lead to different type of cancer, like hepatitis B, human papillomavirus, and obesity by the long-lasting inflammation and elevated level of insulin. It could cause 13 type of cancer. So how can we prevent cancer? By eliminating the modifiable risk factor and by the early detection. Stop smoking and activating the smoking programs. It's free and available in any primary care. You can just book an appointment for the smoking preventing clinic. Vaccination. There is vaccines could prevent a lot of cancer, like hepatitis B. There's a new initiative for human papillomavirus vaccine in Saudi Arabia. Exercising. The American Academy of Cardiology, they recommend, depending on the sedentary, on the lifestyle, they're recommending at least 150 minutes per week for exercising. Blood donor and organ donor precautions and needle stick injury precautions. And the screening cancer programs. There's already initiatives, it's implemented everywhere, governmental and private, like for the breast cancer and the colon cancer. And there's a new initiative, they will implement it inshallah soon, for the cervical cancer and lung cancer. So you have to educate your patient about how the preventive screening tools. It's depend on the consultation itself. تفرق لما نقول للpatient مثلا there is test for colorectal cancer, you want it or not, they will say no. But when you say for them you are in the targeted group, you have to screen for the colorectal cancer, or you have to screen for breast cancer, they will consider it as important. So as we know that a diet playing a significant role in preventing cancer, this schedule showing for us a different calorie intake depending on the lifestyle for the individual. So, but we need to remember that it's depending on the quantity and the quality. So we should not just depend on the calories intake. The rules of vitamins and micronutrient, it's playing a role in preventing cancer. Vegetables and fruits, it's having impact on some cancer like early digestive cancer, and reducing, and some studies showing that consumption of tomato and tomato-based food, it will reduce the risk of prostate cancer. The whole grains like brown rice, the whole wheat bread, the whole grain, controlling our weight, lowering the cardiovascular disease, and lowering the incidence of cancer, especially for the colorectal cancer. Reduce dairy fat, consuming 3 cups of dairy product per day will reduce the risk of colorectal cancer. Including the fiber in our diet, it will reduce the cardiovascular and all cause of the mortality, and also reducing the risk of colorectal cancer. Including the protein in our diet by consuming 5.5 ounces protein-rich meal per day, and including the nuts. There's one observational study showing that consuming nuts 5 or more times per week will reducing the risk of myocardial infarction and stroke and colorectal cancer. We should include the fish in our diet, at least 1 to 2 servings per week, and including the healthy fat. So there's many types of diet considered as healthy diet, but it's depends on the individual preference and depending on the social culture and the patient food, the patient cost, the taste preference, and the food availability. The Mediterranean diet, it's including the fresh product, the whole grain, legumes, and containing olive oil, little or no red meat, and consuming low, moderate fish and poultry dietary product. The studies shows that it's enhancing, decreasing the colorectal cancer. The DASH diet, usually we recommend it for the hypertensive patient. We consuming 4 to 5 servings of fruit, vegetables, 2 portions of low-fat dietary product. Vegetarian diet, it's including eating vegetables and fruits with restricting the consumption of the animal-based product. But we should keep in our mind, we should follow up the patient or any person who is restricted on the vegetarian to avoid the decrease in the minerals and vitamin B deficiency. Low-fat diet, by concentration on cutting off calories from fat and just taking the fat from nutritional sources like fish and olive oil and canola oil. Low-carb diet, by prioritizing the fat protein containing diet and consuming low amount of carb. Ketogenic, it's high in dietary fat and low in carb. This will lead the body to produce the ketones that we can use it as a fuel. And we should avoid the Western diet, the most common type of diet that we use it daily. The wholesome fat and beverages full of sugar, red and processed meat. So patient diagnosed with cancer, they are undergoing a lot of treatment procedures, surgery and chemotherapy and radiation, and they're complaining of a lot of side effects like nausea and vomiting, constipation, pain and memory-related problems. So can we just recommend any kind of diet or any type of diet for the patient diagnosed with cancer? There's insufficient data that's recommending any kind of diet, but they are recommending to having enough portions of vegetables and fruit, eliminating the sugar and the fatty meals. And we need to take in consideration the post-treatment side effect, patient complaining of dehydration, so we need to educate them to drink plenty of fluid and liquid, choosing high nutrient food, eating little to have more energy, being active to increasing their appetite, eating high fiber to avoid the constipation, eating small meals to avoid the diarrhea, at least 8 to 6 meals per day, avoiding certain food like greasy, fried, sweet and spicy food if they are complaining of nausea and vomiting.
5 minutes, doctor.
These are my references, and just remember, ounce of prevention is worth a pound of care. Thank you.
Welcome again. Fourth moderator today, Asma Al-Shammari, Regenerative Medicine, Stem Cells Applications, Dean of Public Health and Health Informatics, College University of حائل. Welcome to Asma Al-Shammari.
Assalamu alaikum. I would like to welcome in the second session, which is a shared session between Dr. Samia Latif. She's working as a communicable disease control consultant at the UK Health Security Agency in Leicester, England. As well, we have online Dr. Ula Muhammad Ahmed, a global public health consultant with the UK Health Security Agency in the Greater Oxford area of the United Kingdom. Platform is yours.
Assalamu alaikum, everyone. I'd like to thank the organizing committee and Dr. Saleh Al-Raji for his very kind invitation to come and speak at this conference. I'll be joined by my fellow colleague and consultant, Dr. Ola Mohammed. Is she online? Do we have her? Okay.
I am online. I
Right.
don't know if you can hear me.
We can't see you, but we can hear you. Brilliant.
Assalamu alaikum. It's great to be here with you virtually. Thank you.
So what Ola and I are sharing with you guys today are our insights. So nature nurtures us and provides the nutrition of all living beings down to the very smallest microorganisms. Our health and our nutrition is linked to the environment through the food we eat, the gut microbiome that we inherit, and the lifestyle choices that we make. Some of the objectives today that we will cover, we're going to take an ecological perspective and look at population health and the ecological drivers of human health related to food and nutrition, and why this is relevant to lifestyle medicine. Now, I did have a quiz, and I was meant to have a Slido thing where you guys could vote, but very quickly, I won't go through all the questions, but perhaps if we can just look at one of the questions. How many microorganisms does the gut microbiome contain? Do you think it's 1 million, billion, or trillion? Can't hear you. Yeah, trillion. And the last question, do you think a glass of orange juice has more fiber or a cup of coffee? Sorry, I can't hear. There's a lady trying to. Actually, that's what I thought, but I was surprised. According to a recent study done by the FDA in America, if you compare the same portion of coffee and orange juice, coffee actually has double the fiber compared to a glass of orange juice. Right. So I think population health, the concept of population health and well-being is covered beautifully by the term al-afiyah. And this was a term that was introduced to us by Dr. Saleh at the Indian Lifestyle Medical Conference. And we heard speakers today speak about al-afiyah and its importance in the Sunnah of Islam. But by looking and applying a population health and al-afiyah approach, what you are doing is you're applying a population focus rather than the individual person in front of you. And this also then opens up the route for intersectoral collaboration when you look at it in its whole. So the socio-ecological determinants of health, if you look at the middle circle, and we heard from the earlier speaker that we have got some factors which are unmodifiable, like our age, the genetics, our genes we inherit, our gender. But there are things that we can do within the lifestyle choices that we make that can alter our approach to how we process nutrition and how our health is affected. And in particular, is if you look at the social determinants of health, so what jobs you do, where you live, your occupation, and then you carry that forward through the environment. And if you look at the natural environment, the environment around us, that is the air that we breathe, the water that we drink, the soil where we grow our crops, all of that natural environment has a bearing on our nutrition and the nutrients we absorb from that environment. And if you look at the built environment, we've got things like roads, infrastructure. How much access do you have to green spaces, to parks, to leisure centers? All of those have a very important bearing on our health. And in particular, if we look at the biodiversity, now something that is often not considered as a determinant of health is actually our gut microbiome, which is comprised of, as we've just learned, trillions of mycobacteria that actually affect the way we absorb our nutrients and also our immunity and our resilience to disease. And if you look at climate change, we know that the climate is altering. And owing to that, there is a difference now in the vector population. So for example, where there is more hot weather, you're going to see maybe more mosquitoes, an increased prevalence of malaria or dengue fever. And also within all of this, the global ecosystem, as we have more urbanization, there is increased interaction between, not just between people, we live in a global village now, but also between people and animals. And that, we saw the results of that during the SARS pandemic, during the SARS outbreak and the COVID pandemic, and also during the Ebola outbreak. So we are beginning to see the manifestation of that human-animal interaction. Now, we know that in Islam, maintaining the balance between the humans, animals, and our environment is hugely important. So much so that our Prophet Muhammad ﷺ also said that when you go out to war, preserve the environment, do not damage the trees and the plants. And we are also encouraged to be responsible for preserving our natural resources, such as not wasting a single drop of water. So I think Islam sets down the principles of a socio-ecological basis of health very beautifully. And if we look at culture and faith, there are some cultures or religions where vegetarianism is encouraged, and that is more sustainable. There are less greenhouse gases compared to those cultures where there is more focus on meat production and consuming meat. And we've also heard in the earlier presentations about how effective and sustainable Mediterranean diets are. Some cultures have more a preference for team sports. Some cultures will do more yoga. In Islam, our form of meditation or mindfulness is our salah. So all of these also have a bearing on our health. And when we talk about cultures, some religious faiths, such as Islam and Judaism, will prevent the consumption of pork. We are not allowed to consume alcohol. Also, there are some cultural beliefs and traditions about eating things like honey, black seed oil, or turmeric in different cultures. My mother-in-law, for example, if she has like a cough or a sore throat, she will not eat rice because she is convinced that rice increases her phlegm. So I think different cultures have different beliefs and traditions which sort of set down the ground rules for how they will access food and nutrients. Right, Ola, this is over to you now.
Thank you. I hope everyone can hear me. So, as Samia has discussed, our health is very intimately linked with our environment. So our communities, our society, our economic environment, and obviously the natural environment around us. And we shape these environments through our activities, and they in turn shape us. So that might seem obvious, but I think it's particularly important when we think about where our food is coming from and how that impacts on our gut microbiome, but also the quality and nutritional content and the safety of that food. So over the past 100 years, we've seen a big change in agricultural practices around the world. We know that there's been a change towards using fertilizers and pesticides. And while that's led to increasing yields of crops, it's also resulted in a lot of biodiversity, particularly bacterial diversity, and also often leads to degradation of the soil, which then impacts on the nutritional content of the food, but also the likelihood that the land will continue to produce. So there's an impact there in terms of food security and how likely it is that the land will continue to produce the crops that we need to survive. There has been a movement towards more organic or regenerative farming practices that promote soil health and recognize the important role that it plays in our health. Sorry, can you hear me?
5 minutes left.
Ola, we have 5 minutes left.
Okay, 5 minutes, thank you. So I think that there are a number of things, as well as the agricultural practices, there are a number of other factors. So for example, how we process our foods. We've heard in previous talks that processed or ultra-processed foods tend to be high in sugar, salt, and unhealthy fats, but they also tend to be lower in nutrients and also lower in fiber. We also know that antibiotic use in people can kill off both harmful and beneficial bacteria, which impacts on the microbial diversity in the gut. But the other thing that maybe people aren't aware of is that the majority of antibiotics sold, so for example, in the USA, 70% of antibiotics sold are actually used in animals rather than humans. The majority of that antibiotic use can then contribute to disrupting the microbial balance or the gut microbiome of animals as well, which then potentially means that they develop antibiotic resistant bacteria, but also it allows the animals to continue to live in very poor quality conditions. If we move on to the next slide, I'll talk about one of the environmental contaminants that's of great concern to the quality of what we eat, and what we drink in terms of our water. We know that microplastics, which are produced through several different routes. So for example, if you wash clothes that are made from polyester, in the washing machine, it can generate microplastics that then get into the water. This is something that almost everyone will do, and the microplastics can then enter into water streams, be eaten and ingested by fish, by other organisms, and that can then be transferred into us when we eat that fish or the other animals that we eat. So next slide, please. So I think in terms of thinking about food, it's really important to look at beyond just the nutrient content of the food. Obviously, the journey that food, whether it's crops or animals, the journey that food has been through, and the life that it's, the life of the animals, for example, has an impact on the quality of the food that we eat, and then has an impact on our own health. So it's important to think there is this concept around farm to fork, just understanding everything that happened from when the crops were produced or when the animals were living, all the way to when it reaches your plate. And that's an important perspective to think about when we consider the quality of the food that we're eating. Next slide, please. So I think there's a concept now that's gaining popularity around circular economy. So a linear economy is one that thinks about taking, making, using, and disposing. And circular economies, which are, to be honest, what most traditional societies are based on, looks at how every part of the process leads to another product, for example, and it's about eliminating waste and pollution. So for that reason, next slide, please. It's really important, I think, when we come to think about lifestyle medicine, that we think about the food and everything that it's been through in order to get to us, as well as the nutrient content and the other aspects of it that impacts on our health. So I think by taking care of our environment, we have an opportunity to not only look after the animals and plants and other inhabitants of our communities, but also to improve our own health. So thank you, back to you, Samia.
So I'll just quickly wrap up. These are some of the things that we can do that Ola touched upon, whether it comes to agriculture or policies or our lifestyle choices, especially moving to a circular ecology or economy, which has more focus on recycling rather than wasting, and promoting whole food and plant-based diet, whilst we consider the cultural and faith-based interventions. And I'm going to end here with a call to action, because as health professionals, we are all agents for change. We are custodians and stewards of the environment we have inherited and that we will pass on to our next generation. So we all have a duty of care. Thank you very much.
Thank you very much, Dr. Samia. Next, we will have Dr. Awatif al-Rashidi, our colleague. She's the Dean of College of Nursing. She worked as a Vice Dean of Clinical Skills. She has a PhD as well an MSc from the United Kingdom. She will present the next session about the experience of nursing in new graduates in Saudi Arabia. Dr. Awatif, platform is yours.
السلام عليكم ورحمة الله وبركاته. في البداية أود أشكر الدكتورة أسماء على المقدمة الرائعة. أشكر الحضور الكرام. كل الشكر والتقدير لمنظمين هذا المؤتمر، وعلى رأسهم سعادة الدكتور فرحان الشمري، سعادة الدكتور صالح الراجحي. شكرا جزيلا لكم. I am honored to be here today with you. I'm Dr. Awatif Dean. I'm Dr. Awatif Rashidi Dean, College of Nursing, High University. Today I'm going to talk about the experience of new graduate nurse in Saudi Arabia and how this linked to the conference theme. Actually, the transition from being a student nurse to professional nurse. In many research have been discussed the effect of this transition on the lifestyle of the new nurses. So the transition from studying nursing to practicing as a qualified professional compromise more than change in the title. Rather, it involved meeting a new demand and adapting to a new role. There are numerous barriers to maintaining a healthy lifestyle for the new graduate nurses, including shift work, workload, and fatigue that prevent them from participating in regular activity, physical activity. Evidence-based places that new graduate nurse turnover at up to 30% in the first 12 months of work and as high as 57% in the subsequent 12 months. This level of attrition is an economic drain on the hospital and represent a factor in nurse shortage, which increase the burden on the existing hospitals, including those new to the profession. So the research objectives were to explore, describe, and interpret the experience of new graduate nurse transition to practice during the first 12 months of practice, to examine the extent to which culture, social attitude contribute to their experience and how they make sense of such experience. Also to make recommendation to improve the retention and recruitment for the new graduate nurse. Moving to the literature review, we have included 4 studies from Canada, 8 from United Kingdom, 2 studies from Sweden, 8 studies from United States, 8 studies from Australia, 4 studies from Taiwan, and others included Japan, Ireland, Norway, Turkey, and Iran. We have conducted a qualitative case study informed by an ethnographic study approach. The case is a government hospital that serves around 600,000 inhabitants. The participants were 9 new graduate nurses and 5 senior nurses agreed to participate in the study. It was fieldwork observation, formal and informal observation with the new graduate nurse, and semi-structured interview with the head department, and also a focused interview with the new graduate nurse. Results are organized according to 3 themes, which reflect personal, cultural, and structural barriers to the nursing profession that arose during the first time of employment. These themes are difficult beginnings, crossing boundaries, and left behind. Moving to the first theme, which is difficult beginnings, becoming a nurse in Saudi Arabia. Emotional cost. It is just so stressful for me. One of the researchers who actually conducted many research on the transition of new graduate nurse, Dr. 2008, says that transitioning from to the professional nursing is exhausting for the new graduate nurse, requiring resilience and strength to manage the overwhelming emotion generated by the process. The difference is big. As a student, this is one of the new graduate student, Sama, says that the difference is big. As a student, it is more comfortable and there is someone who is with you to tell you why or what should you do and if that is wrong or right. While working as an independent nurse, you have more responsibility than you can handle, especially at the beginning of the work when you have to take care of many patients. One of the head nurses commented on that by saying, some of the nurses are knowledgeable, but when they are new, their skills are not sufficient to cope with the nursing profession. So I want to be honest with you. I think they have a lack of skills experience from the time they are in school. They need more training, especially when they are in the school. It is just so stressful for me. Another nurse, Rashda, said that when I get home, I think about how the staff, treated me and left me alone with many responsibilities. I worried that I might have forgotten to give a patient his treatment or to complete his file, or that perhaps I didn't do my job efficiently. Usually, I wait for the next day to make sure that everything is okay. Moving to the second theme, crossing boundaries, shift work, barrier to work, and home-life balance. And this is actually what link the transition from being a student nurse to a professional nurse to the theme of this conference. Most of the new graduate nurses interviewed found shift work disruptive their personal and social lives. In addition to describing the stress induced by the shift work, which affected their overall well-being, they noted that the long hours and constant thoughts of work affected their relationship with their family, as Sama remarked that, as a nurse, I work in 3 shifts, morning, evening, and night. Therefore, I have to delay other duties for my holiday. Sometimes I have to make a schedule to help me finish my duty. My relationship with my family, friend, and wider society are also affected, as I do not have enough time for them. The other new graduate nurse reported that similar view, commenting that shift work isolated them from their friends and relatives. As Shawa explained, yes, it hindered me a lot, and I don't know how to balance my career and my personal life. For example, do I make time for family or personal work? Me had concerned with Shawa, complaining that she had no time to relax or tend to personal and interpersonal matter, which created feeling of loneliness. Me had also commented by saying, there is no balance in my life. I feel that my life is irregular, from work to sleep and then back to work again. I forget family visit, weekend, and event. I may have to work the days of Eid. I don't even accomplish any housework on my working days, and I fear from the idea of marriage because I don't have time. And finally, the third theme, left behind. No one support or help us. Teamwork among nursing colleagues. Welcome to the jungle. There is no time.
5 minutes
sorry.
left, Dr. Awatif.
Okay. Shawa said that there is no time teamwork here. I blame the head of the department and senior nurses because they should help the new nurses until they become independent. Here, everyone is working for himself. I feel like I'm working in a jungle. Head nurse once said that this feeling of potential victimization comes from the new graduate nurse head. They should consider the challenges for the new graduate nurse to improve their self-confidence and trust in themselves. Lack of preceptor support, you have to face a tough reality. Sama said, I feel that we didn't get enough attention. Over 3 months, we had a nurse as a preceptor, but she was not available all the time. She could only give you 10 minutes of her time, although I had hoped that she would be there all through the shift, especially at the beginning of our work. Doctor-nurse communication, they view me as an inferior. Sama said, nurses are low in the hierarchy. In regard to doctors, they look at me as an inferior. Finally, intention to leave. The work for me is like a prison. Mona said, this will affect my choice to continue as a nurse or to change my profession. I may move to work in another department with more respect and less of workload. The social view of the low status of nursing is very important, and it is affecting my choice to continue as a nurse. Sorry, this has been said by Rashta. She is also a new graduate nurse. Mona said, support and guidance are important factor in the desire for the employee to stay and develop himself. But have not had that, I feel that I am lost, and I am always stressed and worried. I think a lot about changing my workplace and moving to a different job where there is cooperation between the members of the team. And finally, Showa commented on that. I used to work to fulfill a dream, but now I am working for the salary. The work for me is like a prison. Conclusion. The new graduate nurse experience the same difficulties in maintaining healthy lifestyle as more experienced nurses. Understanding the barriers which influence their transition can help to inform the strategies that will help or improve the health for those nurses at critical time when they are entering the workforce. A determined effort to focus new nurses on the positive aspect of the nursing profession can successfully extinguish a great deal of the negativity that new graduate nurses often feel, and can promote a smoother transition into practice. Thank you very much.
I would like to welcome Dr. Nada Bloui, a family medicine consultant and the head of Ministry of Health, Safe Birth and System in Tabuk. She will talk about food in preconception, pregnancy, and postpartum. Platform is yours, Dr. Nada.
بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. Good afternoon, everyone. First, I want to thank Dr. Saleh Al-Rajhi and all the great teams for this great event. And my topic today, inshallah, about food as medicine in preconception. Food as medicine, preconception, pregnancy, and postpartum. In this lecture, we'll go through the effect of maternal nutrition on future generation and also the evidence of lifestyle modification, and we'll review the recommendation about weight management, healthy dietary patterns, micronutrient, and supplementation. As we know, preconception and maternal nutrition represent a major public health issue that affects not only the adolescent and women, but also of a future generation. When we are talking about preconception care, we have always to consider fathers, as the influence of male partners' health and offspring health should not be underestimated. Parental nutrition and obesity predispose the offspring to develop non-communicable disease, including obesity, diabetes, cardiovascular, and this is recognized today as the developmental origin of health and disease. Already discussed in previous presentation, but review quick, what happened in this developmental origin of health and disease. Actually, the mechanism here is epigenetic modification. When there is undernutrition and obesity, there is some changes will happen in oocyte and sperm, like DNA methylation, histone modification, and RNA gene modification, will cause some activation or inhibition that's responsible to happen this disease, like obesity, metabolic disorder. This study conducted in China and published before 2 months to explore the relationship between paternal BMI, I mean father's BMI, and maternal neonatal outcomes, and also the long-term prognosis in offspring. The results showed that hypertensive disorder, complicating pregnancy, cesarean section, and macrosomia was significantly higher in paternal overweight and obesity group. And in systematic review published in May 2022 showed that paternal malnutrition not causing only metabolic disease, but also cause breast cancer in offspring adulthood. Okay, what's the benefit of lifestyle modification on maternal and child health? This cohort study done in Canada to examine the relationship between pre-pregnancy BMI and adverse pregnancy outcomes showed that when there is 10% decrease in pre-pregnancy BMI associated with at least 10% lower risk of preeclampsia, GDM, and preterm delivery. This RCT done on mouse model to examine the effect of preconception diet and exercise. The results showed that short term of 8 weeks from diet and exercise intervention was improve the metabolic health and adiposity, and also restore insulin sensitivity, and also normalized adiposity in female offspring. And these changes concomitant with degree of normalization of sperm microRNA content, and that means the epigenetic modification is reversible. We'll go now about some recommendation in preconception period. Okay, who are involved in preconception care? Preconception care is targeted women from menarche to menopause who can have children even if they don't attempt to conceive, and also male partners. Women who had better nutrition state at the time of conception, they have better outcomes during pregnancy, and following of healthy dietary patterns should be encouraged in them. And according to International Federation, they recommend the healthy diet as the first step to meeting nutrient needs in all female. Okay, what healthy dietary pattern I can follow? I like this table and style dietary from Dietary Guidelines American. It shows all the choices that we can consume from all groups and subgroups in food, and it's divided like according to calories per day. Also, micronutrient is very important in preconception period. And according to International Federation, they recommend micronutrient deficiency should be recognized and rectified through the dietary diversity, consumption of fortified food, and also supplementation. Okay, what about iron deficiency anemia in preconception? Actually, according to screening, is not recommended in all guidelines about asymptomatic. But I found this recommendation from CDC. They recommend screening of adolescent and adult female in childbearing age at least once every 5 years if they low risk. But if there is extensive menstrual blood loss or low intake of iron or history of iron deficiency anemia, should be done at least once per year. Okay, what about supplementation of iron? WHO recommend daily iron supplementation in region where anemia is highly prevalent, more than 40%. Targeted menstruating adult to take 30 to 60 milligram of elemental iron. And also they recommend in areas where anemia is less prevalent to take intermittent supplementation. And in Saudi Arabia, we are in a moderate zone, iron deficiency anemia between 20 to 40%. Also folic acid is recommended, as all we know. Iodine is very important, and also International Federation recommend to ask all women about using of iodized salt. And if iodine nutrition is inadequate, we can give supplementation. Weight management is very important in pre-pregnancy, as the most of adverse outcomes of obesity in pregnancy is associated with a pre-pregnancy high BMI. Okay, we'll go now about recommendation in pregnancy. The effect of obesity on pregnancy is associated with higher risk of complication like GDM, hypertension, preeclampsia, C-section. Okay, what about calorie intake? Pregnant with previous BMI, they need additional calories like 340 kilocalories per day in second trimester and around 450 in the third trimester, but we take care about pregnant obese. Pregnant obese may not need any additional calories, but data is inadequate to make it as a strong recommendation. And healthy dietary pattern, we can use this style as it's specific for pregnant. It's involve all food groups and subgroups. Also, pregnant should avoid unpasteurized foods, undercooked meat, and also seafood high in mercury. About caffeine, they should limit caffeine, as American College of OB/GYN recommend to limit caffeine less than 200 milligram per day. Macronutrient, the recommended daily of carbohydrate, protein, and polyunsaturated fatty acid is higher in pregnant. Also, almost of all micronutrient is increased, except of calcium and vitamin D. Iron, folic acid, and iodine is recommended, and iodine, according to American Thyroid Association, to take in pregnancy and lactating, and also in preconception, supplementation that contain at least 150 mcg of iodine. As I said, vitamin D and calcium, the recommended need for all pregnant, lactating, and preconception is the same. Okay, the last part is postpartum. In postpartum, I will concentrate on lactating mothers. And we'll start by the effect of maternal diet on breast milk quality. Actually, maternal diet does not affect the quantity or quality of carbohydrate or protein, but the quality of fatty acid in milk is affected by mother's diet.
Minutes, doctor.
Okay, micronutrient, fat, soluble, and water soluble vitamin depend on the maternal diet. Mineral content is independent of maternal diet. They need calorie intake, mainly for exclusive breastfeeding. They need more calorie in first 6 months postpartum and also in second 6 months postpartum. Because the milk production needs 67 kilocalories per each of 100 ml of milk production. Weight loss, 4 out of 5 studies in up-to-date show the high methodological quality demonstrated there is positive association between breastfeeding and weight loss. And obese lactating mother, they can start diet like 500 kilocalories per day loss. I mean, they can restrict 500 kilocalories to promote their weight loss without affecting milk production. Low carbohydrate diet is not, in lactating is not advised, as will cause ketoacidosis in some systematic review and case reported. We can use this dietary pattern is specific for lactating from dietary guidelines for American. Macronutrient and micronutrient is increased, the need increased in lactating, except for, I said, calcium and vitamin D. Iron in lactating induced amenorrhea is less than the recommended need in other women. Iodine also is the highest need in lactating mother, and according to American Thyroid Association, they can take it in they should take it in supplementation around 150 mcg. Okay, following healthy dietary pattern should be the first step in meeting nutrient needs and daily requirement of all energy, macronutrient, and micronutrient is increased in pregnancy and and lactating mother. Except I said calcium, vitamin D is the same in all. Okay, for health of a future generation, we cannot change their gene, but we can start to change our lifestyle, and always we need to think nutrition first. And thank you.
Thank you very much, Dr. Nada, for your interesting talk. Now we will have Dr. Al-Bandari Al-Ammar. She's an assistant professor in the Clinical Nutrition Department, College of Applied Medical Science, University of Hail. She's a registered nutritionist with the Saudi Commission for Health Specialists. She will give a talk about food as medicine, calorie density. Platform is yours, Doctor.
الحمد لله رب العالمين، والصلاة والسلام على أشرف الأنبياء والمرسلين سيدنا محمد وعلى آله وصحبه أجمعين. السلام عليكم ورحمة الله وبركاته. بداية أتقدم بالشكر الجزيل للجنة المنظمة وللقائمين على المؤتمر، وكذلك لدعوتي للمشاركة. إن شاء الله, my presentation today will be about the energy density. What is the energy density? Energy density, also called the caloric density, is the amount of energy in a particular weight of food. It is generally presented as a number of calories in a gram or pound. Energy density values, which are influenced by the moisture content and macronutrient composition of food, and its range from 0 to 9 kilocalories per gram. Here, figure 1 shows the component of the food with the greatest impact on energy density is the water. Water has the energy density of 0 kilocalories per gram as its contribute weight, but not energy to food. Also, fiber has a relatively low energy density, which provides about 1.5 to 2.5 kilocalories per gram, and it can be lower the energy density of food. But on the other hand, fat is the most energy density component of food, which provide 9 kilocalories per gram, which more than twice as much as energy of the the one provided by the protein and carbohydrate, which provide for kilocalorie per gram. And most high-fat food have a high energy density. In order to better understand which food are low or high in energy density, table 1 here classify food into 4 different categories. Water-rich food, such as non-starchy fruit and vegetables, and broth-based soups are very low in the energy density. It's less than or equal to 0.6 kilocalorie per gram, and should be more consumed in a large quantity of each meal should be included or in the snack. Low energy density food, such as the starchy fruit and vegetable, cooked grain, lean meat, and low-fat mixed dish should be combined and incorporated with very low energy density food as the primary focus of meals. Food with medium and high energy density should be consumed less frequently, and attention should be given to limit their portion size. Rule of the energy density. In addition to food energy and micronutrient, ingestion substance contain water and fiber. As a result, meals can vary greatly in terms of not only energy content, but also weight. So it is possible that food intake is regulated based on its weight or volume rather than in its energy content. This means food with a high energy density would result in higher food intake if the weight of the food were the factor being controlled, whereas food with low energy density would have a higher overall food intake because they contain a lot of water or fiber. So people typically consume the same amount of food, which is the weight, each day, but not necessarily the same amount of energy, the calorie. Hence, by eating a diet with reduced energy density that contain the same amount of food overall throughout the day, we can mislead ourselves into eating less energy without feeling hungry. Here, the term satiation and satiety are essential to understand the role of appetite in the regulation of food intake. Satiation is the feeling of fullness, والشبع, during an eating process. Also, it can be defined as the act that makes one stop eating, cut to the eat, and is frequently associated with the meal size. While satiety is used to describe the post-ingestive process that occur after a meal and inhibit further eating and include the suppression of hunger and feeling of fullness during the intermeal period, and is usually associated with the measures of the time till the next or later meal or snack intake. These processes actually are separated, but it can be overlapping. Hunger and satiety are involved in the maintenance of healthy body weight, as energy intake and expenditure are mainly governed by the rate of gastric empty as well as the metabolism of the nutrient. Figure 2 shows the satiety, which influenced by a number of elements, which begin when the food or drink is taken and continue as the food enters the gut, where it is digested and absorbed. The signals are sent to a specific part of the brain in response to stomach expansion. The sensory reaction and the brain judgment of food and drink eaten. Hormone signals are also released in response to food digestion and absorption. There are other chemicals that tell the brain how much fat we have accumulated in our bodies, which influence satiety over time. These signals are integrated in the brain location involved in the regulation of the calorie intake, result in the sensation of the fullness. In addition to the body satiety signals, there are numerous other elements that affect the eating behaviors, include the portion size of food or plate, the variety of food and beverage available, emotional food, and social context of the eating occasions. Energy density and satiety. Most people eat till they feel full. And this is why portion control alone will not work to people who attempt to reduce their weight. So, to lose weight without chronic hunger, you need to choose the right food, the ones that are low in the calorie density. Here, figure 3 shows 4 different calories, but for 3 different items of food: oil, protein, and vegetables. 1 cup of broccoli is about 83 calories. It's provide about that amount. So you would need to eat 8 cups to get or to reach for 400 calories. You would only need about 1/4 cup of olive oil to reach for 400 calories. And 1.3 cups of chopped chicken would equal about 400 calories.
5 minutes, Dr. البندري.
Dietary energy density and weight management. There are more overweight and obese people than ever before, according to a study done by Al-Quwaidi in 2022 in Ha'il city in Saudi Arabia, that showed that overall obesity increased to 41.4% for male and 77.6% for female, and the overall 59.5%. It appears that diet that can self-regulate dietary energy intake may be critical for obese people in their long-term weight loss and management. The practical strategy to reduce energy density. Number 1, select food item low in energy density. When we advise someone on how to reduce the energy density of their diet, the major goals should be to increase the fruit and vegetable intake while decrease fat intake. The calorie density of mixed food can be also reduced by using more water-rich items such as I mentioned before, the fruit and vegetables, or by reducing the amount of fat added. Number 2, promote consumption of food low in energy density as a first course. Consume at the beginning of the meal serving of low energy density food is usually a strategy to help limit energy consumption. Research suggests that select big portion size of meal low in energy density, such as the salad, which provide between 100 to 150 kilocalories, can help people achieve the greatest increase of satiety and reduce in overall energy intake. Number 3, avoid large portion size of food high in energy density. People should be advised to eat fewer amount of energy density food in addition to change high energy food to reduce their energy density. Food portion size has also been found to affect the calorie intake along with the energy density. Particularly, research has shown that when given a huge portion of food, people consume more energy. Finally, remember that adequate amount of essential nutrient balance across food group and micronutrient, variety of food, and moderation are the core of the characteristic of eating healthy diet. Thank you very much for your attention.
Our next speaker, Dr. Amal Bawazir. She's pediatric specialist at Al Jazeera Children's Hospital in Jeddah. She will give a talk about lifestyle and Alzheimer. Platform is yours, Dr. Amal.
أشكر القائمين على المؤتمر بحائل إتاحة الفرصة لي لتقديم هذه المحاضرة. كما أشكر الدكتور صالح على سعة صدره للجميع، وأشكرهم على إتاحة الفرصة لزيارة مدينة حائل عروس الشمال. طب نمط الحياة ومرض الألزهايمر. يعد طب نمط الحياة هو أحدث فروع الطب في العالم، وهو المعني بتعديل نمط حياة المريض نحو الشكل الصحي، ومساعدة المريض على الاستمتاع بصحته والتحكم والسيطرة على بعض الأمراض المزمنة. ومن المعروف علمياً يكون السبب الجذري للأمراض المزمنة كالسكر والضغط وأمراض القلب هو نمط حياة غير صحي، ولذلك فإن التحكم بخصوص الغذاء والنشاط والبدني وتقلبات النوم والضغط العصبي وعدم التواصل الإيجابي واستخدام مضرة مثل التبغ والنيكوتين والكحول وعقاقير الإدمان، إذن يمكننا التعامل مع السبب الجذري للأمراض المزمنة باتباع نمط حياة صحي متكامل. Next slide. تشكل الأمراض المزمنة غير المعدية حوالي 80%، كما أنها تكلف الدولة الكثير من الثروات والكثير من المشاكل الاقتصادية والاجتماعية، تقدر بحوالي 90% من الميزانية. ولذلك وجود نمط حياة صحي هو يعد الأفضل. وطب نمط الحياة هو استخدام التدخل العلاجي القائم على البراهين في مجال تعديل نمط الحياة كأهم مداخلة علاجية يمكن أن تؤثر في الوقاية والعلاج العديد من الأمراض المزمنة غير المعدية، وتشمل هذه المداخلات نمط التغذية الصحي والنشاط البدني، تجنب المواد الضارة، إدارة الضغوط، إدارة النوم وعدم القلق أو النوم الجيد، والتواصل الاجتماعي الإيجابي. الركائز والعوائق لطب نمط الحياة: تناول الطعام الصحي، النشاط البدني، النوم الكافي، إدارة القلق، تجنب المواد الخطرة، والتواصل الاجتماعي الإيجابي. العوائق الرئيسية لطب نمط الحياة: المرض نفسه، الافتقار إلى الحافز كالجهل بنمط الحياة الصحي، وتدني احترام الذات والثقة، الآثار الجانبية لبعض الأدوية. هذه الركائز: nutritional, exercise, avoid tobacco, alcohol, healthy relationships, sleep, good sleep, stress management. الألزهايمر. مرض الألزهايمر هو عبارة عن اضطراب تدريجي يؤدي إلى تلف وتدهور خلايا الدماغ، وهي حالة تتضمن انخفاضا مستمرا في مستويات التفكير والمهارات السلوكية والاجتماعية، مما يؤثر في قدرات وتفكير الشخص، وفي النهاية عدم القدرة على تنفيذ أبسط المهام والاعتماد على الغير. أمثلة على أشخاص قياديين أصيبوا بالألزهايمر: عمر الشريف، مارغريت تاتشر، ريغن رئيس أمريكا. لا يوجد هناك سبب واضح في الإصابة بالألزهايمر، ولكن التقدم في السن فوق 65 سنة هم أكثر فئة معرضة للإصابة بمرض الألزهايمر، ونسبة ظهوره في النساء أكثر من نسبة ظهوره في الرجال، من 1 إلى 6 في النساء، وفي الرجال من 1 إلى 11. يحدث مرض الزهايمر بسبب التعرض إلى العوامل الوراثية والجينية والبيئية التي تتعلق بأسلوب المعيشة التي تؤثر على الدماغ مع مرور الوقت. مواجهة مشكلات في بروتينات الدماغ التي تفقد القدرة على العمل بشكل طبيعي وتعوق من عمل الخلايا الدماغ وتؤدي إلى إتلافها وعدم التواصل بين خلايا الدماغ، ومن ثم تلف هذه الخلايا وموتها وانكماشها. التعرض إلى العوامل البيئية المختلفة المتعلقة بنمط حياة المريض التي بدورها تؤثر على شكل الوظائف، مثل عدم ممارسة الرياضة، العزلة الاجتماعية، التغذية التي تفتقر إلى العناصر الغذائية التي توجد فيها الفواكه والخضار والكثير من السكر أو الملح، التعرض للردود والارتجاج وإصابات الرأس المتكررة، الإفراط في التدخين، الإصابة بالأمراض المزمنة، كلها أسباب بيئية تؤدي إلى الإصابة بالألزهايمر، ويمكن التحكم فيها عن طريق نمط حياة صحي أفضل. هذه نفس أسباب الألزهايمر. كيف يحدث المرض؟ التغيرات في الدماغ تبدأ قبل عقد أو أكثر من بدء ظهور المرض. تبدأ بتكوين بروتين تاوا وألياف مكونة من بيتا أميلويد، تبدأ تتجمع وتشكل تكتلات غير طبيعية من البروتينات. هذه التجمعات والتراكمات غير الطبيعية تؤدي إلى تراجع وظائف المخ وعدم التواصل بين الخلايا، وبالتالي تؤدي إلى التلف والموت. مع ازدياد الخلايا الميتة ينكمش دماغ الشخص كما هو موضح في الصورة. هنا الدماغ الطبيعي والخلايا العصبية الطبيعية، هنا انكماش في السيربرال كورتكس، انكماش في الهيبوكامبس واللارجد فنتريكلز، وهنا الخلية العصبية ووجود التليف فيها. هذا مرض الألزهايمر، الباثولوجي لمرض الألزهايمر بسبب وجود بيتا أميلويد بروتين. أعراض الألزهايمر: فقدان الذاكرة، تغير في المزاج، اختلاط الزمان أو المكان، الانسحاب الاجتماعي، تغير في الرؤية، العدوانية، صعوبة في إكمال الأنشطة العادية، شكوك خاطئة، وضع المتعلقات في غير أماكنها، الكفاح لتوصيل طلب أو معلومة. كذلك المشاكل في النسيان، في التفكير، في تقلبات المزاج، صعوبة في التعرف على الأماكن المحيطة، الاكتئاب، الأوهام، صعوبة في اختيار الكلمات للنطق والكتابة، صعوبة في القيام بأمور مألوفة مثل ارتداء الملابس أو الاستحمام، تغيرات في نمط النوم. دور الغذاء في علاج الألزهايمر: ترتبط العديد من الأطعمة أو يؤثر تناول نظام غذائي غير صحي في تكوين البروتينات الضارة في الدماغ بيتا أميلويد، والتي تسبب الإجهاد التأكسدي والتهابات الدماغ التي تكمن وراء مرض الألزهايمر. كما أن السمنة وأمراض القلب والسكري، هذه الأمراض قد تزيد نسبة ظهور مرض الزهايمر، ويمكن التقليل من نسبة حدوث الزهايمر بطريقة غير مباشرة عن طريق اتباع حمية صحية لهذه الأمراض: قليلة الدهون، عالية الفواكه والخضار، قليلة السكر، تحسن الأمراض المزمنة، وبالتالي يتحسن مرض الألزهايمر عن طريق الغذاء. تناول مجموعة متنوعة من الأطعمة، وخاصة الفواكه والخضروات والحبوب الكاملة والبروتينات الخالية من الدهون ومنتجات الألبان قليلة الدسم، وتقليل استهلاك السكر والملح يؤدي أيضا في دور الغذاء في علاج الألزهايمر. يعتبر البرتقال والتوت والأسماك والخضروات الورقية من أفضل 3 أطعمة تحارب فقدان الذاكرة، والتي هي جزء من الألزهايمر، وكذلك الأطعمة التي تحتوي على فيتامين ه والأوميغا. سكر أبيض مع كورونا، أرز أبيض من الأطعمة التي تساعد فقدان الذاكرة. دور الرياضة في تحسين مرض الألزهايمر. يحافظ أولاً على حجم الدماغ وكفاءته للوقاية من الألزهايمر، يحسن الإدراك والذاكرة ويبطئ من التدهور العقلي لمرضى الألزهايمر، تحسين النوم وتوفير فرص للتفاعل الاجتماعي وتقليل الشعور بالعزلة. التمارين الرياضية تقلل مخاطر السقوط من خلال تحسين القوة والتوازن. الأنشطة الهوائية تعتبر أفضل أنشطة لمرضى الألزهايمر، مثل المشي السريع، تمارين الرياضة المائية، ركوب الدراجات، كذلك حل الكلمات المتقاطعة لتنشيط الذاكرة. التفاعل الاجتماعي. ما هو دور التفاعل الاجتماعي في مرض الألزهايمر؟
5 minutes دكتور.
الدماغ عبارة عن عضلة يجب أن تمرنها تماما مثل العضلات الأخرى في السامنة. يساعد التعامل مع أشخاص آخرين في الحفاظ على نشاط الدماغ والحفاظ على الذاكرة وتقويتها. التفاعل الاجتماعي يؤدي إلى الحفاظ على صحة الدماغ وربما يؤخر ظهور الألزهايمر. كما أن العزلة الاجتماعية تؤدي إلى 50% زيادة الإصابة بالخرف، تؤدي إلى أمراض القلب بنسبة 29%، تؤدي إلى الإصابة بالسكتة الدماغية بنسبة 32%. أثبت الأبحاث الحديثة أن أن الأرق يكون بيتا أميلويد في الدماغ الذي هو السبب الرئيسي وراء حدوث الألزهايمر وعدم التخلص منه. أما النوم لمدة 6 إلى 8 ساعات في اليوم يؤدي إلى التخلص من البروتين بيتا أميلويد، فيؤدي إلى تأخر ظهور الألزهايمر. مرض الألزهايمر. الأمراض النفسية. الضغط النفسي قد يؤدي إلى الأمراض النفسية مثل القلق والاكتئاب والخوف، بدورها تؤدي إلى عمليات الشيخوخة في المخ، والتي تسرع من التدهور العقلي والإدراكي المرتبط بالعمر، وقد تتطور وتسبب ظهور المرض الخرف والألزهايمر. العلاج. ضبط مستويات الكوليسترول في الدم يقلل من الإصابة بأعراض الألزهايمر. العلاج بتطوير نمط الحياة الصحي، ضبط مستويات الكوليسترول. التحكم في مستويات ضغط الدم يؤدي إلى ضرر وتلف في الأوعية الدموية، وبالتالي يؤدي إلى تقليل الأكسجين، مما يؤدي إلى حدوث خلل في التواصل بين الخلايا والعصبية بعضها لبعض، ويساعد على ظهور الألزهايمر. الحفاظ على النشاط الذهني من خلال التفاعل الاجتماعي. التغذية السليمة والاهتمام بتناول أطعمة متوازنة وصحية تحتوي على جميع العناصر والألياف والبروتينات والفيتامينات المهمة. الحرص على شرب مياه كثيرة. تجنب شرب المشروبات الغنية بالكافيين والألكحول. توفير النوم الجيد لفترة كافية في اليوم. توفير الرعاية الكاملة الصحية والطبية من الأسرة لحياة أفضل لمرضى الألزهايمر. مريض الألزهايمر يجب أن يشعر بالأمان والانتماء، ويجب أن يكون هناك أسرة داعمة له من خلال دعم حركتهم ومشاركتهم في مختلف الأنشطة، وتجنب الضوضاء، والاهتمام بأهمية التصميم الذكي والمريح للمنازل والحدائق لتوفير بيئة أسهل وأكثر أماناً. لا يوجد في الوقت الحالي دواء يمكن أن يعالج مرض الألزهايمر، ولكن يوجد أدوية بفعالية محدودة يمكن أن تؤخر تطور ظهور المرض بحوالي 6 أشهر إلى 2 فقط. resources. وشكرا لحسن استماعكم، جزاكم الله خير.
The last session will be a kind of heavy talk with Dr. Dina Al-Mnif. She's a consultant of family medicine and diabetology, faculty member in College of Medicine, King Saud University, Saudi Board of Family Medicine, Saudi Fellowship in Diabetology. Stage is yours, Doctor. Thank you very much.
السلام عليكم. صوت واضح؟ تمام. البوينتر. طيب السلام عليكم ورحمة الله وبركاته. Good afternoon everyone. I am really honored and pleased to be here with you today. Inshallah, my talk today will be about anti-inflammatory diet. كيف البوينتر بس؟ Okay. So this would be the outline of my presentation. Before going in depth into anti-inflammatory diet, let's go into the basics of the basics. Let's start with a brief introduction about inflammation, starting with its definition, its types, and its classifications. Okay, so starting with the definition of inflammation. So it's simply defined as a protective local response to cellular energy initiated by the body's immune system. So you could tell it is a part of the healing process. The inflammation types, it's classified into acute and chronic, depends on the duration of the inflammation. So, starting with the acute inflammation, so it's simply triggered by pathogen. So whatever's invasion by viruses, bacteria, or fungi, or by an injured tissue simply because due to burns, laceration, frostbite, chemical energy, you name it. The major cells involved are neutrophils, mononuclear cells, the primary inflammatory mediators, which are responsible of the cellular and vascular events, are vasoactive amines, prostaglandin, peptides such as histamine, bradykinin, and serotonin. So by its name, the onset starts rapidly. It starts immediately, and it lasts for a couple of days with an net outcome of resolution. But sometimes, in certain conditions, in certain scenarios, this acute inflammation persists into chronic low-grade inflammation. Okay, so acute inflammation simply characterizes by the vasodilation of the blood vessel and the increased permeability of the blood in the local response. So it gives you this characteristic features of swelling, pain, erythema, and heat, as you can see in the pictures. Okay. So as I mentioned earlier, acute inflammation could fail into resolution and could persist into acute low-grade inflammation. So what does chronic inflammation is? So the major cells involved are the mononuclear cells, fibroblasts. The primary inflammatory mediators are the cytokines, growth factors, active radical reactive oxygen species, hydrolytic enzyme. And by its name, the onset is delayed. It lasts for up to months, and it could last for several years. So the net outcome, the body will try to restore itself by fibrosis or angiogenesis, but sometimes it could lead into tissue destruction. Okay, so there are multiple diseases in the literature that were linked or associated into chronic inflammation, such as cancer, arthritis, neurological symptoms, neurological diseases, skin diseases, gastrointestinal diseases, diabetes, metabolic syndrome, and the list is limitless. Okay, so the clinical presentation, you could tell that the sign and symptoms varies depending on the condition and the site of injury. So you could have body pain, joint pain, mood disorder, depression, cognitive problems, gastrointestinal complications, fever, depending on the condition. As I mentioned earlier, immune system initiates inflammation. We all know that the immune system is not only located in a single organ, it is scattered throughout the cells and tissues all over the body. But do you know that 70% of the body immune system is located in the gastrointestinal tract? So it is considered as a primary physical barrier, as the first line defense. So it is like considered as the gate to the inside of our body. So it makes sense that whatever been ingested and got into our gastrointestinal tract might affect the health and the digestion of the gastrointestinal tract as well. Hence, it might activate the immune system. Hence, it might increase the capability or the susceptibility into curing or preventing chronic diseases. Okay, so an interesting point to point to, many experimental studies have shown that components of food and beverages may have an anti-inflammatory effect. Dietary factors influence systemic low-grade chronic inflammation via various mechanisms. Diet plays a key role in inflammation. So, what does the evidence say? What does the evidence say about diet and inflammation? Where is this in terms of research and evidence? Well, diet and inflammation has been a subject in significant research. There were multiple, and so many studies that has been published in the literature that were revolving around diet and inflammation. Okay, so in summary, what does the literature say? So it described the anti-inflammatory way of eating. Just to keep in mind before describing it, that there is no one-size-fits-all approach in an anti-inflammatory way of eating. So it can be carried out differently by different individuals as long as it is centered on eating whole and processed foods high in vegetables, fruits, and fibers. It is not a diet. It is a lifestyle change. People do tend to lose weight in it, but it is not intended as a weight loss plan. People who are eating in an anti-inflammatory way are focusing on real whole food that exists in nature and have not been chemically altered. So its main goal is to support the body by providing the essential main nutrients, provide steady energy by stabilizing blood glucose, and the people who are following an anti-inflammatory way of eating, they are eating to thrive, not survive. Okay, so in the upcoming couple of slides, I have outlined and summarized the components of an anti-inflammatory diet. Let's start with the macronutrients, starting with the fats. In summary, they have reported and recommended that the consumption of monosaturated fat, polyunsaturated fat, do have anti-inflammatory properties, such as olive oil, fish oil, alongside with cardiovascular benefit. Fruits and vegetables. I don't think there is any healthy lifestyle way of eating that does not include fruits or vegetables. So they do contain a high amount of anti-inflammatory molecule like antioxidant, flavonoid, polyphenol, which are very powerful anti-cancerous, antioxidant, and anti-inflammatory molecules. So they counteract the free radicals produced by inflammation, which directly cause cell damage. When it comes to protein, what was recommended is plant-based. So it could be an alternative to animal source of protein, such as legumes, tofus. They do also have, alongside with the anti-inflammatory effect, a beneficial effect in both lipid and endothelial function. High intake of dietary soluble and insoluble fiber do have an anti-inflammatory effect with a recommended level of 30 grams or more. This is my favorite slide. So, cocoa. Cocoa has been proven that it has an anti-inflammatory effect along with improvement in lipid profile and an endothelial function as well. Nuts are considered to be an important source for fiber, minerals, monosaturated fat. They're shown to be associated with the reduced rate of coronary artery disease, metabolic syndrome, and mortality. Okay, so when it comes to carbs, low glycemic index carbs, which were recommended. What does that mean? So it is a score that we score any carb-containing food in which we describe how quickly does this carb-containing food increase the blood glucose. What we want is, we don't want a high increase in the first duration because this would cause a lot of blood glucose swings and this would be harmful for the body. So what we aim for, a slower destruction of glucose. So a slower destruction would cause a better absorption of the nutrients. So when it comes to carbs, a low glycemic index defined by an index of 55 and less, which is found in oats, barley, non-starchy vegetables, sweet potato, they do reduce the inflammation and reduce fat and have a negative metabolic effect in the body. Okay, when it comes to spices, turmeric and curcumin, اللي هو الكركم. So curcumin is an active component found in turmeric. Turmeric, interestingly, found that it can suppress the COX-2 expression. so it could give us an analgesic effect. So be creative. It could be used in cases such as osteoarthritis, whoever patient has joint pain. Curcumin, on the other hand, found in the literature that it could help in the maintenance of ulcerative colitis remission and improvement of oral lichen planus. This is my second favorite slide. Black tea and green tea, by carrying components like polyphenol, showed reduction in CRP, which is an inflammatory marker, in the human clinical studies. Sesame as well showed an anti-inflammatory markers, and alongside with it, it might have a potential hypotensive activity. Okay, so done with the macronutrients. Macronutrients, on the other hand, the deficiency of magnesium, vitamin D, vitamin E, selenium, and zinc found that it was evident that with the deficiency of these micronutrients are associated with chronic inflammatory conditions. So they do carry an antioxidant and an anti-inflammatory function. Okay, so after reviewing the components of an anti-inflammatory diet, I need to stress on the pro-inflammatory diet that have the capability of increasing the inflammation in our body. Okay, so sweetened beverages, refined carbohydrates, fried food, processed high fat, red meat, saturated fat, excess alcohol, high glycemic index carbs, trans fat, and hydrogenated oil all could have a pro-inflammatory effect in the body. Okay, so after reviewing the components of an anti-inflammatory diet and the pro-inflammatory diet, here's a question. Do you think that our way of eating could affect the digestion and could affect the overall health of our bodies? As a matter of fact, it does. Unfortunately, we come at a time and at a place in which, with the era of technology and the era of digitalization and the huge transformation we're going through, multitasking while we're eating has become the new normal. Just take a moment and realize the majority of the meals that you have eaten in the past couple of weeks. One meal while I'm rushing through my next meeting, the other one while I'm scrolling down the social media, while I'm texting, while the TV is on. So all of this would cause a lesser satisfaction experience, and it will cause a lesser awareness of the components of food with an unconscious overeating. So here comes the magical role of mindful eating. So what's mindful eating? It is a type of a mindfulness exercise. It's an approach of eating in which it focuses on being fully present while you're eating. It increases the awareness of your thoughts, your feelings, your physical senses while you're eating and afterwards. So, how to practice it? Okay. I'll tell you the steps just in summary, so you could practice it in the upcoming, maybe tonight's dinner or tomorrow if you can. So, when it's the time of your meal, I just want you to simply sit down. Do not walk, do not run, avoid all the distractions, stop working, put the computer and your phone aside, stop the TV, just relax, sit, be in the moment, and avoid all the distractions. Number 2.
5 minutes, Dr. Dina.
Take a few breaths to bring you to the present. Just relax and loosen up a bit. Number 3, you know that eating could be a magical experience. It's more than just taste. It's more than just eating food and just satisfy your hunger. Activate your senses. When it's time of your upcoming meal, just enjoy the power of sight and enjoy the color of your food. Enjoy the aroma of the smell of the food. Enjoy the sound of your food while you're eating it. Eat slowly, chew well. Take a pause between each bite, and this would help you in a better digestion. You know, just remember that the digestion starts in the saliva. The saliva contains an active ingredients that could help in the matter of digestion. Honor the food. Acknowledge where it came from. How was it prepared? And last, eat only when you're hungry. Before you eat, just ask yourself a question. Why am I eating? Is it out of boredom? Is it out of fun? Is it because the meal is simply in front of me? And while you're eating, investigate your hunger. Am I full now or I'm ready to stop? So the benefits, as we went through it, better digestion, increased awareness, enjoyable experience, healthier relationship with their food, healthier option, and risk reduction, hence lesser chronic diseases and inflammation. But for the sake of time, I'll just skip these couple of 2 slides. And remember that, remember, to control chronic inflammation, it needs more than diet. You need to tailor and to tackle each pillar of lifestyle medicine. So diet, physical inactivity, obesity, smoking, sleep disorder, and stress needs to be controlled alongside with the diet. So the general recommendation is to increase the uptake of anti-inflammatory food, as we mentioned, exercise regularly, achieve and maintain a healthy weight, avoid smoking, get enough quality of sleep, manage stress with healthy tools. So I came to the end of my presentation with the take-home messages. Taking a more proactive approach by choosing a healthy eating choices can decrease inflammation, hence chronic diseases. Mindful eating offers a scientifically proven, effective way to help regulate the stress response for optimal digestive function, which is the cornerstone of wellness and survival. And last, promote better lifestyle changes and learn to use food as medicine as a way for prevention and treatment. Those are my references, and thank you very much.
Thank you very much, Dr. Dina. It's very interesting and important talk. Now we will be with an important moment, which is the questions for all our speakers for this session. Any questions? Otherwise, I will take the benefit of being a moderator and start with the first question. Actually, I would like to ask Dr. Banan Al-Malki. Somebody will provide the microphone. Dr. Banan, you give a very important talk about nutrition and cancer. Is there any ongoing or specific information regarding addressing this issue in Saudi Arabia, national study?
Assalamu alaikum. Thank you for the question. As we discussed with Dr. Khalid from Oman, we have the data for the screening cancer for the screened patient from breast cancer and colorectal cancer, and there's تطلعات إنه إحنا نبدأ بالداتا اللي موجودة عندنا with the diagnosed patient initiative for starting treatment with the diet, with ongoing the chemotherapy and the radiation. Nowadays, I don't know صراحة إذا فيه موجود ولا لأ.
Is the data that you have based on Riyadh, Hail, in a specific region, or it's general data?
I'm responsible on the data for the Eastern Health Cluster, and we can get the data from Saudi Arabia, from the national program, if we need it. Yani.
Thank you very much, Doctor. Next question, please. Otherwise, I will keep asking. Any questions? Any questions? تفضلي دكتورة.
Thank you so much for these very informative and practical talks, actually. And mashallah, we enjoyed really these talks. My question regarding the ketogenic diet with Alzheimer, there is any evidence regarding that? I'm not remember doctor talking about Alzheimer. She was go through a lot of things regarding Alzheimer with food.
but I don't know if there is, because there is some studies talk about ketogenic diet in association with Alzheimer. This is one thing. And the other question for Dr. Adina regarding the inflammatory food. There is some studies talk about the gluten and lactose, and they categorize gluten and lactose as inflammatory type of food, but I'm not sure if this is also evidence-based or just trials or what.
Apologize, your first question for which speaker?
Ketogenic diet and Alzheimer. There was a talk about Alzheimer and food.
Alzheimer and food by Dr. Amal.
Yeah.
Yeah.
الألزهايمر and food عن طريق تناول الأطعمة. يعني أنا ما خصصت إنه كيتوجينيك دايت أو شيء. اللي موجود إنه low fat أو low protein, high vegetable and high fruit, decrease the salt and sugar. That the diet improve the health of the diet for patients of Alzheimer. Okay, and a lot of people who have Alzheimer have chronic disease like diabetes or hypertension or cardiac vascular disease, and if improve the diet through this make a management of diet for this disease, it will improve the Alzheimer by indirect way.
I think Dr. Dina. Second question.
طيب. Thank you very much for your question, Dr. Nasreen. Well, depending on gluten and lactose, just to confirm, it was gluten and lactose, Dr. Nasreen?
Yes. Yeah.
Okay. So in the literature, it was mentioned that gluten and lactose could cause some sort of inflammation, but that depends on the immunity and the sensitivity of the person, him or herself. So there are some patients who could develop and maybe okay. So they might develop more reaction to such molecules as they are being or labeled are more sensitive to these molecules. So in general, I cannot recommend to cut off all gluten and lactose. That would be depending on the patient himself by being more vulnerable or sensitive to these molecules.
Thank you very much, Dr. Dina. Second question.
Assalamu alaikum. Thank you, Dr. Dina, for your informative lecture. I have two questions for you. The first one, how can you assess the chronic inflammation clinically? Like, is it CRP, high sensitivity CRP, interleukin 6, or what is your marker for assessment? And the second question is, if there is a dose for the anti-inflammatory diets that you mentioned, like a dose prescription for this food? Thank you.
Okay, thank you very much for your questions. Okay, regarding the first question, Afwan, the first question was how to assess clinically. Okay, so in terms of clinical assessment or practice, there are no any routine tests or investigations that could be done. As I mentioned before, clinical presentation in terms of signs and symptoms are more likely enough to diagnose or to label a patient with chronic inflammation. However, in research, they did, while they have been investigating the evidence of diet and inflammation, they have used some couple of investigations such as CRP, ESR, as you mentioned, as a sort of inflammatory markers, and CRP and ESR, WBC on the long side. However, as a routine, it was not been recommended. The signs and symptoms or the clinical presentation in general are enough. Your second question was if there's any maybe specific portion for each component. Well, remember, it is not a diet. It is a lifestyle way of eating. So as in term of portions, عفوا, it was not labeled or recommended. However, only go with the recommended daily allowance of each macronutrient. And remember, it is not a magical pill, so it will not work over time. So it might take a couple of days, weeks, and it might take months. So just focus on the components, limit down or cut down the pro-inflammatory whey or food components, and you'll be good to go, inshallah.
Thank you very much, Dr. Dina. So we will not take long. I know all of you are exhausted. This is the end of the day, so there is no further questions. Thank you very much for the audience and the speakers. We will move on for the last activity in our session. We'll be distributing the appreciation certificate by Dr. Mishal Al-Nais and Dr. Saleh Al-Rajhi. Thank you very much.
Thank you very much for all speakers, and thank you for all moderators. We'll start distributing your certificate. Professor Abdulaziz Al-Uthman. Dr. Sharif Gochi. Sorry to announce your name. No. Dr. Iba Filimban. دكتور أسماء الشمري. دكتور أنس العنيزان. دكتور نجاة التوم. دكتور بنان المالكي. دكتور سامية لطيف. دكتور عواطف الرشيدي. دكتور ندى البلوي. دكتور البندري بن عمار. دكتور أمل باوزير. دكتور دينا المنيف. Thank you very much. We come to the end of our sessions for today. See you inshallah tomorrow for more sessions. And today, Dr. Saleh, we will announce for the gala dinner in the الحياة resource. Salam, yes. And if you want also to have the visit to Salam Garden, and then for some guests to الحياة resource. Thank you very much, and see you tomorrow in the scientific program. Thank you.
Recording stopped.